Good morning. Welcome to the first hearing of the Committee's inquiry into Budget Estimates 2023-2024. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name's Dr. Amanda Conn and I'm Chair of the Committee. I welcome Minister Park and accompanying officials to this hearing.
Thank you.
Today, the Committee will examine the proposed expenditure for the portfolios of Health, Regional Health, the Illawarra and the South Coast. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome and thank you for making the time to give evidence.
Thank you.
All witnesses will be sworn prior to giving evidence. Minister Park, I remind you that you do not need to be sworn as you have already sworn an oath to your office as a Member of Parliament. For all other witnesses, could you please state your name and position title and swear either an oath or affirmation? And please begin with the first witness to my left.
Good morning, my name is Rebecca Walker. I'm the Chief Executive of Health Infrastructure. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning, my name is Deborah Wilcox, Deputy Secretary for Health Systems Strategy and Patient Experience. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning, my name is Luke Sloan. I'm Deputy Secretary for Regional Health. I solemnly and sincerely, truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning. Philip Gregory Minns. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Kerry Chan, DepSec Population and Public Health and Chief Health Officer. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Good morning, my name's Susan Pearce. I'm the Secretary of New South Wales Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Morning, Matthew Daly's my name. I'm Deputy Secretary for Systems Sustainability and Performance, and I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Rebecca Fox, Secretary of the Department of Regional New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Interesting. Do we have additional witnesses who aren't at the table?
Good morning, my name is Stephen Carr. I'm the Acting Deputy Secretary, Financial Services and Asset Management and Acting CFO. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. Good morning. My name is Dominic Morgan. I'm Chief Executive of New South Wales Ambulance. And today I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Today's hearing will be conducted from 9:15am to 5:30pm. We are joined by the Minister for the morning session from 9:15 to 1pm with a 15-minute break at 11am. In the afternoon, we'll hear from departmental witnesses from 2pm to 5:30pm with a 15-minute break at 3:30pm. During these sessions, there'll be questions from the opposition and crossbench members only, and then 15 minutes allocated for government questions at 10:45, 12:45 and 5:15pm. And we'll begin with questions from the opposition.
Thank you very much, Chair. Thank you and welcome, Minister. Great to see you and your exemplary team here today. Minister, in May 2020, you said in a post on Facebook, and I quote, that high quality and accessible palliative care and end-of-life care should be a priority for any government, end quote. why would you lie to the people of New South Wales and cut palliative care funding?
Well, let's be very clear, and I acknowledge your role as a former regional health minister and acknowledge the committee, many of which have a long and detailed history with healthcare right across New South Wales. We're not making a cut. In fact, in terms of palliative care, we will be spending $1.7 billion over 4 years. That will be 6.8% higher in 2023-24 compared to 2022-23. We will be increasing it again in 2024-2025 by 8%. We're putting $93 million into capital investment for palliative care. What we have done is make sure that we have a budget that is sustainable. Now, this committee is examining the budget. I brought the New South Wales budget papers with me today.
Oh, Minister, we'll have plenty of time to look through and look at those budget papers. I'll just move on in the essence of time, because there are significant cuts to palliative care, which we'll be outlining during this session. But today, I ask you this, Minister, will you apologise to the people of New South Wales for cutting palliative care? To those people that will die in pain because of the New South Wales Labor government's cuts to palliative care?
No, what I'll be saying to the people of New South Wales is that you have a government who's committed to delivering high quality, first class palliative care in regional and rural New South Wales and in our metropolitan cities.
Did you propose the cuts to palliative care, Minister?
I've got an absolute laser-like focus.
Was it you,
on
Minister,
making
that proposed the cuts to palliative care?
Point of
palliative
order.
care
Point of order.
services-
Sorry, I'll hear the point of order, please.
Let's get this out of the way early. Witnesses are to be afforded courtesy at all times. So that includes allowing the Minister the opportunity to answer the question.
To the point of
Thanks,
order,
Chair.
Chair. We are allowed to pivot with the questions and to actually go and move on to a new question as well. That is within the standing orders.
Further to the point of order, under procedural fairness resolution adopted by the House, number 19, witnesses will be treated with courtesy at all times. And as we all know, the Minister is here by invitation.
I am treating the Minister with great
and
courtesy.
look, you'll get opportunity
to the point of
respond.
order.
You'll get opportunity.
Don't waste my time.
Sorry, to the point of order, obviously you do have the right to pivot the question. I would ask you not to speak over the Minister.
Minister, I'll put my question again then. Did you propose the cuts to palliative care savings as a measure in this budget? And if you did not propose the cuts, who did, Minister? Was it the Premier?
Well, let's be clear. We're not cutting palliative care.
Well, you
We
are
are,
cutting
over the next
palliative
4
care.
years, investing $1.7 billion. We're spending more on palliative care than we ever have before. I'm
But that's
determined to
simply
make
not
sure
correct,
that we
Minister.
have. I'm
That
determined
is
to make
simply
sure
not
that we have a
correct.
palliative care system for people living in rural, regional, and metropolitan areas that is first class.
Minister Parr,
You were in the
the
previous
budget was
government.
going to be
You were in the
$1.85
previous
billion.
government.
It's a $150 million cut. It is a $150 million cut.
So over the 2023-2024 budget, it'll include, over the forward estimates, $1.7 billion, money that we have never seen invested in palliative care before, something that is very near and dear to my heart. I know it is near and dear to many people's heart on this committee as well.
Thank you,
It's
Minister.
been an issue that
Minister,
people have been
I'm
passionate
glad
about.
it's dear to your heart. It's actually really dear to mine as well. Spent a great deal of my career in it, and I know it very well. And I know that there is a cut. We all know there is a cut. And Minister, in 2021, you visited Bulli Hospital and you met with palliative care workers because, as you said, it does mean a lot to you. And I genuinely acknowledge that. And that's why I'm so shocked with the cuts. You said, and I quote, that listening to palliative care nurses and health workers in our community, I have learnt how important this part of our health system really is, unquote. Minister, did you tell those workers who you used in your media stunt that if you won government, the first thing you would do is you would look at this funding?
Well, let's be clear about a couple of things. We are spending and allocating $1.7 billion over 4 years
Which is a
in palliative
$150
care
million
funding.
cut.
Okay, so let's everyone in the committee, those of us who spend a lot of time focusing on budgets and the preparation of budgets, also need to
Of which you have
understand the
cut
way in
in
which...
palliative
Point of order,
fund-
Chair.
Point of order.
The Honourable Member is now directly flouting your previous ruling about speaking over the top of the Minister as he is trying to answer the question.
Thank
I'll
you.
ask you to call it to order.
To the Honourable Member, I'd ask that you can ask for elucidation or follow-up questions, but please to not
Sure.
just interject to speak over the
Thank
Minister.
you, Chair.
The member talked
Minister,
about.
do you deny it is a
I haven't finished my
150
question,
million
Chair.
cut?
I haven't finished my answer, Chair.
Minister, do you deny it's a $150 million cut to palliative care? It's a yes or no?
So the honourable member talked about.
Minister, do you deny
Point of order.
it's a yes or no
The Minister
answer?
is trying
Yeah,
to
thank you.
answer
To
the
the point
question.
of order, you didn't let him actually start
not-
answering that question.
Thank you, Chair. We are investing $1.7 billion over 4 years in palliative care. We are providing more than 570 full-time equivalent staff over 2026-2027 period. We are focusing on delivering both infrastructure, $93 million across regional and rural,
Thank you,
Western
Minister. I do
Sydney,
need to move
as
on
well as
because that was
making
not
sure
my
that we are
question,
investing
Minister.
in the human capital.
Minister, that was not my question. I am presuming now that you agree that you have cut $150 million out of palliative care.
Point of order.
No.
Do you deny that
Sorry, I don't
1.85
agree
is
with
less
that.
than
Point of order.
Sorry,
1.7? It's
Just-
simple
Mrs Taylor, I
maths,
need to hear the
Minister.
point of order, please.
Just for the point of the committee's reference, I don't agree with that. What I do agree is we're investing record amounts in palliative care. It is something that is very important to the communities that in this place we're fortunate to represent. I understand that. What I think the Budget Committee should also understand is something that was made evident to me in the first week when I took over, something that unfortunately the previous government didn't allude to, and that is that 1,112 nurses were going to lose their
Minister
jobs.
Park, we'll
on
we'll get on
July-
to that
1
later,
July
but now you really
2024.
are strange. So
So
I will pose
that
this
is a
question
significant
again,
challenge,
Minister.
and we're here.
The Minister's now over-talking me, Chair, so it needs to go.
I would ask you to get to your question.
Yeah, so do you deny that 1.85 is less, 1.7 is a cut of $150 million?
I know what I'm saying to the committee is that we are investing a record amount in palliative
Okay,
care, the
all right,
likes
Minister,
that we haven't
let's
seen
go.
before.
We'll just keep going here and we'll just outline it all. So, Minister, it's been revealed to me that you've cut funding for 2 palliative care staff at Bulli Hospital. Will you apologise to the people of Kira for those cuts?
Well, what
Will
I'll
you
sa-
apologise
well-
to them?
Well, what I'll say to the people of Kira, I'm not aware of that, so let me be very clear about
Would you like
the
to take
specifics.
that on notice, Minister?
Well,
Would you like to take on notice that
sure.
there've been 2 palliative? Okay, thank you
I'm-
very
I'm
much.
happy to, but-
Thank you for taking that on notice. Minister, the same Facebook post you said, and I quote, "I'll always do my very best to ensure that you have the resources that you need to provide the care that means so much to so many." Will you take this opportunity here today to apologise for lying to the public about cutting $150 million out of palliative care in New South Wales?
Well, your inference is wrong. We're investing a record amount in this part of the health system, both in terms of staffing, funding and infrastructure over the next 4 years. Were there challenges that the government that you were a member of did not allude to the
Yes,
community?
but you're the government now and you make the
relation
choices
to-
and
in
you've made
relation
the
Point of
choices
order.
to cut
Yeah.
palliative
Point of
care by
order. Point of order,
Mrs
Chair.
Taylor, order. To the point of order.
The Minister is again trying to answer the question, repeatedly talking over the top of him as he is attempting to answer the question is utterly disorderly and not courteous.
Thank you. I asked the member if you're interrupting for that to be for a follow-up question.
Yeah, thanks. Okay, so Minister, I note that you have cut $150 million in funding for palliative care in New South Wales. Have you spoken to Daniel Mookie about this cut, and is the money now going to fund the tax break for Star City Casino? Is that where the $150 million for palliative care is going? Or is it going to Joe Halen to pay Josh Murray? Where is that $150 million going that you cut, Minister?
Well, you're wrong on all 3 accounts. So
well, not wrong.
that was
You've cut
successful.
it by $150 million.
We're investing a record amount into palliative care, an amount that is going directly
Minister,
into
that is
both
simple.
services
You
and
cannot
order.
mislead the committee. You cannot
Order.
mislead the committee.
We're directly.
I have a point of order, please.
Sorry.
Passions are obviously high on this issue, and they should be. But the procedural fairness resolution requires the minister to be afforded some time to answer the question that's been asked of him, and I've just asked the member to afford him that time.
Thank
And
you.
to
I'll
the
uphold that point of order.
The minister cannot mislead and should not mislead the committee. So it is my job to absolutely prosecute that, and it is quite frankly the job to let this flow. If there's nothing to hide, then the minister will keep asking the questions. But when there is, the defence being run by the opposition
really, when it's quite obvious what's going on here, is not helpful either.
Further to the point of order, I think the Minister needs more than 10 seconds to answer the question that's been asked of him.
There was more than 10 seconds.
I appreciate
You're running
the
defence.
passion of the honourable member on this topic. I would ask if we can let the Minister at least get through a sentence of his answer before interjecting, please.
So we are investing 1.7. That's a record amount into palliative care from any government, both present or past. It'll be 6.8% higher, as I outlined anyway, in 2023-24. And again, it'll increase by around 8% in the following year. So this is a significant investment in palliative care. Budgets by all governments are always challenging, but I make no apology for making sure that we have record investment in palliative
Minister,
care, both in terms of the
Thank you,
human
Minister.
capital
I
and
have
the
limited
infrastructure.
time, so I will move on now. And the record amount was the record amount that was announced, but you've cut that by $150 million. And dying people and their families in New South Wales have a right to know the truth, because people will die in pain now due to these cuts in palliative care funding. And I've worked with you a long time, and I am really staggered. And that's why I think that it's either the Premier or it's Mr Mookie. Someone hasn't fought hard in ERC, but something has happened here. But Minister, I understand that dozens of positions right across the state that were earmarked for nursing home services and visits have now been cancelled. Could you please tell us how many of those have been cancelled?
I'm
in
not
terms
aware
of
of that.
clinical
but-
nurse educators of palliative care. Would you like to take that on notice?
Happy to take it on notice.
Minister, do you think it's not important that people in nursing homes be allowed the dignity of proper palliative care?
Well, I think everyone, I'd like to think in this parliament, would agree that palliative care and the way it's delivered in nursing home, aged care homes, whether it's delivered in the home or our hospitals, has to be one of focused around dignity and care of the patient, as well as care for the family and those supporting the patient. I hope I
Thank
can
you,
speak
Minister.
on behalf of the Parliament
agree.
that would be a focus.
I agree. But it is becoming evident that I don't know if you're entirely sure about all of these cuts that have been made, so I appreciate you taking that on notice. Minister, on the 4th of August you said, and I quote, "The New South Wales Government is committed to ensuring people with life-limiting illness across Western Sydney receive the highest quality of end-of-life care to provide peace of mind when these patients need it most." A very genuine comment. Minister, in the 22-23 budget, the Coalition funded a new palliative care unit for Westmead over 4 years, and the funding required to run this facility has been cancelled due to your cuts. Why are you building a new facility and not funding its operations? And will you today, because of that, apologise to the people of Western Sydney for your cruel cuts?
Well, I think the honourable member needs to be a little bit careful, because her statements this morning, many of which have not been factual, and this is another one. So I always find it's important, having spent 12 years in opposition, to work very diligently in preparation for estimates. It is important, and there wouldn't be too much reference or needing to read these documents called the budget papers that would give you an understanding that you're wrong, because we are actually delivering Westmead palliative care. It's a new 15-bed acute supportive and palliative care unit at Westmead. It's expected to open in the next few years, around 2026 at this stage. We're in the master planning stage for that facility. We'll be undertaken in partnership with Western Sydney Local Health District. I've met with many members out there and a number of elected members in this place, including people like Hugh McDermott and Julia Finn, who have been very, very good advocates, Donna Davis and others, on all sides of the fence, to be honest.
Thank
this
you,
is
Minister.
This is an important facility
Yeah, I
for the
agree it's
people
an
of Western Sydney.
important facility. So which part is not factual about the cuts? Which part? Which part is not factual? Please tell us where the operational funding is for the palliative care unit at Westmead in the budget.
Well, it's in the budget. We'll be delivering.
Where is it?
We'll be delivering
Where is
Westmead by
it?
2026.
Where is it? You just said...
Well, you're the one who said it's not there.
Well, that's right. So where is
Well,
it?
then,
And you said it is. Where is it?
Well, we have a difference of opinion.
Well, no, Mr. Park, this is ridiculous.
Well,
Where is your fund? Where is it?
It's not ridiculous because you're the one making
Yes, but
incorrect
where,
statements.
Where is it in the budget about your funding for that?
We are delivering for Westmead an acute 15-bed supportive and palliative care unit. We are going to have that up and running by 2026. That is
Mr.
our
Park,
commitment. That's
Minister
what we'll
Park, was
continue
there
to
a
do.
letter that was sent to Westmead Local Health District on Friday that clearly did not show that forward funding?
What was that, sorry?
Was there a letter sent to Westmead Local Health District showing that that forward funding was not there? Yes or no?
Sorry, I'm not aware of it, but
Would you like to take that on notice?
yeah, I will. But
Yeah.
I mean,
Okay, so
I'm the
please,
minister.
you know,
and
Minister
I'm the
Park
minister,
res-
and we're delivering something in Westmead.
Absolutely,
palliative care.
Minister Park, but as you just said to me, you know, when you're in government, it's actually about the infrastructure and the staffing. So let's
that's
move
ironic
on to
talk-
that,
well, that's
Minister.
ironic
But
because
that was
you-
that is
You
unbelievable.
proceeded to cut 1,112 nurses from 1 July next
Oh,
year.
Minister Park, let's address that
I've-
right
I've-
now.
well,
Let's address that. Those new nurses were nurses that came in
didn't know it was Dixon
with the
Park.
government, and they would have been in the budget. I mean, who in their right mind? I mean, this whole thing that you're pushing about 1,200 nurses, it's just ridiculous. Not even the media believe you. So let's
Point of
simply move
order.
on with that.
I've got a point of order, please.
It's 1,112. It's not 1,200. It's 1,112. I've got a breakdown by LHD if people would like it to.
Minister Park,
me to take
I'm
that
asking
through.
the questions here.
They
You're
were
not
due
providing
to
the statement, so
expire.
I'd
Sorry,
like to
point
move
of
on,
order,
please.
Chair.
Order, please. I'll hear the point of order.
If we could just ensure that the questions weren't argumentative and didn't contain argument. There was a question there, but it was prefaced with a lot of argument in the lead up to it.
That's okay. Let's move on then. Minister, is it true that since you refused a $3 million coalition election commitment for palliative care in Orange, that a private organisation is considering how it can operate a palliative care facility? Are you privatising palliative care in Orange?
I've got some information about Orange because it's something that the local MP, Mr Donato, has talked to me and our team about. Western New South Wales Local Health District provides specialist palliative care. I'm sure the honourable member will know that. In 2021, Orange Hospital established 2 designated palliative care beds that no doubt the honourable member was a part of. That was a part of your specialist medical oncology, haematology and palliative care services. Under the program, 3 additional beds are planned for Orange Hospital. Construction of the upgrade is anticipated to start, we hope, next year. And there's a group called, I think, Push for Palliative
That's right,
out in that region who have been advocating to myself, no doubt the local member and others around this. So that's where Orange is up to.
So you didn't cut the $3 million, or you did, Minister? I appreciate everything you've said about Orange and the wonderful work that they do there, but did you or did you not cut the $3 million?
No, we're delivering on top of what you...
Minister, did you or did you not cut the $3 million? It's
No.
fine if it's no, but I just need the truth.
No, we are delivering 3 additional
So
beds.
do you want to take
for
that
Orange.
on notice, Minister?
Point of order. Point of order.
I'll hear the
I would
point of
take
order,
something on
please.
notice when I'm finishing it.
The minister is clearly trying to answer the question. Continuing to talk over the top of
Okay,
him
I'll move on,
is in
Chair, thank
flouting your previous ruling.
Yeah,
and
thank you. I'll
completely
repeat my previous
discourteous.
ruling. The member is able to interject. Please
I'll
at least
move
give
on.
the minister a sentence first.
Minister, on the 11th of October, the Honourable Greg Donnelly said to the House, I report to the House the enormous disappointment and disbelief regarding the 2023-2024 state budget cut of $150 million from the $743 million funding boost announced last year. Are you saying that your own member is wrong?
Well, let me tell you about palliative care, but let me firstly acknowledge...
Are you saying that your own member is wrong? It's a simple yes or
I'm
no
loath to
question.
take another point of order.
Well, don't.
Chair,
Well,
Chair,
stop
Let him answer the
interjecting.
question.
Order, please.
Let your minister
Order,
do his job.
please.
Interjecting.
Chair, could I have 6 or 7 seconds? Just
The
to
minister
start?
has
Is
the
that
call.
all right? Just want to acknowledge I've been in this place for 13 years, and the Honourable Greg Donnelly has been a tremendous advocate for palliative care
He has.
services across that time, and I'm sure that preceded that time. We are investing a record amount in palliative care. People who care a lot about passionate subjects, many of which are on this committee today, should and would, and no doubt like government to continue to do more and do
Minister,
better. I
do
think that's
you agree
that's
with
always
your colleague or not?
what I'm saying is to the committee, and I'll say it one more time just so everyone is clear, we are investing $1.6 billion into palliative care over the next 4 years.
Okay.
That is a record level of expenditure.
So is Greg Donnelly
and
wrong?
we will continue,
The opposition's
we will
time's
continue
expired.
to invest in palliative care for people
Greg
both
Donnelly
in the
is wrong.
regions, rural, remote and metropolitan areas.
Greg Donnelly is wrong.
Thank you. The opposition's time has expired. I have some questions about the implementation of the Min's Labor government's promises regarding safe staffing levels in public hospitals, particularly for nurses. Firstly, what's the expected timeline for the work currently being undertaken by the Safe Staffing Task Force for emergency departments, intensive care units and wards currently using the nurse hours per patient day system?
Yeah, thanks for the question. I've been meeting with the nurses and midwives probably over the last 3 months, virtually every week. We have not only do we have a task force underway, but we are also engaging deeply with them around this. We have entered a memorandum of understanding. Securing the 1,100 nurses that weren't funded was critical to this rollout, on top of the 1,200 that we had committed to. I'm confident that, I don't want to put a direct time on it right now. I'm confident that we are coming to the pointy end of when we can start to see that rollout. We will start in our emergency departments, but we will probably include other wards as well, general wards where we're moving to a 1-to-4 system. The discussion that I had, not that I want to talk about private discussions, so I'm wary, but 2 days ago with the Nurses and Midwives Association, we're at the really pointy end of just clarifying a few things around how it will work in smaller hospitals, and just clarifying a few things about how it would work in terms of where we would commence this and what is the best way to roll this out. I don't have an exact time on it. The Nurses and Midwives Association have been very, very good in terms of understanding that this is reform the likes we haven't seen in 15 years. We are completely changing the way we staff hospitals. I just want to say to the committee, and I've said this both publicly and privately, but I just want to be really upfront about this. We're going to have some challenges along the way with this. We're going to have some bumps along the way. There's no two ways about that. But I'm confident with the team that we have both at the Ministry, LHDs and the support of the nurses and midwives, that we will have this starting to roll out very, very soon. I don't want to put a time on it yet. I'm happy to come back to the committee or to you directly and say once we have a specific date locked in. But we have been literally working on this on a weekly basis and sometimes multiple times a week for the last 5 or 6 months. It's challenging, there's no two ways about it, because it's not just the staffing, but it's also the back office in terms of making sure that shifts are properly resourced, etc. So this is a big change, but I know it's something that you're personally very focused on, and so should the committee, and I think the people of New South Wales should be as well. It's an important reform.
Thank you. I have more questions about this, and firstly just wanted to commend that it is refreshing to have a health minister who has made a commitment to work on safe staffing in our public hospitals. Has the government commenced its review of the birth rate plus staffing model for maternity units?
Yeah, I think we have. I might refer, is it Deb or Phil? Or sorry, yeah. Just so I don't want to. It's an important program, one that the association has talked to me about. Michael Waits is obviously passionate about this part of it, so I might just double check with Mr. Minns if that's okay.
Chair, that's my understanding as well. There's at least been 1, possibly 2 meetings, but it is fair to say that most of the endeavour and effort has gone into trying to plan implementation of safe staffing in other contexts, but it is a parallel process that will be resourced and will be well underway by next year when we're implementing safe staffing.
Thank you. Minister, in the review of Birth Rate Plus, can you make a commitment that babies will be counted as patients in the workload for midwives?
Yeah, well, certainly. I probably won't say it right here now about a commitment. I want to get this safe staffing reform rolled out in the parts that we are doing. But the people who work in and around maternity have made that certainly clear to me that that's important. I can assure you they've been very, very strong advocates reform has to start somewhere, and I know that by picking emergency departments, there are people in other parts of the hospital say it should have started there. I have to start reform somewhere. I don't have a magic switch that can cover every single part of the hospital at once, but no one is more determined than I am to make sure that we improve staffing in our public hospitals. I'm focused on it like no one else is, and I'm determined to see reform in this way, because I think it is the only way in which we continue to enhance the quality of healthcare that we do for the people of New South Wales, which is focusing on the human capital, not just the infrastructure that we build. But Mr. Minns, did you want to add anything in terms of that?
I can just clarify that there's been more than 2 meetings of the Birth Rate Plus team or joint committee. Part of what the review will need to do is look at the underlying methodology. So Birth Rate Plus is a proprietary methodology. It contains a formula. The difference with maternity staffing to safe staffing levels in other wards is that you don't have the predictability about patient attendance associated with childbirth. So it's a survey model that takes into account a large number of factors to do with mothers, babies, and the acuity of care. And when you do a survey, you're trying to understand what is changing in that catchment area of birthing mothers. So a key part of the review is to unlock that proprietary methodology and understand how it goes about producing the formula that drives the staff numbers.
Is there a timeline for the progress of that review?
Well, I think we'd be seeking to have it concluded around the time that we're ready to start rolling out safe staffing, which at the moment we'd sort of say is in the February-March timeline.
I look forward to asking you about it again in February next year.
And I know you will.
At the New South Wales Nurses and Midwives Association conference, Minister, you said that your work on safe staffing is the beginning and not the end. Is there any work being undertaken to address the current unsafe staffing levels in areas that are not under the remit of the task force, including neonatal intensive care, paediatrics, mental health, drug and alcohol services and community health?
Yeah, I'm glad you asked that question. The people... Well, all of those groups have been particularly passionate, but I just want to call out probably people who work in neonatal and mental health have been very strong advocates in this space. What I've focused on first is getting those areas that we are focused on getting up in the first round done. This is a pretty significant reform piece. I was concerned when we didn't have the 1,112 nurses in the forwards. I'll be blunt. That would have made safe staffing reform impossible to do had I not been able to secure that funding, which I think is about $500 million. But yes, we will continue to look at other areas, absolutely. But we have to get the areas that we've started on focused on first. All reform has a starting point. It's not done overnight, and whilst one of my traits is certainly that I'm incredibly impatient, I've got to accept that this needs to take time to get right, and I do just want to acknowledge the nurses and midwives for understanding the nature and scale of this reform, and that we haven't undertaken reform like this in the way in which we staff hospitals since NHPPPD was introduced, which is, sort of 09 thereabouts. So it's been well over a decade and a half before a government's taken something like this on. So I understand that the association wants me to continue to look at other areas, and I will continue to do that, but my focus and priority at the moment is getting the reform underway.
I understand that it's your intention to convert all wards that are currently staffed under the nursing hours per patient day model to minimum shift-by-shift ratios. Does the NHPPD staffing apply to public hospitals in peer group D?
Phil, is that one of the ones that we're having a look at?
I'd probably want to take that on notice and give you a more precise answer, but I don't think so, would be my opening statement.
Yeah, thank you. I'm happy for you to take it on notice. I don't think so either.
No.
So peer group D hospitals include Bellingen, Cootamundra, Glen Innes, Leeton, Narrandera, Pambula, Parkes, Temora and Tumut.
That's correct.
what changes to support staffing levels can be expected by the burnt-out frontline nurses supporting these communities if they are not going to be supported by the Safe Staffing Task Force?
Yeah, well, we'll continue to roll out staffing increases at those hospitals. So that's the first point to answer the question. Where we won't get in the first tranche of the reform is landing them into a shift-by-shift allocation. And I equally said, and have said this from the very beginning of this reform, that this is going to take time. I've actually probably really downplayed the ability for any government to get this up and running immediately in all areas without any challenges. There are going to be challenges because we are completely changing the way in which we staff hospitals. Now, I understand that hospitals like that and other parts that are not covered will continue to advocate and agitate. It doesn't mean that I'm not going to be allocating and that LHDs in those areas won't be allocated additional staff as a part of the 1,100 that we've saved and the 1,200 that we'd already come through, plus what was coming through the system under the previous government, and acknowledge the regional health minister's back. That it's just that as a part of the reform piece, I've got to start in a certain area and I've got to make sure that I get those components of the reform up and running, and that's what my focus is at the moment.
Can you tell us how many of those 1,100 nurses are being allocated to Peer Group D hospitals?
No, I can't. I could probably
Please
take it on notice and try my best to get it back to you, Ms. Conn.
Thank you. I'm moving to a different topic now.
Okay.
You've stated that there's not a sufficient volume of patients to sustain medium complexity cardiac surgery requiring bypass taking place at both the Children's Hospital Westmead and Sydney Children's Hospital Randwick. In a letter to the Medical Staff Council at Sydney Children's Hospital, you stated that in the event the activity increases to a level where clinical experts believe a second site is necessary and sustainable, then that would be fully supported. What level of activity would justify recommencing medium complexity cardiac surgery at Sydney Kids Hospital Randwick?
I'll take on notice, but I think it's somewhere in the order of 600 or so. I'm just looking at my DepSec, Ms Wilcox. I think it's somewhere in the order of 600. It's a very good question. And it's a question that I spent a lot of time in the first couple of months trying to work through. All of the clinical advice that I'd received, certainly the bulk of the clinical advice that I'd received, and I understand that different clinicians have disputes and debates about this, and I don't want anyone to think that I don't think that's important. In fact, I do think that clinicians should debate these types of issues. But I've landed on what I think is the most appropriate model, which is we're going to open up paediatric cardiac transplants. We're going to do the more complex and continue to do the more complex surgery at Westmead. The less complex surgery, ECMO, etc., will continue to be done at Randwick. But Ms Wilcox might just want to add any, if you think I haven't outlined that enough for the chair.
Yeah, thanks, Minister. I think that's covered off there. The figure where we get to a volume where the clinicians, because as you're well aware, Dr. Cohn, not just about the surgeon doing the procedure, it's about the entire team, nursing, allied health and the like, and the number would be somewhere of the order of 600 to 700.
I've spent a fair bit of time trying to get a hold of the case numbers, as have clinicians at the Sydney Kids Hospital Randwick. Why hasn't the department's analysis of the case numbers been released publicly as part of this decision?
My understanding was, in terms of the teams at both hospitals in the network, they have been provided advice and had regular discussions with the chief executive and heads of department around the service model, and volumes were certainly a key part of those discussions. But
sorry, not answering my question. Why wasn't the analysis of the case numbers released to the public and the community?
I don't have a definitive answer on that. There has been no decision to not provide information to the public around the decisions around this service, but I can take that on notice in relation to the volumes in particular.
Thank you. Minister, in your answer, you just stated that ECMO is going to continue at Sydney Kids Hospital Randwick. How can you be confident that this can continue to be provided safely without a cardiac surgical program, including bypass at that site?
Because I'm confident with what I've received from advice from clinicians and the department that we can continue to deliver that level of service safely and effectively, and that the more complex, intricate, challenging surgeries, and I've got to say, they are not as common anymore as what they once were, because what we are doing is interventions earlier in the piece to stop that type of complex cardiac surgery. I understand it still happens. I understand. I'm not denying that, but the volume is at this stage not going north. It's sort of heading south because we are often intervening earlier. But I'm confident that in the 2 sites that we have and the work that they are doing, that we can continue to provide the very best care to some of our sickest children, and that's what I am focused on. And I know that's what you and others in this committee would be focused on. I'm not denying that, but I'm confident that we can do it on the model.
Can you name one other hospital that provides paediatric ECMO without a cardiac surgical program, including bypass?
No, that level of understanding. No, I can't. I'll have to take that on notice.
I look forward to you taking on notice. I can answer the question for you. There are none in Australia or New Zealand.
Okay. Well, I'm confident that
The chair's a doctor.
I'm
What do we do? I mean, it's a new
Yeah.
world, Minister.
I'm
It's a great new
I'm
world.
confident, Dr. Cohn, that I'm confident that we can do it because we are doing it. That's what I'd say. We are continuing to deliver what I think is world-class healthcare at those 2 children's hospitals.
So in your letter to the Medical Staff Council, you cited that paediatric cardiac surgery is a team game, and as you've mentioned, the broad range of clinicians that are involved in addition to the surgeon, which I really appreciate as well. But is that not also true for the provision of ECMO? How can you be confident in the quality of emergency ECMO when that whole team doesn't have the volume of practice that they would if they also were performing medium complexity cardiac surgery with bypass?
Well, because I'm confident that given trauma and ECMO services are now being delivered and continue to be delivered at both sites, and that's been the case for a long time, I'm confident, and more importantly, I want the community to be confident, that if their child needed that level of care, they would, through one of those 2 hospitals, get in what my, probably bias, I understand that, opinion is, some of the best levels of healthcare for paediatrics in the world. And I'm confident that the system has been up and running robustly at the moment, continues to do so. But is it an area that we monitor? Absolutely we do. Of course we do. I think the committee would expect that of me as the Minister and that of my officials, and I'd certainly expect it of myself. But that's the decision that we've made, and we believe that's the best level of care that we can provide some of our sickest children at the moment, and we'll continue to do that.
I understand that surgeons at the Children's Hospital in Westmead have tried to plan cardiac surgery for older children at Westmead Private Hospital rather than at Sydney Kids Hospital in Randwick. And that report was in keeping with widely publicised reports of unacceptably long waitlists for elective surgery at Westmead due to short staffing. Why do you continue to stop medium complexity cardiac surgery from taking place at the Kids in Randwick when the necessary expertise and equipment is already in place?
Well, because as I've said, there's no change from our perspective in the current arrangements for cardiac surgery at the network. Low complexity cardiac surgery is provided at both hospitals, as I've said. Trauma and ECMO, as we call it, will continue to be provided at both sites. We're talking about small numbers of highly complex procedures that we believe is important to be done at a site where that volume is sufficiently high enough that the expertise and skills of clinicians can continue to be developed. Ms Wilcox, did you want to add anything in terms of anything that I haven't added that for the Chair?
Yeah, I think just to add in relation to the ECMO, and again, I'm obviously not a clinician in this area, but certainly the advice from the clinical team and the team at the network is that ECMO can be implemented by people other than cardiothoracic surgeons, and there are a number of large hospitals around the world, particularly in Europe, who are now conducting this, not just in cardiac.
Yeah. So I'd note that medical specialist training varies greatly across the world. We generally recognise, for example, New Zealand training.
Yeah.
I repeat my question, which has already been taken on notice. Is there a single other hospital in Australia and New Zealand that's providing ECMO without a cardiac surgeon?
I'd have to take that on notice, not to my knowledge.
And my last question was just about volume. Minister, in your last answer, you talked about high complexity procedures, and I'm not aware of anyone disputing that the very high complexity procedures should be centralised at one site. So I'm really focusing on medium complexity procedures that need bypass here. Is there any evidence that mortality or morbidity has improved since those procedures were centralised at Westmead?
Well, I don't know if there's any evidence. I haven't. I'll take that on notice, only because I don't want to mislead or give you the incorrect information. But just to say to the committee and to the community that the delivery of first world-class healthcare at those two hospitals is pretty important to me. I know it was important to the last government, and we'll continue to make sure that the model we have in place treats the sickest kids in the very best way possible. And I think that's what you would expect. I'd expect that of myself if it was my child, and we believe we've got that model. But Dr. Cohn, I want to be clear about this. I understand that there are sometimes challenges and clinical disagreements and debates. I for one, think that makes us a stronger and healthier public health system, not one that I want to discourage. That's all.
Thank you, and I look forward to your answers to those questions on notice to the opposition.
Thank you, Chair. Thank you, Minister. Minister, just going back to what Mr. Donnelly said, because, you know, you said that you really respected him. Mr. Donnelly and I sometimes don't see eye to eye, but I absolutely respect his devotion and commitment to palliative care over his career. But do you agree that there was $743 million in the forwards for extra money in palliative care that is now $150 million less? I would remind you that you're under oath, Minister.
Yeah. I reminded
Yes.
I am under oath. I don't need that reminder. So let me be clear again. I just want to go back to a few questions that you asked, because I've got some information
So, Minister,
around that issue.
My question was very...
You asked around palliative care
point of order,
positions
Chair.
at Bulli. That's what
Sorry,
you
I've got a
asked.
point of order.
Point of order that the Minister's been asked a direct question and the Minister appears to want to go back to earlier questions and not answer the question that's been asked.
To the point of order, the Minister is here by invitation and can answer the question as he likes.
You're better than that.
The Minister can choose to answer the question as he sees fit.
To the Chair, we're investing... I do respect Mr. Donnelly. He knows that too well. In fact, he's worked on the Health Committee for a long time.
Yes, he has, and he said that
Yes.
there's a $150 million cut where there is.
And
So
I-
do
and-
you or do you
and
not agree?
And I respect, Minister, as I'm sure you have very strong and passionate views, particularly in relation to cancer treatment in regional rural health care. I understand you have those views. Each of us have passionate views about things. What I'm saying, and an expectation that government of all political persuasions in this area continue to do better and should do better. What I'm saying to you is we are investing a record amount of $1.7 billion over 4 years.
Minister,
That
you have
includes-
actually said this. I would ask you this. Are you giving evidence to the committee that there was not a reduction in palliative care funding as had been committed in the 22-23 budget?
What I'm giving evidence to the committee about, to the honourable member, is that this Labor government is investing a record amount in
Minister,
palliative
you
care.
have said that
We will
multiple
continue-
times.
we
My
will continue
question
to
is
invest
a
record
simple
amount
one.
in palliative care because we believe it is an important part of healthcare.
Minister,
As I
I'm
know
going to
that
move on now
Mr.
because
Donnelly-
you are. This is misleading and
Point
it
of
is very
order,
disappointing.
Chair.
So
Point
I'll
of
move
order.
on.
I'll
thank
hear the
you.
point of order, please.
Right.
There's continued interjections and speaking over the top of the Minister as he's answering the question. You have previously ruled on this. It is utterly discourteous.
Thank you. I'll remind the member of my previous rulings.
Thank
Could you
you,
please
Chair. I'll
interject
move-
with questions and allow the Minister some time to actually try to answer?
I'll move on. It would help if the Minister answered the question, but I'll move on. Minister, are you aware that you have cancelled 11 palliative care medical staff in the Northern Sydney Local Health District? Will you apologise to the people in Northern Sydney that will now have to die in pain because of your cuts?
No. So I don't believe that is the case.
So know that you're not aware that you cancelled 11
Well,
positions?
no,
or
no. So, Chair, I'm around 4.5 seconds into my question. Maybe I get a
It
little
would
bit
help
longer
if you
than that to
answered it,
start.
Minister. It would make it easier for everybody.
Sorry, I remind the
Because
honourable member to allow the Minister at least a sentence of his answer. I
Well,
think
the
we
reason,
can all
the
agree
reason
that's
why
fair.
I'm a little bit concerned about the inferences being made by the honourable member, Chair, is that The advice that I've received already during this committee is that there was a reference to palliative care positions being cut at Bulli. Now there's been references to palliative care positions being cut, I think it's at Northern Sydney. I've been advised from New South Wales Health that that is not the case at Bulli. So I'm just concerned that we're making comments that are wrong. I'm now responding to you and saying that the earlier remarks you made about Bulli, my advice from health is that that is incorrect. So I'm trying to be as respectful as I can, but I'm not confident that the inferences and remarks that the honourable member is making is accurate.
Okay, Minister, well, would you like to take that on notice then until you can verify the accuracy if you're not sure?
Well, I will, but I want
Okay,
to. But I
thank
want
you,
to take
Minister.
off notice the one that I've already responded to, because I like
Minister,
to make sure that this
we'll
committee
have-
gets answers while I'm here. That's important. That's my accountability that I set myself as the minister. So
Well,
we
that's
can
fine,
take off
Minister,
the one
but
about
we
Bulli.
have letters to the contrary, so
Well, we can take off the one about
That's
Bulli.
great, but thank you. So, Minister, in November, I announced a $13.6 million announcement for a dedicated palliative care unit at Wyong Hospital. Why have you cancelled the $4.3 million annual funding required to run this unit, and will you apologise to the people of Wyong for creating a ghost palliative care ward?
I know we'll continue to invest palliative care services in the Central Coast. The specifics...
Then why have you cut the funding, Minister?
The specifics that you raise or that you infer, I'll take on notice, and we'll be able to answer you probably during this committee. But can I just talk about the Central Coast?
Well, no,
and
Minister,
the
because
commitment?
I'm the one asking the questions,
well,
and I'd like to
and on
move
the
on.
Point of order.
Point
of order.
I'll hear the point of order.
The Minister can answer as he sees fit. I understand and respect that the Honourable Member is the one asking the questions, but again, she has to afford the Minister time to answer, and he can answer as he sees fit.
And I have, and the Minister said he'd take it on notice. That's how this
And he was
works. So I'll
continuing
move
to
on the next
elucidate the
question.
response.
Thank you.
The issue at
Look, I
Wyong is
suggest to the honourable
important.
member, if with the
issue-
level of interjection, we're probably going to continue to hear points of order during
see
your
what happens
time
when
from
they
the
run
government.
cover. Yeah.
Well,
Yeah.
I'm
Try
Okay,
and
move
help
on
me
then.
help you.
I'll move on.
The issue at Wyong
Minister,
is
are
important,
you aware
and I've met
that-
those groups up there too, and I acknowledge that the member, both the Labor members in that area and the member for Terrigal have been strong advocates around this
and
issue.
they have, and it's fantastic that Wyong's going ahead, Minister Park, but in order to run a palliative care unit, you need staff, and to have staff, you need the arrangements to be in the forward so that happens. So, you know, let's just be really honest. I understand you're in a very difficult position here because the Premier has obviously cut this money. So,
Well, I was in a
Minister,
difficult position in
November-
my first week
I'll
in
move
this
on.
job when I found out that you had cut 1,112 nurses,
Oh,
that they would be
Minister Point of order.
removed
I've got a point of
from
order.
July 2024. I mean, that's a
Order,
that's a big
please.
job.
I'll hear the point of order, please.
Chair, I've refrained from calling points of order on a number of occasions where personal reflections have been made of others. I'm now going to call a point of order on it. It's been done a number of times during the hearings, and I just ask that you call the member to order when it occurs.
Thank you. I'll uphold that.
Yeah, the Premier said yesterday, Minister, that the money needed to go to recruiting nurses, many of whom would be working in palliative care. So the Premier admitted to the $150 million cut yesterday. Why won't you?
Because what I'm focused on is the investment in services that we're
So do you
doing.
disagree with the Premier, Minister Park?
No, I don't disagree with the Premier around
Minister
the importance
Park-
of palliative care. I
Minister
never
Park,
will.
if you-
I know it's something he's passionate about.
Minister Park, if you were the Premier, would you have cut $150 million out of palliative care?
Well, I'm not the Premier.
But if you
honourable
were
member.
Minister Park,
So
I think you'd make a terrific Premier.
I'm not the Premier.
Well, I hasten to say I don't think you would, Minister Park. I don't think you would have
Our
cut that.
Premier is doing a fantastic job, and he's doing a
Minister-
fantastic job.
Thank you, Minister. So we don't have the forwards for Wyong, but Minister, are you aware that because of the cuts to palliative care, that 3 dedicated palliative care beds will now be cancelled in Orange Hospital?
No, it's not my advice at all, Honourable Member.
Okay.
Our advice...
So you're saying they won't be cut?
Our advice, Honourable Member, is that we're doing 3 additional beds. That's on top of what your government, I think, did in 2021, which was two beds, and construction of the upgrade. My advice from New South Wales Health and the team at Health Infrastructure and the Ministry is that that'll take place in 2024.
Thank you, Minister. So no cuts there. Thank you, Minister. Minister, can you please tell me how many dedicated palliative care beds there are at Bathurst Hospital?
I'll take that on notice.
I can tell you there's actually none, Minister. And are you aware that because of your cuts to palliative care, that 5 dedicated palliative care beds will now be cancelled at Bathurst Hospital? Are you aware of that, or would you like to take that one on notice as well?
Well, let me tell you, you just said that there are no beds at Bathurst, I think you said. Is that correct?
And they were meant to have 5 with
okay.
the palliative care enhancement funding that's now gone.
Honourable Member, I don't want to state the obvious, but you were in government for 12 years.
Yeah, but now you are Minister Clark. Now it's your turn.
I've been in government for 6
and
months.
you've cut palliative care
Mrs Taylor,
funding
please
by
allow the Minister to at least get
$150
through
million.
a sentence.
Honourable Member and Chair, I've been in government for 6 months. We
cut
secured
palliative care by
1,112 nurses that they were going to cut. And
Oh, Minister.
we will continue to roll out
Sorry.
palliative care in Western Sydney, in metropolitan areas, in rural and regional areas, in remote
And Minister, we
areas.
put money aside
That's
to fund
important.
5 beds in Bathurst, but you haven't. So,
Is there a question?
sorry? Yep. Don't worry. I'll keep going. Minister, can I please ask you why your parliamentary secretary hasn't attended today?
He's unavailable.
He's unavailable. Is he unavailable because he doesn't support your cuts to palliative care?
No, he's unavailable, and I think one or two of these that I observed during 12 years of opposition, I actually never remember. Certainly, you didn't, Honourable Member, have a parliamentary
Minister Park, Eleni Pennos attended. Multiple parliamentary secretaries attended.
You didn't have a parliamentary sec there. The Honourable Minister Hazard never brought a parliamentary
Minister
secretary
Parker, it's
there.
not correct. There were parliamentary secretaries that attended, but that's fine. Minister Park, would you agree with me that the people that are sitting with you there today, the secretary, the minister, the person who runs health infrastructure,
Rebecca
your deputy
Walk.
secretaries, that they are the most amazing individuals? Would you agree with me?
Absolutely, I would.
Yeah. I would actually hasten to say that the Department of New South Wales Health would have to be one of the standout departments
Thank
in
you.
the New South Wales government.
I agree, and with
You
your
agree.
experience,
I thought you'd agree.
I respect that.
So, Minister, would you agree that women deserve to have a safe workplace? The Premier agreed with me yesterday that was an important thing.
Well, of course I do, and
I knew you would.
I
I knew you
would
would.
like to think that
So-
not just as a feminist, but everyone in this building, everyone in this hearing, thinks that would be the case,
Yeah.
and it would worry me if we didn't.
Minister, your parliamentary secretary has said some pretty defamatory things about very senior health officials on your team. He has referred to one of them as Marie Antoinette. He referred to a previous health secretary as Elizabeth Coffin Cough. He referred to the
point of
CE
order.
of the
I'll hear the point of
Southern
order,
Local
please.
Health District as
Order. I've got a point of order, please.
I'm assuming there's a question that's coming at the end of this, but
There is, if you'd let me finish.
But I mean, there's a series of statements being made in the lead up to a question that is seeking to adversely reflect on a person in a personal or reputational way who is not here to actually
I could
address
table.
that. So
I'll
rule.
table all the comments from Dr. Holland, Chair.
Thank you.
I
I
see
would
you
I
rule
would
the question out
caution
of
the
order.
member about adverse reflections
Yeah.
and allow her to continue her question.
So, would you agree that any sort of comments about the outstanding people in New South Wales Health are absolutely disgraceful?
Well, people should treat public servants respectfully and professionally.
But your
and
parliamentary secretary doesn't. So, what do you have to say to that?
I don't know what you're referring to. I'm not aware of that. I don't know that.
You're not aware of it.
Well, no, I'm not.
No.
But,
Well, I actually believe you, Minister, because I don't think you would ever tolerate that sort of behaviour. And now your parliamentary secretary is working with a number of people who he has defamed and been absolutely derogatory about. And
Point
also,
of order,
Minister
Chair.
Park,
I'll hear the point of order.
The rules of debate still apply to committee inquiry hearings. There are some serious allegations of improper motives and imputations of personal reflections that are being made here that I would ask you to rule out of order in the honourable member's line of questioning. I respect you've got a line of questioning you're entitled to ask, but the way in which you're doing so it seeks to reflect personally on someone's character and has some quite serious imputations.
Yeah, I'll uphold that point of order.
right. Well, I have an email here from the New South Wales Health Department actually asking for these comments of Dr. Holland's to stop and how inappropriate they are, and I'm happy to table them as well.
Look, let's be clear. My involvement with Dr. Holland and my relationship with him has been one where I have valued his counsel and I valued his advocacy for the communities that he represents. These allegations are being made without any reference. I don't know if it's accurate or not. What I will tell the committee is this. I think Dr. Holland is a man who advocates very strong for his local community. He's very passionate about healthcare. He's very passionate about the care for children and mothers, and he will continue to do that. I'm very pleased that he's my parliamentary
Thank you, Minister
secretary.
Park. On February 20 on ABC Southeast last year, Dr. Holland referred to national members as a pack of dogs on ABC Southeast Radio. Would you agree that that is an inappropriate use of commentary, calling myself and the Honourable Nicole overall a pack of dogs on radio?
I mean, I don't know, Chair, respectfully, I don't know that any of these issues are based in fact.
Well, they
or
are
not.
100%
So
fact.
I've been asked to comment on things that I'm not aware of.
Okay.
I don't think that's appropriate for me to do. What I can say is my relationship with Dr. Holland is very strong. I'm very proud that he is my parliamentary secretary, and I think he's a very good advocate, particularly for the people of southern New South Wales.
Thank you, Minister Parker. I can't imagine you with your integrity and what you have stood up for ever supporting comments like that. Also, to Minister Park, I asked the Premier yesterday if he expected all of his ministers, parliamentary secretaries, and backbenchers to be up to date with their disclosures, and he said that that was very important. Would you agree that we have to have accurate disclosures to maintain our integrity and transparency?
Yes.
And what would you say, Minister Park, if I told you very factually, and I have the evidence here, that your parliamentary secretary has failed to disclose any of his directorships of companies?
Well, what I would say to every parliamentarian is what the Premier has made it clear to us, that he expects all of us to comply, whether it's the ministerial code, whether it's our parliamentary code. That's what I do, that's what he expects of me, that's what he expects of everybody else. I can't comment about individual members, the honourable member.
Yeah.
I wouldn't do that about you. I'm not going to do that about Dr. Holland.
I understand that,
I say in
Minister
general
Park.
that we have requirements to disclose a range of different things
Thank you,
under
Minister
that,
Park.
and that's what I do, and that's what the Premier expects of me.
Thank you,
That's what he's
Minister
made
Park.
clear to our
I
team that we should
understand
be
that.
doing.
And Minister Park, I actually apologise that I have to ask you these questions, but because you're parliamentary secretary, 25 minutes before the committee was due to start, decided not to turn up. I've been given no choice. And Minister Park, were you made aware when Mr. Krakenthorpe was stood down that 72 hours before that, Dr. Holland deregistered his family investments, of which he was a director, and he also failed to disclose that. He's the director of a company for 28 years, and miraculously he deregisters that company right before Tim Krakenthorpe was stood down. Do you reckon he's psychic, or that was pure good
Point
luck?
of order.
I'll take the point of order.
I'm reticent to do this, but we're now flagrantly ignoring procedural fairness resolution, paragraph 13. There is a legitimate line of inquiry.
It's legitimate.
This is not.
I'm
this is
done.
not the forum.
I'm done.
Yeah, look, there's some pretty
I'll move
serious
on.
adverse mention. You've tabled documents that the committee will consider at the end of the day with regards to whether they'll be published or
Thank
not.
you, Chair. Yeah.
Mrs. Khan.
Minister, if we can go back to the issue of palliative care, and in particular the closure of St Joseph's next month, caused by your budget cuts, what
Incorrect.
happens to those 24 beds at St Joseph's?
Honourable Member, it's nice to meet you. I just remind you that you also have a responsibility as a part of this committee to speak factually. That is incorrect.
Oh, point of order, Chair. Now we have the Minister
That
trying
is incorrect.
to school a member. That's not
Trying
on.
to link something to something else in relation to that hospital is wrong. So
Are the 24 beds at St Joseph's closing?
well, St Joseph's is not going to continue to operate the way it was.
Where will those
I
24
know
palliative
I know
care
you
beds go?
Well, just let me finish. I know you understand that. We are expanding palliative care in Western Sydney, I think including at Auburn, from memory. I'm happy to get to the specifics, but please, that is a hospital run by St Vincent's. I know you know that, Miss Carter, but I think it's important that we don't try and join dots that are not.
Where will
able
those
to be
24
joined.
beds be going?
I'll provide a detailed response on notice. I
Take
know
it on
my,
notice. Okay.
Could you also-
I know my deputy secretary.
Could you also
Ms.
perhaps
Wilcox,
advise whether the 0.8 medical support that those 24 patients currently receive will also be travelling with those 24 beds, or will that medical support be made redundant?
Well, let me make this clear. I was about to say I can update you. Happy to take information on notice. I may not need to, because I know that my Deputy Secretary, Ms Wilcox, has been working with St Vincent's on this issue, as have met with them on this issue, and we are working with staff around this issue. So I might just refer to Ms Wilcox.
Oh, that's fine. We've got time with Ms Wilcox later. Can I just ask you, Minister Park,
well,
what was, we
but
do, we
Chair-
have the bureaucrats all afternoons. We want to
Chair-
talk to you.
Chair, can
What
I
was
just
the
ask
funding
something?
allocation?
Point of order. Point
Thank
of
you.
order.
I'll take the point of order.
The Minister is entitled to answer the question, but also direct the question as he sees fit.
Yeah, I think it's
No.
reasonable.
Thank you.
A
I'll allow
reasonable
the
question
Minister
was
to
asked.
redirect the question.
A reasonable question
Point
was
of order,
asked.
Chair. Point of order. Through estimates yesterday, that was not the case. We have the bureaucrats all afternoon. We're here to question the Minister. If we want to keep... I want to move on to a new question, Chair, and I've limited time, so I'm going to move on.
Further to the point of order,
What was the
Chair.
funding allocation for palliative
to the
care
point
over
of
the
order.
next
Further to the point of order.
Just because it was run yesterday, it doesn't mean that the Minister is entitled to
blatantly
answer as he
wasting
sees.
time because
The
you
Minister
know
is
how much
entitled to
trouble
answer
your
as he
minister's
sees
in.
fit, but also he's entitled to direct it as he would. As he
While
would
the timer
like.
is not
If you
running.
continue to
Understand how this
interject,
works.
I understand the standing orders
You were in
and
a
the
different
procedural
session
fairness
with a different
resolution.
committee and a different chair yesterday. I understand that the Minister is able to redirect questions if it's in the interest of getting this committee a more accurate answer to a question that's been put.
Which is what I was
Chair,
trying to
since
do.
I started my last question, can I just ask it and the Minister can take it on notice?
Time's expired.
The time's expired. I'll move to Ms Fairman,
Okay, two more
who's very
sessions.
admirably on WebEx due to having some respiratory symptoms. Thank you very much, Ms Fairman, for not sharing those germs with us, and I'll allow your questions.
Thank you, Chair. Morning, Minister.
Morning, hope you're feeling better.
Thank you. I just wanted to ask you questions about pill testing to begin with, which is probably not out of the, not what you were, what you were expecting, I'm sure. You're aware of the ACT pill testing services, aren't you?
Yeah, I am. I've had some
Yeah.
discussions.
Have you
I think.
read that?
Sorry.
Yeah. Have you had a look at the results of the pill testing trials there?
I've read some material around it. I don't want to give an incorrect answer to say I've read the specifics about the trial, but I'm certainly aware of the trial, and I think Queensland is also doing some work around tendering out something in this space.
That's right. So there's just extraordinary statistics actually that come from CAN tests, the work that they have done both at the fixed trial as well as at when they were operating at music festivals there as well, the Groove and the Move festival. But one statistic is that up to 30% of patrons stated they would definitely not take a drug when their test came back with an unexpected drug. Are you aware of that result?
I'm not, but I've got Dr. Chant with me, Kate, who's obviously working and has been working across a range of different governments for many years in this space. So I'm happy to.
That's fine, Minister.
Okay.
I
No
just want to talk to you about this result because one of the benefits of pill testing or drug checking is that people, when they access the service, get access to health professionals as well, who they haven't potentially been able to speak to anybody in their life about how to take or what to do in circumstances where they do take drugs to be as safe as possible. Are you aware of that?
I'm aware that there's been some work done in that space. I'm not aware of the specifics, but I can assure you that whilst, as the Premier said yesterday, we don't have plans to do pill testing at the moment, he and I, very clear, are not closing the door on reform in this space. We are trying to make, Kate, largely because of suggestions from the sector and coming through the evidence, music festivals as safe as possible. and we've rolled out a number of measures to make them even safer. That is something that I'm proud of, but it is something that I think is necessary, and we are continuing to look at a range of different issues in this space, and I think that's what I expect of myself. I'm assuming that's what a committee like this would expect of a minister and a department as well.
So, but you do see benefits, I assume, in terms of if people do go into those services, they talk to health professionals at an environment where they're potentially going to take drugs. There's health professionals there. They speak to people for the first time. Sometimes they get advice that makes them not take those drugs. That's better than not having that service there at all, isn't it?
Well, I'm very focused on harm reduction measures. There's no two ways about that. We've got peer-to-peer operating across our music festivals. We've got improved messaging, improved first aid, improved water allocation and resourcing, making sure that we've got medics on site close by. The peer-to-peer stuff is important. What we've said is we don't have a plan for pill testing at the moment, but at the same time, as the Premier made clear yesterday, and as I have both publicly and privately, we will continue to not close the door on reform right across the landscape to make things as safe as possible.
Has any pill testing service provider reached out to you to offer their services?
I'll double check or take it on notice. I think they have, certainly through New South Wales Health. I'm not 100% sure through my office, but certainly through New South Wales Health, I think they have. I just don't want to mislead the committee, Kate. Could I just ask Dr. Chant just for 20 seconds just to make sure that...
Thanks, Dr. Chant.
Yes, Ms Fairman, they have reached out. I think the letter correspondence has gone to the Minister's office, but again, I need to check the time and date of that. So happy to talk about that. You also may not be aware, Ms Fairman, that we currently do some what we would call back-of-house drug checking, and we have a relationship with police, that police seizures are tested, obviously for police purposes, and anything of concern is elevated to us for consideration through a panel that involves also experts, clinicians, plus also representatives from newer and other groups. We also do look at our real-time emergency management presentations for drug-related harms and work with our clinicians to obtain samples to detect unusual contaminants. We do have a process of issuing public warnings in that case, and we have issued a number of public warnings. I think it's really important to note, and obviously the Minister, the matter for pill testing more broadly is a matter for government, but it is important that we acknowledge that the nature of the intervention with pill testing is as you described, but it's also important to acknowledge that a lot of the harms that have been associated when we've looked into the deaths associated with overdose have been MDMA, and so we do urge and are doing a big push so that individuals know the signs and symptoms of MDMA toxicity, make sure that they're aware of the early symptoms, particularly go slow when they're taking the medication, to care for each other, and we've done a lot of work with our peers and creating safe chill-out zones in our festivals, but also increased our medical capabilities at the festivals.
Thank you, Dr. Chant. A couple of questions just on that. When you're saying back-of-house testing facilities, what do you mean?
I mean that our forensic and analytical services which is part of New South Wales Health Laboratories, provides testing and analysis for police. And
right, you don't mean at festivals?
Well, just in the course of the work that police obviously need to do that for their criminal purposes. But we also...
but just to be clear, you're not testing the drugs at the festivals?
Well, some of them will be obtained...
on site at the festivals?
Not on site at the festivals, but some of the pills that have been collected through police activities will be tested. Anything that is of concern will be discussed with health.
So just
Separately
to
to
be clear,
that,
if there's something dangerous in circulation at a festival, that police confiscate. Are you telling me that New South Wales Health tests that immediately and is therefore able to alert festival goers at that festival that there's a dangerous drug in circulation?
No, what we're saying. We're saying that
that's
there's
what
three.
pill testing does.
Yeah, we're taking this. So there's 3 prongs. So, for instance,
That's the point.
So if I can just describe what the current system does, if we have anyone presenting,
Minister, that's fine. I think. Oh, sorry, Dr. Chant. Maybe you should be Health Minister, but Dr. Chant, that's fine. Thank you. I know what it does. I just needed to. Another question is just in relation to you talked about MDMA, the fact that the people are kind of dying of MDMA overdoses. The coronial inquest really, when Harriet Graham really looked into this, it was really as a result of largely most of those, if not all of those terrible victims of that summer were taking many drugs. Alex Ross-King, for example, took them all at once because she saw the drug dogs. Others are taking too many at once. Don't you think that is part of the problem, is that people are consuming drugs in a way that if they're going to take it, the fact is that they're taking all of their drugs at once because of trying to avoid drug detection dogs and the like.
Yeah. Thank you, Kate, and I want to acknowledge from the very outset, all the time that I've known you, you've been a very strong advocate in this space. And whilst we don't agree with everything, I do want to acknowledge that to the committee. The issue of drug detection dogs is obviously one for the Minister for Police to outline. But what I don't want to give this committee any sense of, and I'm sure you don't either, Kate, is that pill testing is a silver bullet to stop deaths at music festivals, because the physiology and the way in which the physiology of a person's body interacts with the substance they take is something that can't be measured, and that's factual. So whilst I understand you're passionate about it, and I've outlined our position, I also don't want the community to have a view that just because you have pill testing means that your child, if they use pills, is not going to face some very, very harmful effects. That would be misleading, that it is some sort of silver bullet. That's all.
Sure. Thanks, Minister. I've heard the statement about not being a silver bullet before. I understand that. I don't say that pill testing is a silver bullet, just like seatbelts aren't a silver bullet. Would you agree? But seatbelts will make people safer and can prevent deaths, which is what pill testing does.
Well, we are looking at how we make festivals as safe as possible. Already, during my time as Minister, we've rolled out a number of measures that I've outlined, including additional peer-to-peer support, including additional first aid, including additional access to medical services, including making sure that we have adequate water and information going out to patrons and visitors to these festivals frequently about making sure that they behave in a way that reduces their harm. We haven't got plans at this point in time to do pill testing, but as the Premier has said multiple times, as I have said multiple times, we are not closing the door on reform. You would know that we are doing a drug summit next year, the first time that the government has done this in over 20 years, and no doubt this issue and other issues will be ventilated at that summit and will be discussed and debated, and no doubt, as I'm sure the committee would be aware, that yourself and others, people no doubt on the committee, will be participating in that, and I look forward to that.
Thank you, Minister. I very much look forward to the drug summit as well. But what's stopping your government from putting in place at least a trial this summer so that the results of that trial can inform the discussion that will take place at the Drug Summit about pill testing. If that doesn't happen, all we'll be discussing are trials that have taken place in other states, pill testing operations, drug checking operations that have taken place in many other jurisdictions. But why wouldn't we just put in place something that has a pill testing service at a few festivals, one in the community potentially, but at a few festivals, just to see and be able to report back and discuss?
Well, Kate, I understand.
What is the harm in doing that?
Kate, I understand that's your position, but as I said, government hasn't made that decision and is not planning to make that decision. Equally, this is an area across the board, not just in pill testing, but a range of different measures and reforms that we're not closing the door on, okay? But we are going to do this in a sensible, measured way. We believe what we are doing at the moment in terms of increasing the support and protection and information and access to health and medical staff at festivals will certainly assist that. As the Premier said, I think it was yesterday, certainly in other forums, we haven't closed the door on reform. We are going to be engaging with the community, with members of Parliament in both houses, and more importantly, from my perspective, experts in this area as a part of the Drug Summit that we'll hold next year. So I'm not going to preempt what is going to happen at a Drug Summit. I don't think that would be right either.
Thanks, Minister. Speaking of experts, if it was up to you and New South Wales Health, you'd agree to pill testing, wouldn't you?
I know, we made a decision. I'm a member of a government and we've made a decision around that at the moment, and that is what we don't have plans for pill testing, but as I've said, as the Premier said, probably as other members of the government has said, that we are not closing the door on reform in this space. I think the fact that we have acted very quickly to what I think is bolster the safety of music festivals for those attending in a very short space of time is important to acknowledge. I think it's also important to acknowledge that pill testing on its own is one measure. It is not the only thing that should be focused on, and as I've said repeatedly, it isn't a silver bullet.
Thank you, Minister. Have you made any approaches to other members within your government about the unfair drug driving laws here in New South Wales that discriminate against medicinal cannabis patients? There are tens of thousands of people who use cannabis medicinally in this state, and as a result, most of them probably choose not to drive because they risk losing their licence. Does that concern you?
In relation to the representations, I think you'd agree, Kate, members of Parliament, whether they're ministers or members in the upper house or members in the lower house, continue to engage on issues of public affairs and topics and policy issues. That's what we're paid to do. I'd be worried if we didn't. But I think the big challenge here, and whilst this predominantly sits with the Minister for Roads, the Honourable John Graham, whilst the big challenge here, I think, is around the issue of impairment and how do we measure impairment, and that's a challenge. What my focus is making sure that people are as safe as possible if they're going to undertake driving, and they're as well as possible. This issue has been discussed with me by the Honourable Jeremy Buckingham, and I know he has, like yourself, strong views on this. But at this stage, we're not planning to do that, and I think the big concern, but I'll let these issues be raised with Minister Graham, just because I don't want to be misleading to the committee, but I think the big concern is around impairment.
Yeah, I mean, the issue with it as well, though, is that there are other drugs, legal, because medicinal cannabis is perfectly legal. There are other drugs that also potentially impair, potentially more so, such as opioids, that people have prescriptions for that are driving. So it just seems that there's this incredibly kind of unfair situation here, isn't there? That people can be zonked to their eyeballs on opioids. Obviously, they shouldn't drive, but at some point, something's got to happen with this really unfair law. And you know that a lot of people who are very sick can't get medicinal cannabis because they need to keep their licence. It's a terrible, terrible situation, particularly for people in regional New South Wales.
Yeah, it's a challenging public policy space. There's no two ways about it. Having worked with many
But
people...
it's legal medicinal cannabis. So the challenge in terms of impairment is the same for opioids as it is for medicinal cannabis.
Well, the challenge is making sure, as you know, that people are safe when they get on our roads. I think that's what we're all trying to do. I understand what you're saying, but it is a legislative piece that is centred with the Minister for Roads. He's obviously taking advice from people such as those in the Centre for Road Safety, or the version of which no doubt rests with Transport for New South Wales now. I understand that is a challenge, but I understand that the impairment issue is a real one, and no doubt he'll continue to engage with members of Parliament on this issue. I think that's what you would expect.
Thank you. I'll just I think I've got a little bit of time remaining. I just wanted to talk about the $500 million in relation to the ICE inquiry. There was $357.9 million, I understand, allocated to New South Wales Health. Wondering how much of that has been allocated and spent for this financial year. And Dr. Chan, you were invited to, with the Police Commissioner Karen Webb, advise the government whether services were in place for the pre-court diversionary scheme to be enacted. Yes. So I assume that's all happened?
Yes. Kate, I'll just add some comments, and then happy, of course, for Dr. Chant to go into this. Yes, we engaged with the opposition last week about pre-court diversion, something that will potentially stop around 6,000 people from going into the court system for very, very low possession. The previous government, as you said, committed, I think, $500 million over the 4 years. 358 was allocated to health, 141 was allocated to other areas. Of the 358 million over the 4 years to health, 163, Kate, is for evidence-based treatment, prevention and early intervention strategies. 96 is for integrated support for people with complex needs, obviously vulnerable people. 11.7 million is for enhancing digital capacity. 66 is for alcohol and other drug workforce through the establishment of more positions for critical roles such as Aboriginal health workers. And 20.2 is for the better use of data and evidence to inform the system and management and monitoring and evaluation. And that is being rolled out. And Dr. Trent, did you want to?
Just in the interest of time, I'm happy to clarify any particular points, but I think the Minister summarised that there's been a lot of work done to stand up the services and allocate the money as quickly as possible within the procurement and contract requirements.
Thank you. We've got 2 minutes left before government time. I'll give that time to the opposition.
Oh, thank you very much, Chair. Thank you very much. Minister, can I just ask you, what was the funding allocation for palliative care over the next 4 years at the pre-election budget update? And what was the funding allocation over the next 4 years, as in the budget 23-24?
Well, I've already outlined what's in the budget. It's 1.6, a significant increase compared to what had been rolled out previously. We will continue to roll out a significant amount of investment in palliative care, and should we be able to continue to increase that, we will no doubt have a look at that, as well as other priorities that we have in the health system. But I think you also raised, Honourable Member, about cuts to Western Sydney in a letter I think you referred to I've got advice from New South Wales Health that there is no cut in dollars in relation to Western Sydney. I think you also advised the committee that there was cuts in North Sydney Local Health District. I'm advised that that's not the case, and they've increased their medical staffing.
Thank you, Minister.
At
I might
Greenwich and
go.
Hornsby hospitals.
Thank you.
though
So
I
just to
wanted
clarify, you're not prepared to say
No.
the numbers to demonstrate that $150 million cut, but my colleague would actually like to follow up now, so I'll hand over to her about that letter.
Okay, thank you, Honourable Member.
Thank you, Minister Park.
Thank you, Minister.
Thank you.
I have a letter from Deb Wilcox, who's here with us today, written
Yes.
to all LHDs, informing them of funding allocations over the next 4 years of $743 million for palliative care. I also have another letter to those same LHDs on Friday, informing them that $150 million of that allocation has been cancelled. Who is right, you or your department?
I think the letter was, you're saying, from Ms Wilcox, so
Well,
I'll ask
the,
Ms
the
Wilcox.
question, Minister, is you seem not to acknowledge any cut.
Would you be able to provide a copy of that letter, Ms Carter?
I believe I will be able to. I have a digital copy at the moment. I'll endeavour to do that in the break.
Because I'm
But
sort
the
of
question
arguing about
remains.
something that I haven't seen, Ms Carter. So I think
So the department sends letters about cuts to LHDs,
The
and you
member's
have no
time's
knowledge of that.
expired.
Sorry.
It sounds like that letter will be provided, so this conversation can continue later in the day.
My
We
advice
have
is the
15
letter
minutes
doesn't
of
talk
government
about
time.
cuts if that's the letter you're referring to, but I don't know the letter you're referring to, Ms Carter, so I'm just making
If there's
sure
one
that...
letter that says
Mrs.
743
Cotter, I
and
apologise.
another that says
You're cutting into
153.
the government's time. They only get 15 minutes.
So the government's having
Thanks.
time now.
Thanks, Chair.
First time
Minister.
ever. Here we go.
Minister, can you please
What a
explain
joke.
when you first discovered the temporary nurses that have been left unfunded by the previous government?
Bravo.
Yeah, this was a very big concern of mine.
This is the best you can
I
do.
think it
I
came
call
up in
Mrs.
the-
Taylor to order. The government only gets 15 minutes. Please let them use their
The
time.
government has never, in all of my history,
I
taken
think it
questions
came up in the
because the
first
cover-up
week.
continues.
Order.
Certainly,
Unbelievable.
It was a discussion that I had great concern about
How
hearing,
pathetic.
and I spent the next few days trying to work out a plan with my officials around how we were going to address that. A removal of 1,112 nurses.
There was no
There was no
removal.
removal.
That
Order.
A removal of 1,112 nurses from 1
You
July
can't lie to the
2024. That was never alluded to in the lead up in any public statements by the former government in the lead up to the election. I think anybody who takes over this role would be concerned if someone tells them in a short period of time of taking on the role that there is 1,112
Point
of their
of order,
frontline
Chair.
staff
Point of order.
that are not going
Point
to
of
be
order,
in
Chair.
I need
place
to.
Second
in
I
the
need to
space
hear.
of 12.
Sorry, Minister. I need to hear the point of order.
Sorry, Chair.
Chair, I just refer to the fact of being accurate in estimates and not misleading the committee about things that the Minister is so clearly doing.
The minister is under oath. He's already made us aware that he's very well aware of that requirement, and I'll allow him to continue his answer.
We're going to Chair and to the honourable member who knows this area of healthcare very well.
Thanks,
given
Minister.
her background.
So just to clarify, there was no indication from the former government, either the former Minister for Health or the former Minister for Regional Health, that they were only temporarily funding 1,112 nurses.
Who would temporarily
certainly-
fund nurses?
Order.
Listen to how ridiculous you
Mrs.
are.
Taylor.
No one was made aware to me and wasn't made aware to me that the previous government had communicated that with the with the
point
public.
of order, Chair.
And what they had communicated
Sorry.
Point of
was...
order.
I need to hear the
You
point of
guys
order.
are a joke.
The Minister seems to be referring to positions that we created and we funded, and then suggesting that they were
That's not a-
unfunded positions we created.
That's argument. That's not a point of order.
Sorry.
Minister.
I will explain it to you
Even the cameras have gone 'cause they know how
more
ridiculous
easily,
it
Ms
is.
Carter, and I will say this, that in the allocation of healthcare workers, I think the overall allocation of 10,000 odd, just for the purpose of the discussion, there was 1,112 of them.
What do you
From
say
a
to the
nursing
palliative care
perspective,
services that are
that
cut,
was
Minister?
from being cut from 1 July 2024, Ms Carter.
What do you say about your
So
palliative
I
care
don't
services
understand
that
what
you're
you don't
cutting?
understand about that.
And each of those 1,112 nurses are now funded permanently. Is that
Not in
correct?
palliative
it's
care, they're
correct.
not.
I ask Mrs. Taylor to please not interject.
And I'd just like to update the House around where those 1,112
Not in
nurses are based. 138.2 is in the Hunter, New England, an area that I know you love and have been a terrific advocate for. South Western Sydney Local Health District, that's 119.2, will remain in place. Western Sydney will see 109.1 remain in place. South East Sydney and Sydney LHD combined over 200 nurses. We've got Northern Sydney LHD, an area that I know the Deputy Secretary Deb Wilcox knows very well, 82 nurses. The Illawarra, Shoalhaven, Central Coast, Western New South Wales combined over close to 200 nurses there. Northern New South Wales LHD 51. In one of the honourable members' parts of the world, in Southern New South Wales Local Health District that I know she knows, 26.6. In Far West, that's an additional 6.5. And in Mid North Coast and Murrumbidgee combined there is around 85 nurses. So you can see whether it's in regional, rural, remote or metropolitan areas, these are particularly important that these positions remain in place, and that was something that we got cracking on not long after I was sworn in.
And Minister, how much was the investment for making these temporary nurses permanent, if you could update the House?
Well, it's hundreds of millions of dollars. I think close to $500 million here has been allocated. This is investment that was absolutely critical if we are to roll out our safe staffing reforms that you and others on this committee from the government have been tremendous advocates for on behalf of the communities where not only you reside but you may represent as a part of your duty electorates. This has been an important reform piece. It will be a reform piece that takes time because it's the largest reform that we've undertaken in the staffing of public hospitals for many, many years, but it is a reform piece that we need to get right, and we are going to make sure that we continue to work with the association and continue to work with our LHDs and our nurse unit managers, our district nurse unit dons. These are important individuals, and we'll continue to roll this out right across New South Wales.
Thanks, Minister. I'll now turn to a question about elective surgery. When you became the Minister, you made it clear that you were concerned with the number of people who have been waiting longer than clinically recommended for their elective surgery. How many people were on that list when you became Minister?
Yeah, over 14,000 were on that list, and actually on the first day, the Premier and I went to Liverpool Hospital and made it clear that we wanted to set up a task force examining this issue. I want to acknowledge one of the task force co-chairs, our Deputy Secretary Matthew Daly, who's in the committee and with us today. A tremendous amount of work has been put in to that task force by surgeons, anaesthetists, clinical nurses, those involved in the management of surgery across New South Wales hospitals, and we've been able to get that number down by half to 7,000. Now, I know Matthew Daly and I both want to see that continue to improve. We are not finished yet. As late as yesterday, I met with the task force again around trying to make sure that we continue to look at ways in which we embed some of these practices, including same-day surgery for some of the conditions that perhaps we would have done overnight for. We're going to continue to look at this area to try and make sure that we deliver world-class healthcare that is safe and effective, but at the same time we efficiently make sure that we're running our hospitals to enable people to get access to very important surgery that is life-changing, but is also is life-limiting. And that is very, very important to me as the Health Minister. We always will have a waiting list. I think people in the committee and those millions of people at home watching this today, I'm sure that you need to understand that there'll always be an elective surgery waiting list. What we do need to understand is the focus is on those that are waiting outside our clinically recommended time periods, because they're people who we really should have got to. And when we came into office, that sat at about 14,000. We've got that down to about 7,000. We've got more work to do, and I'm determined to continue to drive this reform.
Thanks, Minister. Thanks, Chair. Questions?
No further questions from the government? Okay. Then we'll be breaking for morning tea until 11:15.
Sure. Thanks. You can use all your time.
Being 11:15, we'll resume today's hearing and we'll start with 20 minutes of questions from the opposition.
Thank you, Minister. In December 2022, LHDs were advised by letter that there was $743 million available to them for palliative care funding for enhanced end of life and invited to plan for that. Has that figure been updated?
Well, can I say this, Ms Carter? I'm deeply troubled by some of the remarks this morning about misleading claims about critical funding for palliative care, something that is very important to all of us in this room.
And we can update that now. Has that figure been updated?
Ms Carter, I let you ask the question. I appreciate if you let me answer the question.
I would be delighted if you answered it, Minister.
The specific claims that palliative care services are being cut in places like Bulli, Western Sydney, Northern Sydney and Orange are untrue. It's critical that we as a committee and you as a committee member don't mislead the community, particularly about this important area of healthcare. I'm advised, and I'll inform the committee again, that there will be around 160 palliative care workforce increase this year. It's funded by that 6.8% increase, or $23.3 million. Now, I think that's important to clarify, Ms Carter.
Minister, I entirely agree. Thank you for the clarification.
I'm glad you agree,
what
'cause
would
you
be
didn't
good
agree
to
this morning.
clarify is the entire $743 million still available to LHDs?
What we've said all along around palliative care is that
Why
we
won't you
are
answer the
investing
question?
1.7. I don't mind how you
Thank you.
allocate the numbers.
Is the entire $743 million still available to LHDs? If it's not, by how much has that been cut?
The 2023-2024 budget, and this is budget estimates, includes, and I'll say it again, more than $1.7 billion
Yes,
over
you've
the
said that
forwards,
before. I'm
over the
asking you about the
forwards
$743 million.
palliative care.
The Premier acknowledged the cut.
Palliative
Why
care
are you
will
not
be-
able to acknowledge the cut,
Palliative care will
Minister?
be increasing the funding by about 6.8% higher than 2023-2024.
Stop reading the notes and answer the
and
question.
it'll increase again in 2024-2025.
Fantastic.
Thank you, Ms Carter.
And the $743 million that was to be made available to LHDs, how much of that, as at today, is still available to the LHDs?
Ms Carter, you and I may have different interpretations of numbers. I don't have the correspondence that you referred to because I wasn't in government, and it would most likely be inappropriate for me to access it, and I don't access the previous government's
So the Premier
materials.
acknowledges a
So I'm
cut.
going-
Some
I'm-
of your
because-
colleagues acknowledge a cut, but you don't acknowledge a cut?
What I acknowledge is the investment that we are putting into palliative care, Ms Carter, and that is what we will continue to focus on. And I, as the Health Minister, as have previous health and regional health ministers, understand that this is an important part of healthcare in New South Wales. We also understand...
It is an important part of healthcare.
We
Since
also
you've become
understand
Minister...
that we were 1,112 nurses short from 1 July next year. So I
a
would
question about
understand
those
that.
nurses, Minister. How many of those will be going to work in palliative care?
Of the 1,112, I'm not 100% sure on that figure.
Well, the Premier indicated yesterday that a number of those nurses would work in palliative care. How many
I'm
is
sure they are.
constituted?
Well, given it's a substantial increase. I mean, in some parts it's 60 or 70 people in LHDs.
So the Premier knows more about the allocation of those nurses than you do, Minister?
No, you asked me for a specific number.
Yes.
I think is that right?
No, the Premier indicated a number of those nurses would work in palliative care. As Health Minister, I'm asking you to tell us what the allocation to palliative care of that nursing staff is.
A number of them will no doubt work in palliative care. They'll work in maternity. They'll work in
But you're not
critical
sure what
care,
the
they'll
number
work in-
actually is.
They'll work in
And you're not
oncology,
sure what
but
the number that's actually been cut from palliative care is. Is that what you're telling this committee?
I think you're asking two different questions.
Okay. Are you sure the number of nurses allocated to palliative care, yes or no?
I've told you that we've increased the
No,
number of
okay.
palliative
Are
care.
you sure how much money is being cut from the promised allocation for palliative care, yes or no?
Ms Carter, I'm not sure you know what you're talking about.
Oh, come on. That's not.
Because
that's
I've explained
even
it
below
to
you.
I've explained it to you now multiple times, and
That's not.
you are not.
So
you're
the
not letting me
Premier
answer the
acknowledges a
question.
cut, members of your own party acknowledge a cut, but you claim there is no cut. All right. Since you've been Minister, what palliative care units have you visited?
Palliative care units that I've visited. Geez, I've visited that many hospitals.
Thank you. Which palliative care units
I can give you
have
a
you
list
visited?
of those because I don't want to mislead
take
you.
that on
But
notice?
I'll give you a list. Given that I'm in hospitals a couple of times, at times a week, and I'm doing unannounced visits,
I'm happy for you to take that on notice.
visited
Happy
that
for
many
you to take that on
hospitals and that
notice.
many different units. It's
Happy for you to take that on notice.
sure.
Minister, on the 4th of August, you said, and I quote, "The New South Wales Government is committed to ensuring people with life-limiting illness across Western Sydney receive the highest quality end-of-life care to provide peace of mind when these patients need it most." Couldn't agree with you more.
Thank you.
Minister, given that the cuts from the money promised in 2020 have cancelled 10 dedicated palliative care medical staff from this region, will you admit that you have lied to the people of Western Sydney? And will you apologise to the people of Western Sydney who will now die in pain because of these cuts?
Ms. Carter, I think your comments are bordering offensive and disrespectful. So I ask you to be cautious about your comments in the
Minister,
order,
I
Chair.
think it's
Yes,
disrespectful to the people of Western
Order.
Sydney
I need
not
to
to
hear the-
recognise their health needs.
I need to hear the point of order.
Point of order, Chair. The Minister cannot make disparaging remarks against members of this committee like that. That was judgmental and sarcastic and completely out of order.
Well, to the point of order, I think it's been well canvassed in previous remarks. Some of the remarks accusing the minister of such, quite personally affronting
It's not a
things.
point of order.
No, well, if you'll let me finish.
On the point of order, I agree that the Minister's most recent comment was less respectful than it should have been, but also that many members over the course of this morning have asked questions that are containing argument and also disrespectful. So I ask all members and the Minister to please try and discuss these very sensitive issues with
Thank you,
respect
Chair.
and professionalism, please.
Thank you,
Susan
Chair.
hasn't been
And
disrespectful.
I wasn't, from my perspective, being disrespectful. What I was saying is that all of us need to be mindful of our remarks as public figures and community leaders. And palliative care is a very sensitive issue to people.
That's why you don't
What
cut
I
it.
said this morning was that I was concerned with some of the remarks made about cuts in Western Sydney, cuts in Wyong, cuts in places like Orange and North Sydney, when I've clearly outlined that that's not the case. So, Ms. Carter, what
Minister.
I'm saying is that we as political leaders and community leaders, when we are talking about healthcare services and issues that are near and dear to the hearts of many people, particularly vulnerable people, we need to be careful of our remarks in this space.
Minister, you are saying that there is an increase and a record budget because we committed to that in the 2022-2023 budget. You have reduced that by $150 million, and that means LHDs are getting less than was committed in the 2022 budget. How is that an increase in spending?
Okay. So I'm going to try and go through this, Ms. Carter, line by line, so that we are clear and that we have an understanding of one another.
1.85, 1.7,
if
150 million difference. We
Point of order.
understand the
Point
line
of
by
order, Chair.
line.
I need to hear the point of order.
Quick.
Continued interruptions over the top of the minister while he's attempting to answer the question are utterly disorderly and discourteous.
And continued refusal to actually
Order.
address the issue
Order.
is disorderly.
Order. Please don't argue with each other. Your comments need to be directed through me as the chair, and I'll repeat my earlier reading from this morning. Members can interject, but please at least let the minister get through the first sentence.
We are increasing the funding by around 6.8%. We're also boosting frontline staff in the palliative care space. We are boosting infrastructure across regional and rural New South Wales. And yes, particularly the former Minister for Regional Health, this was a passionate issue that she shared, no doubt, with her community and the government, and that is why we are continuing to roll this investment out.
For the money.
Palliative care services are important.
Minister.
So is securing the employment of 1,112 nurses to ensure our health and hospital system was sustainable, and that we
Minister.
were able to introduce reforms that improved the health and hospital
Minister,
system.
did you propose to the ERC to reduce the funding allocation to palliative care that was committed to in the 2022 budget?
Well, Ms Carter...
Who cut it?
Ms Carter...
Because if you didn't propose it...
Point of order.
Was it...
Ms Carter, with the greatest respect, you would
I
be
need to hear
asking
the
me
point of order.
to participate in illegal activity if I talked about cabinet discussions. That is something that I'm not allowed to do. So, whilst I understand the importance of this committee, I'm not about to commit an offence. I don't think your
I would not
ministers-
want you to commit an
I don't
offence,
think your
Minister, so let's
ministers
move on to
ever
a different
talked about
area.
discussions in ERC.
If you're not comfortable talking about who proposed the cuts, we
I'm
can
very
move on to a
comfortable
different
talking
area.
about
Point of order.
I'll
I
hear
just
the
don't
point of
want to
order.
do
The
things
minister
that are illegal.
can't.
Yes,
Excuse-
happy to move on.
Excuse me.
Happy to move on.
I'll need to hear the point of order.
I think she knows what she's talking about.
Order.
My point of order was only going to be the minister cannot answer a question that is not a lawful question.
He's made that clear in his response. I'll go back to questions.
Minister, you would be aware that Western Sydney has the highest population of Indigenous people outside the Northern Territory.
Yes, I think Mount
How
Druitt is
many-
one of the highest, I think,
is.
individually, I think, from memory.
How many Indigenous palliative care workers are available to care for this population?
I'll take that specific question on notice.
I'm happy to answer it for you. There is one worker at Mount Druitt.
Well, why did you ask me the question for?
Because I wanted to establish,
Oh.
as Health Minister, whether you understood the special needs of the population in Western Sydney,
Of course I do.
culturally and linguistically diverse, with a high level of Indigenous people, all of whom approach death differently because death is it's a very culturally sensitive time.
Yes.
With the additional funding that had been flagged in 2022 that the LHD had planned for, additional Indigenous workers to help people in palliative care had been planned for, as well as people from culturally and linguistically diverse backgrounds. How many of these will now be available for the people of Western Sydney in palliative care?
Culturally appropriate palliative care and culturally and sensitively appropriate healthcare across New South Wales is something that is critically important. It was, I hope, important to the previous government. It is important to our government that we continue to improve this.
And it was so important to the previous government that additional funding was allocated to enhance palliative care, especially for these communities. It's my understanding that close to $70 million of that enhanced funding is no longer available in Western Sydney. Do you understand the impact of these cuts on culturally diverse communities, on linguistically diverse communities, on Indigenous people in Western Sydney? What your cuts will do as they die.
You didn't want to cut it, Minister,
Ms
did
Carter,
you?
have you finished your question? Okay, so let me answer your question again. My advice from New South Wales Health is we're not making cuts in palliative care in Western Sydney. Now, I'm going to go through again. I understand your inference about culturally appropriate care. I get that. I also understand that it is not just important in palliative care, it's also important at the other end of life around birthing, which is why we're investing in places like Wominda and birthing on country services. So, Ms Carter, I think respectfully, everyone in this room has an understanding that we need to do better when it comes to culturally and linguistically diverse communities and our Aboriginal community. I certainly understand that I need to do better and this government needs to do better. I hope that successive governments continue to have the same focus so that we can reduce the gap in some of the healthcare outcomes that these people experience. But in relation to palliative care, my advice is that in relation to Western Sydney, we're not making those cuts. But
the Premier
we're making
acknowledged
comments
yesterday, the Premier has acknowledged previously, $150 million of the enhanced funding for end-of-life care is no longer available because of budget cuts. About 70 million of that has gone from Western Sydney. Now, you would recall the cuts to Screen New South Wales and Made in New South Wales that were reversed by your government. Approximately the same amount of money. So why is it that money can be found for filmmakers but not for the dying people of Western Sydney? Are filmmakers more important than the dying?
Ms Carter, I think you would agree that your last comment was inappropriate. I hope you would agree that.
No, I am shocked, Minister, that these budget allocations have been made. I'm shocked that money is taken from palliative care funding, especially directed towards vulnerable
I need
communities.
to hear the point of order.
Oh,
Like that.
there wasn't a question there, it was just a series of
Yeah, I
statements.
agree. I'd ask the member to have a question and not just a comment.
My question is, do you understand the impact of cuts on Indigenous communities facing death in Western Sydney?
Well, I understand the impact that 1,112 nurses and those being cut would have had on the community right across New South Wales. That's pretty significant and something that your government, when it was in power,
But you can't tell us
didn't
how many
outline.
of those nurses will be working in palliative care, can you?
Well, there'll be a number working in palliative care.
Number.
Yes. Well,
Unspecified. We need detail because local health districts need to be able to plan for how they care for the dying. In terms of planning, the 24 beds that are going from St Joseph's, where will they be going to?
Well, I'm glad you talked about St Joseph's, Ms Carter, because it is something that my colleague and our Deputy Secretary, Ms Wilcox, has been working with St Vincent's on, and I've also had a number of discussions with them about this. You would be aware that they made the decision, that's important, to decommission St Joseph's.
I'm asking where they're going, Minister.
Well, through you, Chair, I'm answering the question appropriately and respectfully. This is an important question and I'm doing so.
Continue your answer.
Continue. St Vincent's and Western Sydney Local Health District have agreed that the health services at St Joseph's Hospital will be transferred to the Western Sydney Local Health District to ensure continuity of service, Ms Carter. The transfer to Western Sydney Local Health District will take effect, aiming to take effect on 8 November 2023, and all health services will be provided at either Auburn Hospital or Westmead Hospital. And I would be advised that there'll be no loss of health services to the New South Wales community, including to communities in Western Sydney as a result of that. Now,
So you're confirming all the 24 beds will still be available?
Well, what I've just said to you is the services that will will be moved over to the public system. I'll get Ms Wilcox to
Can I
add
ask
any
you one
further
more question
information.
about those 24 beds?
Well, could I
Can I ask the question first? Will the 0.8 medical support for those 24 beds also be transferred across? Or has that position been made redundant?
No, my understanding is that those services will move across, but to make sure that I'm giving the committee full and complete answers and that we don't have to waste time on taking things on notice, which I prefer not to do, because of my respect for the committee process, I'll ask Ms Wilcox to add any further information.
Look, I'm happy for you to get advice, Minister, but as Minister, I would hope that you could answer a direct question. Or perhaps you're embarrassed about what you're having to tell
Point
us
of order,
about
Chair.
palliative care.
Yeah.
Point of order. The Minister
I
is
appreciate the
entitled-
point of your last comment was not respectful, Mrs Carter, and I would repeat that the Minister is entitled to seek clarification from the department witnesses.
Thank you, Ms Carter. I provided a detailed answer, and to add to the detailed answer that I would do, given the importance that you place on such a topic and the importance of, no doubt, that this is to the people of Western Sydney, I'll ask that our Deputy Secretary add any further information that can increase the understanding for the committee around what is happening at St Joseph's.
Thanks, Minister. Thank you, Chair. The Minister is correct, of course. There are 39 beds currently at St Joseph's Hospital. They're made up of 24 palliative care and rehabilitation beds, 11 older persons mental health beds, as well as 4 beds for Huntington's chorea and motor neuron disease. I can confirm that all of those beds will be transitioning across to Westmead and Auburn hospitals. All of the staff who are currently caring for those patients in St Joseph's have been offered positions in Western Sydney Local Health District. There are a very small number
Can I ask, if one doctor has decided that they're not transferring, is that position to be filled by somebody else, or has that position been made redundant?
There are some positions, I can't speak to that particular position.
Are there any positions which have been made redundant?
Not to my knowledge. The decision for redundancy
Could you perhaps take that on notice?
I can add, if I may, Ms Carter, the issue of redundancy is a matter for St Vincent's Hospital.
Perhaps we can discuss that this afternoon. I have one last question for the Minister.
Thank you, Ms Carter.
Minister, it's not too late to apologise to the people of Western Sydney about these cuts. Will you apologise?
Ms Carter, I'm not going to apologise for making record investments in palliative
So
care.
you're not going to apologise, Minister, for the cuts to palliative care funding?
Ms Carter, if you're asking me, do I have a very high expectation of myself and my department to deliver the very best healthcare services for people
You
across
wouldn't
New
have cut
South
it,
Wales?
the Premier did.
The answer is I do, and I will continue to make sure that we do our very, very
Premier
best
made you do it.
to do that.
The opposition's time has expired. Ms Abigail Boyd.
Thank you very much, Chair, and good morning to you, Minister,
Good morning, Ms. Boyd.
and to all of you. The unions this morning marched on Parliament House in relation to the ban on manufactured stone, trying to get your attention. Did they get your attention?
Well, I think you would agree that I'm someone who engages deeply with the workforce. That is something that I'm very proud of. The rights of working men and women is something that is near and dear to my heart. This issue is very, very important. This issue is largely a work safety issue. We make some reporting when we find incidents or illnesses into that system. And I know that that is something that other cabinet ministers are examining and looking at. Certainly the Minister for Workplace Safety as well as the Treasurer has something in this, has been a long-term, someone who's had a long-term interest in this, but it is something that we report into that process. But I'll get Ms Chant to add, just in case there's anything that she would like to add to that
So
answer.
we receive the notifications and we forward those to Safe Work for investigation and appropriate regulatory activity. And as the Minister said, it really sits within that work safe.
And I understand that, but I guess the frustration that I have and that unions have is that New South Wales is taking has been taking a position to the National Cabinet that is very much in line with industry and not in line with what the workers want and need. As the Health Minister, and given that silicosis is a health issue, have you been advocating in Cabinet to change that position so we get a ban in New South Wales?
Ms Boyd, I'm not allowed to talk about Cabinet deliberations, but I can say that this is an issue that has been discussed and is well known in varying different aspects of government and within individuals within government. What I've tried to say this morning and outline respectfully is that I understand that it's a health issue, which is why we report into the process that the government, the statutory process that is set up through WorkSafe and WorkCover and organisations like that under the Minister. So I'm happy to explain that further, but that is where our role is. But if you're asking me, am I concerned about people who present with this, I think everyone would understand and should be concerned, no doubt about that. But the actual regulatory regime and the operational regime that sits around this and the implementation of change that sits around this sits with other colleagues of mine in the Cabinet.
I'm sure you understand and have seen the science that shows that there is no level of silica dust exposure that is safe, and yet Caesarstone has been putting out advertisements and other misleading information saying that actually 40% level could be safe. Given as Health Minister and given that the unions are looking to you for leadership, are you concerned that this misinformation is being delivered in relation to a health issue in New South Wales?
Well, I don't like misinformation on any issue. I think that's problematic on any issue. It's particularly problematic if it relates to health issues. I'm not referring to this particular issue because I haven't examined it, but I do want to say that we've got a very big capital project. We do a lot of building in New South Wales Health, substantial amount under the leadership of Rebecca Walker and the team at HI. Our building projects have stopped using engineered stone and our guidance around this has been updated. So I wanted to give you an assurance that this is an issue that internally we take seriously, but the regulatory framework around this sits with a different ministerial colleague of mine.
And I understand that, and I understand that there's a couple of different issues here. The stone benches, which is the very easy one, which is the one that Caesarstone has a direct sort of interest in the profits of, and banning that is very different to the huge amounts of construction and exposure that workers are also having in tunnels and in other places in relation to construction projects that New South Wales is overseeing. There is a massive issue here, and what we have been told is that the screening for silicosis in this state is not of the same level as other states. Will you be intervening to ensure that there is better screening and treatment given to those workers who are really suffering with silicosis in this state?
Well, as someone who's the health minister, if we can make improvements in a particular area, whether it's screening, diagnosis, treatment, care, research, I'm certainly interested in looking at ways in which we can improve the delivery of healthcare services and the screening of those services. I don't want you to think in any way that we're not focused on that. As the health minister, of course I would be.
Yeah, and you can understand the frustration of the unions and the workers when they're not getting the policy response that they want out of your government on what is a health issue. What commitment can you give to the unions today that you're listening to their demands?
Well, I can give the commitment to the unions that I'm listening today as I'd listen to them on a range of different issues. I'm someone who's very proud of the fact that I engage pretty much on a weekly basis with the unions who represent working men and women in my portfolio areas, whether that's the HSU, the Nurses and Midwives Association, ASMOF or others. And we are taking this issue seriously. We'll continue to make those reports. We'll continue to make improvements internally in terms of the materials that we use. And I can give you an assurance that if we can look at improving what we are doing in relation to screening, then we will examine that. I can't give you a definitive answer as to what and when that means, but I can give you an assurance that New South Wales Health continues to look at what other jurisdictions are doing in this and other spaces, and we continue to make sure that we're delivering world-class healthcare.
We're falling well below the other states, though. When it comes to screening, our methods of screening are not as robust as our neighbouring states. We are reporting a third of what experts believe we should be reporting if we're using the right monitoring. That means that there are a huge number, hundreds of workers, potentially with silicosis who don't know about it and are not getting the care that they need. Are you committed to not only ensuring that they get the care they need, but also preventing more workers from getting silicosis by putting a ban on engineered stone?
Well, we've already said what we're doing in relation to New South Wales Health projects. We'll continue to work with unions, we'll continue to work with industry. I'll refer to Dr. Chant in a moment, just in case there's anything she can add to this. But I want you to understand, and the committee to understand, that of course this is an emerging health issue that we are concerned about, as has other health issues over the decades where governments have had to take leading roles in. We will continue to look at this, we'll continue to work collaboratively and to make sure that we're delivering the very best and making sure we're doing our best as governments to keep workplaces safe. Dr. Chant, did you want to add anything else?
I think it's clear. We've outlined our position, and we just note that some of the screening is really linked to at-risk workers, and so again, very much in occupational health and safety. And obviously, New South Wales Health supports robust occupational health and safety screening and appropriate follow-up.
Silica dust is the asbestos of the 2020s. We are looking at what is going to be a huge number of people accessing the health system in order to get help. I'm a bit concerned that the health department is not taking more of an active role in relation to this issue. Will you take a more active role in relation to this, Minister?
I think we are taking an active role, Ms Boyd, but if you're asking me, does health continue to look at emerging health issues and work out how we can improve our treatment, preventative strategies, research and care, that always happens, and that is an expectation of mine, as I'm sure it was an expectation of other ministers from other governments. I think the community would always expect me as the minister to be looking at ways we can improve our health services particularly to working men and women, and the engagement that I have with unions across my portfolio is extensive, and I'll continue to do that. And in relation to this issue, I will continue to look at ways that we can play a role to providing healthcare and preventative health in this important space.
Thank you. Just in the short time I have left, just
Yes.
one question. Obviously, the Disability Royal Commission handed down its report just recently, and one of the recommendations is in relation to the treatment of people with intellectual disability within our health system. What will health be doing to ensure that people with intellectual disability are receiving more comprehensive and accessible health care, particularly primary care?
That is important. I've met with a number of disability groups. I know that the Minister for Disability Services has done some work in this space as well. At a district level, we are continuing to engage with disability groups across the board to make sure that we improve the level of healthcare that we provide them. I've made it clear in a number of discussions that this is an important piece of work. You are right, we need to do better in this space. I'm confident that through the Secretary, local health districts understand that is important. I probably want to add that you are right in saying that it may be different for different disability groups depending upon what that is, which is why I've said and made clear to health that we need to be having some deep engagement with these groups, making sure our staff are appropriately trained, and making sure that when these individuals come into our service, that we are providing a level of care that meets their needs and are informed by both themselves, their carers and their support network about how we can do that better.
Thank you.
The Honourable Tanya Mihalich.
Thank you, Madam Chair. Well, good morning, Minister.
Good morning, Tanya.
Just a quick couple of questions from me. Have you had a chance to review local health advisory boards since the protocols around the people that are selected onto those boards since you've become Minister?
Do you mean our LHD boards,
Yes.
Tanya?
Yes.
Yeah, government is going through a process at the moment of reviewing boards across the entire government. We are having a look at them at the moment to try and increase a little bit of diversity amongst our board membership because I think it needs to be more representative of the communities in which they serve. So we'll continue to have a look at that. Yeah, hope that.
Will you evaluate how many, or do you have any, or have you to date evaluated how many of those members are actually third-party lobbyists or registered lobbyists?
No, but I understand, and I'll ask Susan to jump in here or another DepSec to jump in just in case that they need to add to this. I understand there's a stringent process that board members go through as part of appropriate governance disclosures that they need to comply with in relation to being on boards. I don't have an exact answer or exact number to what you're saying, but Susan, did you?
Happy to start that, Ms. Mihalich. Their board members are required to complete conflict of interest disclosures.
So they have to complete a conflict of interest if they're a lobbyist. They have to make that clear that they're a third-party registered lobbyist.
I would think that
is that something you ask?
That would be reasonable. That anyone
does that
who was
rule
a
them
lobbyist
out or prohibit them from being a member?
I might pass to Mr. Minns to see if he's got anything further to add. But
We could take that on notice. You may
any
not have the
conflict of
answer now.
interest that a board member would have would be assessed in respect of those
Who's
appointments.
the chair of South West Sydney Local Area Health Board?
Sam Haddad.
Sam Haddad.
Yeah. Do you have a specific example you'd like to give me, Ms.
No,
Mihalich?
I'm just asking. So are there? I just want to know whether there are currently any lobbyists or third-party lobbyists on any of these boards.
Could you further elaborate what you mean by that?
There's a register list of lobbyists that New South Wales has.
Mhm.
I want to be confident that any member, that's any CEO or chairman or member of or staff member of a registered lobbyist company isn't a member of one of these committees?
Well, they'd have to go through the governance procedures and the disclosure of
It may not
conflicts
rule
of
them out,
interest.
Minister. I just
Yeah.
want to know whether it
Yeah.
does or doesn't. It may
Yeah.
not. And if it doesn't at this stage, will the government look into ruling out lobbyists, particularly lobbyists who have an interest in health infrastructure and where health infrastructure goes in New South Wales,
Yeah.
that they be ruled out from being members of these type of committees?
Look, what I will say is we'll continue to focus on making sure that our boards are robust as possible. They're representative of the communities in which we serve. They have stringent governance requirements around them, as you would expect from any government board, and that's where we'll continue to focus.
Minister, where will Bankstown Hospital end up being?
We'll identify a site, and when that site is identified, we'll make that public. Can I make it very clear, though, we are taking the advice of Health Infrastructure in relation to this, and I've had a number
Will we
of...
be taking advice from South West Sydney Local Area Health Board?
I've taken a number of discussions with Health Infrastructure about this. Advice comes in from many sources when you're a minister, but the advice that I'll be listening to in relation to the location of the site, and I want to be clear about this because it's important to me, will be from Health Infrastructure, and that is important going forward.
The former government made an announcement on the 3rd of February that they would have, that the site that they would, if had they been elected, they would have built Bankstown Hospital across the road at Eldridge Road. And they also announced on the 3rd of February a clinical services plan. Has your ministerial office or yourself or any member of your senior executive here in the department had any discussions with Bankstown Senior College?
Bankstown.
Senior College, which is the site that the former Premier announced the hospital would be.
I don't think I've had. I don't think I've had, but Miss Warp from HI.
Thanks, Minister. During the site selection process, there were a number of discussions with Department of Education and Schools Infrastructure in relation to a number of sites which were being considered.
Okay. I asked the question, sorry, is that, have I got 5 or 10 minutes?
That's your time expired.
How much time was I given?
There was 5 minutes. I would have, if it is a follow-up just on this topic, I'll allow one more.
Have you, Minister, had any, has the Premier had any direct discussions with you about where he would like Bankstown Hospital site to be?
I'm not aware of that.
He hasn't discussed with you at any time in your time as Health Minister where he would like Bankstown Hospital.
I'm certainly not aware of that, Ms Mahalik, and I want to be clear about this because it's important to me and I hope it's important to the committee. The advice that I'll be taking around Bankstown, the future redevelopment of that hospital, which I know is something that is very important to you, I understand that, and I know you've advocated in this space for a sustained period of time, and I acknowledge that. But the advice that I will be taking will be that of Rebecca's team at Health Infrastructure. I hope you understand that that's my job is to make sure that we are following a process, and the advice that we're taking is from experts. The experts who advise me are located in Health Infrastructure, and that's where I'm going to be focusing on. When that announcement will be made, it will be obviously be backed up and recommended by experts within the infrastructure space that exists within HI.
In the last 2 minutes of crossbench time, I'll ask a quicker one. Meningococcal meningitis is an incredibly severe condition with high fatality and lifelong complication rate. With cases on the rise and no clear indication from the federal government to add meningococcal B vaccination to the national immunisation program, what action have you taken, Minister?
Well, I think it's a very good question, and it's an issue that has concerned me for a bit. I've made a number of representations. I've made representations to the Commonwealth Government about seeing if we can get this on the NIP, or the National Immunisation Program. This is an important area, but I think that it can become problematic if jurisdictions go around that National Immunisation Program schedule. At the moment, I know the Commonwealth is no doubt looking at this and examining this. We are in New South Wales Health doing the same examination. We don't, at this stage, have a plan to fund that from the New South Wales Government perspective, but the committee should understand that it is an area I'm looking at closely. Dr. Chant is also looking at this area closely. We are looking at trends both in terms of vaccines or emerging vaccines that may be able to look at a range of different conditions, but we are also looking at trends in terms of number of cases. We do know that there are other jurisdictions who have gone it alone. I understand that, Dr. Cohn, but at this stage we are taking a more nationalistic approach, which is through the NIP. We've made representations through that, but it is an area of public policy that we are looking at carefully. I've had a number of representations from individuals and family members and community groups and advocacy groups impacted by this. That's why I've raised it formally in correspondence with the Commonwealth, and it'll be an area that we continue to discuss within the New South Wales Health team led by Dr. Chan.
Thank you. I'm out of time. To the opposition.
Thank you very much. Minister, this will be the last time that I ask this question, but will you commit today to restoring the $150 million in funding that you've cut to palliative care? Just a yes or no, and then I'll move on.
I'm committed to rolling out the $1.7 billion in palliative care funding.
Thank you, Minister. I'll move on. It's disappointing, but Minister, on the 27th of June 2023, you met with Tanya Thompson, the member for Mile Lakes. You told Tanya Thompson that Foster is safe. So why do you say now, and what do you say to the community of Mile Lakes, that you have taken Foster out of the budget?
Well, I won't refer to private discussions I have. I don't recall that, but I in respect for that member of Parliament, as I hope people
The member's very clear on her recollection.
As I would hope members of Parliament respect if I have discussions with them, I won't be making those discussions public. I think that's reasonable.
So you deny saying that to the member?
I don't recall ever saying that. But in relation to Foster, we understand that it is an important project. The work hadn't been done in relation to the planning and the clinical services planning around that site. Ken Konofsky did a review of infrastructure across the New South Wales government sector. We have decided to pause, not scrap, but pause on that project at the moment.
So, Minister, are you saying that you're pausing because it wasn't ready? Because I would be very careful, knowing my previous history with that, about where those negotiations were up to. So are you saying now that you're pausing it? Because the $20 million allocated in the 22-23 budget, what has it been repurposed for and where has it gone?
Let me just finish. So that the infrastructure review that Mr. Konofsky did looked at projects and where they were in the forwards and in the implementation phase. It was a project that I think you would agree was not at a stage where any detailed funding, design, significant planning had been undertaken. What those decisions were made on was a number of factors, and I'll just want to go through them for the honourable member.
Well, no, Minister, in the interest of time, I'd just like to say, after cutting this hospital, cutting Foster, when you told the member you'd do it, when it was in the budget, how are the people of the Mile Lakes electorate supposed to believe that you will remain committed to the Manning Base Hospital?
Well, because I am committed to the Manning Base Hospital. I'm very committed to making sure that we deliver healthcare services and infrastructure across rural, regional and remote New South Wales. Like you, it is something that I'm very, very passionate about. In relation to Foster, at the time, in relation to the project readiness, there was concerns around there was minimal clinical service planning undertaken for that project. No site had been acquired for that project. The detailed scope for the hospital had been finalised.
Okay, thank you, Minister. Thank you for that. So why did you not, if you're so committed to Manning and the people of Manning, why did you not allocate additional funds to the hospital in the budget?
Because we're continuing to roll out the program of works around Manning that was committed and budgeted for. I think
so. There was $100 million budgeted for Manning.
I think the honourable member would agree that we have seen over the last probably 2 years, I know your government experienced it, significant escalation costs around projects. I think that's a fact that we would all agree in. We are having some challenges, and I'll ask the Chief Executive Officer of Health Infrastructure to add, but we are having challenges at the moment, as is any public utility and public infrastructure.
Yes, I understand, and you're completely right, Minister, and I understand.
that.
Thank you for that. So you're not having Foster and you're not putting 100 million into Manning, you're just doing the 4.6. So
No,
can I
the
just
100
ask
mi-
you,
no,
and I'll just move
no,
on,
the
thank
honourable
you,
member,
Minister.
that's not
At
right.
the election,
Chair, I
Labor
need to-
promised...
Point of order. Point of order.
Order. The Minister wasn't actually given a single second to answer that question.
Chair, I respectfully need to say
Okay.
that
I have limited time,
the
Minister.
$100 million for Manning Hospital Redevelopment Stage 2 project will continue. Will provide patients, carers and staff the new modern hospital that was planned for and to meet the needs of that community. We're continuing with that project. So I
It's
just
not on
want
the budget.
I just want to make sure that that's
Yeah, it's
that's
on the
how I-
budget. So, Minister, at the election, Labor promised an additional 500 paramedics for regional and rural New South Wales. What have you done to ensure that all 500 paramedics will be placed in the regions?
I didn't know this was the time for Dixes, but look, the issue around regional paramedics is near and dear to my heart. It was a significant election commitment, one that the Commissioner and I are working on literally as we speak. Those will be dedicated to regional, rural and remote. They won't be going to places like Newcastle, Wollongong and Sydney.
Thank you, Minister. You've answered that question, but I just say in letters to their constituents before the election, Joe Halen, Chris Minns and Marjorie O'Neill, amongst others, promised to deliver some of these 500 regional paramedics in their own electorates. So why would the members for Summerhill, Cogra and Coogee claim this? So are you stealing health resources from rural and regional New South Wales and redirecting
I need to
them
hear the point of
seats in
order,
Sydney?
please. I'll hear the point of order.
Okay. That is a very difficult question for a minister to answer without that document.
Oh, you know
being-
it's
being
there. You know
tabled,
that's
so
what
to-
they did.
Further to the point of order, there's some quite significant allegations of improper motives, imputations of improper motives in that, and I'd ask you to ask your
I'm
Honourable
happy
to
to
withdraw
table
that
the election.
about stealing. I think it's
I can't.
I will rule the question out of order, but accept that those documents may be tabled if you've got them.
I'm happy to table it. I just want to know why they said they were going to have the 500 paramedics when you said they would be. I have absolute faith that if you said there'll be 500 paramedics for the regions, I believe you, Minister, I really do. But why then would they have put those out before the election?
Well, I can't comment on individual remarks. All I can say is that as the Minister and as the Minister for Regional Health, this is something that's really important to me. It's something that's important to Commissioner Morgan. It's something that the Rural and Regional Health Inquiry identified as problematic in terms of access to emergency care services in the bush. This is a pretty landmark investment and one that needs to happen.
Yeah, and thank you. And I note that. And as I said, I note how genuine you are, but those members put out those comments and we all know they did. So ahead of the election, Labor pledged $70 million for 3 regional helicopter ambulance bases. Did these costings include operational fees?
I'm sure all of our costings were put forward through the Parliamentary Budget Office. As a part of the budget preparation, it did work through issues around healthcare and resourcing and infrastructure. So we've worked through that in the budget, and the budget's outlined where we're going forward in relation to that. Sorry.
Minister Parker, no, it's all good. It would cost more than $150 million to run these 3 bases over 4 years. So how do you propose to operate these bases, having budgeted just a fraction of the cost?
Well, we'll continue to make sure that when they are brought online, they're adequately staffed and resourced. That's what I'll be doing.
Okay.
I'm not going to be opening bases with no staff there. The honourable member, I don't think would expect that.
No, I don't. That's why I don't understand how you can't budget the right amount for it. That's why I don't understand it. But thank you for answering the question. Minister, can I ask you about something that's really close to my heart? The Wellness Health In-Reach Nurse Program of about, I'm hoping
Is
there's
that the
100.
school nurses?
The school nurses, yes, that's right.
I know that's not what their name is, but that's...
I know. Well, that was, someone insisted we call it that, but let's call it the right thing, Minister. So the WIN nurses, which are the school nurses. And so that funding will run out next year. I've spoken to many of those nurses who have contacted me. They love their jobs. They've had the evaluation that says final evaluation on it there. It is overwhelmingly positive. I'm really proud of these nurses and the job they've done. Are you going to continue the program?
I want to acknowledge the work in this space. In fact, in the last couple of weeks, I've had a look at these nurses in some detail. I understand that as of 12 October, we've filled 98 of the 106. So that's, I wanted to update you on that because I think you may have asked me something formally around that, and I asked my department just to come back and give me an update on that.
You read me well, Minister.
That's okay.
Are you going to continue the funding?
We're certainly, the program's going to be will be evaluated, and we'll have a look at that evaluation. If it's as good as what you're saying it is, Honourable Member, then I'm confident that we will continue good programs in New South Wales Health that deliver good outcomes, regardless of where they were established. I hope that's the case. When,
Minister Park, everyone's going to think we get on too well in a minute. Now, Minister Park, I need to draw your attention to this document from the New South Wales Ministry of Health, dated 22nd of December 2020. It is my favourite document that I've ever had, Minister, and it actually says evaluation and it actually says final. Minister, I need you to commit for these 98 nurses. What a phenomenal effort that is, and not my effort, that's the effort of New South Wales Health and those nurses that have done that work. They need a guarantee that their jobs will continue, or I know and you know that what will happen is they know those jobs are expiring and so they'll start to look for other things. So I would like a commitment today that any nurses that are going on leave will be replaced, and that these WIN nurses, this amazing pilot and program that New South Wales Health did, is going to continue post-June. Those nurses need to know.
Yes, so Honourable Member, I, as I'm sure you did, as I'm sure Minister Hazard did, spend enormous time reading advice that comes up to me. I haven't received that advice or that report yet. So respectfully, I just want to make sure that that I'm across it. Well,
what I'm
as
trying
I understand,
to say
the final report, or the interim report, is November 2023. I should be receiving that, and we will examine that. I understand the program. I think it's an important program. If it's continuing to do good things to deliver healthcare in New South Wales, then certainly we will be looking to fund those programs going forward. But I need to have a look at that evaluation myself.
Thank you,
respectfully.
but I'll table this for the committee. It says final document evaluation. And thank you very much for that, Minister Park, and I will give you my absolute word that I will be following this very closely.
I know you will.
Hand over to my colleague.
Thank you, Minister. In January 2020, you stood outside the Sydney Children's Hospital at Randwick with your colleague, the member for Coogee, and your federal colleague, the member for Kingsford Smith, welcoming the former coalition government's decision to return full cardiac services to the hospital. Do you recall this?
If you said I was there, Miss...
Facebook is a wonderful thing.
Deputy Chair, then I'm happy to continue the line of questioning. I don't mind.
Thank you. Well, that decision was announced following the Richard Henry review of December 2019. Are you aware of the review?
Yes.
And you would be aware perhaps that recommendation 34 of the review states that the Secretary of Health makes it clear that both the Children's Hospital at Westmead and Sydney Children's Hospital will be comprehensive specialist children's hospitals with tertiary and quaternary services on each side. Do you remember that recommendation?
I'm sure it was there, Ms Carter.
Thank you. Yeah. And you recently wrote to the chair of the Senior Medical Staff Council at the hospital to inform them that medium complexity surgery, including cardiac bypass surgery, will no longer be performed at the Sydney Children's Hospital at Randwick. Have you backflipped on your position?
No. Let me sort of spend at least a little bit more than 10 or 15 seconds taking you through this process. I think this issue should have been resolved earlier in terms of the previous government, but the reality is decisions slip into next governments, and it's a decision that I'm accountable for and I made. And I did so on the basis of the best advice. We are continuing the existing arrangements which have been in place for some years now, including under the previous government. These are based on the weight of evidence and expert advice from clinicians, consistent with a number of different reports and findings, including the recommendations from the 2020 Paediatric Cardiac Services Model of Care Panel, which was independently chaired by Professor Willis Marshall, Chair of the Australian Commission on Safety and Quality in Healthcare. Also, the Paediatric and Congenital Cardiac Council of Cardiac Surgery of Australia and New Zealand, in a letter to former Health Minister.
I appreciate the detail. I think what we're really looking at is the decision's been made to remove these services.
I'm going through the
that.
decision. You referred to a submission. I'm going through you through
Oh no,
the reason I've
I
taken
appreciate
these
you would have had
decisions.
reasons for that decision. I'm
Okay.
just confirming that. And are you aware of the mayoral minute moved on the 24th of October by the Mayor of Randwick Council to write to the Premier and to yourself to request that the government restore and maintain an appropriately funded paediatric cardiac surgery program at the Sydney Children's Hospital?
Deputy Chair, I haven't seen it, but I've been made, I think, aware of this. Respectfully, running a health system the size of New South Wales Health mean that I may not be on top of Randwick Council mayoral minutes.
I can understand that, Minister.
I've never been one to perhaps focus too heavily on local government, Deputy Chair, so if I have missed that mayoral minute formally, then I apologise, but the role I have at the moment is a fairly substantial one, and
I appreciate that, but you've indicated that you were aware of that minute. I'm just wondering whether you or I, perhaps somebody from your office, since you're so busy, have a conversation with Councillor Dylan Parker to move a rescission motion yesterday to prevent this motion from going ahead.
I'm not aware, but I can take that on. I haven't spoken to Mr. Parker about it, but
Minister, would you think it was appropriate for a ministerial staffer who was a serving councillor to move a rescission motion like that from going ahead?
Well, I don't, Ms. Carter, I don't know that it has or has not occurred, so I'm sort of...
It has occurred, and is that perhaps just an attempt to cover up the cuts you're making to services at the Sydney Children's Hospital?
Well, Ms. Carter, you're confusing two issues. I'm not making cuts to services at the hospital.
So
I've made
children's
a decision,
cardiac services will be available at the Sydney Children's Hospital.
Ms. Carter, I've made a decision based on clinical advice that we will
to cut services.
That we will continue the arrangements as put in place by the former government. Complex care should be done based on clinical care and volumes at one site. We've decided that that site is Westmead. I understand, Ms. Carter, that has not been welcomed by everybody, but I do believe in this role. I am elected and appointed to these roles to make decisions, and I will make decisions. That is a decision that I have taken. I understand that you don't agree with it.
Thank you.
But it is a decision that I've got advice, and I was going through a range of different...
Perhaps we can move to a different issue?
Well, I'm happy for you to move to a different issue,
Thank you.
but I wanted you to make sure you
Thank you.
understood that.
I'm interested by the money allocated in the budget for new rural and regional paramedics, a figure of $438.6 million. Does that figure cover the wage increases which are currently being negotiated?
Well, the Health Services Union, that is the union that covers paramedics, has not accepted the wage offer as yet. We are still in negotiation with that union. Respectfully to their work.
Perhaps I wasn't clear, Minister. I wasn't asking about the status of the negotiations. I asked whether the budget figure included the wage increases.
Just let me finish, Ms. Carter, if that's okay. They haven't accepted the current government's wage offer, and we are continuing. I'll ask either Commissioner Morgan or Stephen from Finance to add any more if they wants to.
It's a simple figure. Are the wage increases included in that budget
Point
figure?
of order. The Minister has tried to answer this question several times. He's entitled to answer in a way as he sees fit, and also direct the question
Point of order, there isn't an answer
I'm not.
given.
You are.
There's continual interjections over the top of the Minister as he's trying to respond.
To the point of order, I reiterated my ruling this morning that the Minister is absolutely entitled to consult the department witnesses who are here for that purpose.
Scott, I think you'd agree that I've tried to answer all your questions as wholesomely as possible.
Sorry, Ms. I just want a simple answer.
We have allocated,
Does the budget figure include the amount for wage increases?
Scott, I'd just like to finish if that's okay.
Please.
We've allocated around $3 billion, I think, I'll stand corrected of the exact amount from Treasury, around essential workforce salaries and increases, because we understand that after 12 years of wage suppression that this is a significant issue, and this has made it a challenge for us to attract and
So are
retain
you telling me,
paramedics.
just so I'm very clear, Minister, you're telling me that the budget figure includes an amount for wage increases?
Let me assure you, Ms Carter, that we will be rolling out 500 additional paramedics. In terms of the
So
amount...
you're misunderstanding my question. Does the budget figure include an amount for wage increases?
You haven't let me finish, Ms Carter.
No, you don't
We
want to
have a
answer.
separate fund around that workers that will access through those wage increases.
So you have
We
a fund in the budget for wage increases? Is that what you're telling me?
There is additional money. There is additional money put aside by government to fund wage increases
So
in
there
areas
is a
where we
fixed
know...
pot of additional
Mrs.
money
Carter,
available.
The time's expired.
Yes.
I was allowing the
Yes.
Minister to finish the answer after the
Yes,
time.
Ms Carter. When we roll out 500 paramedics, the agreement that we land with that union and the representation of those workforce will be paid for by the government and included in that rollout. I think
And the figures in the
I don't really
budget?
know how I can explain that any more clearly to you.
Is the figure in the
respectfully.
budget?
You don't have time for asking more questions. Minister.
Yes.
What is the objective of the redevelopment that's currently planned for Albury Hospital?
We want to improve... Well, I probably should acknowledge your deep advocacy for it. I think when you were first elected, perhaps even before you were sworn in, you talked to me about it.
It's very kind of you.
So
I was previously the Deputy Mayor of Albury, but please get to answering my question.
That's pretty important.
Smooth work, Minister.
We are focused on improving healthcare in that border region. We believe that we will be able to do this by increasing the availability of healthcare services on that site, a site that was previously started, that funding under the former government of around about over $500 million. I think it's about 538, but I'll stand corrected on the exact amount. And we are focused as a partnership with Victoria on delivering the very best healthcare there. I do acknowledge, Mr. Chair, that there are groups within the community that are advocating for a greenfield site. I know that, and I know that you have raised that with me before. We believe that we can deliver an improvement to health services in the border region by the development that we have proposed. The master plan process is out and in discussions.
So for the redevelopment that you're proposing,
yes,
how many beds does it have?
Look, I'll go and get some additional information, but I should say to you that that is normally developed as a part of the master plan process, which is underway. It does include a new multi-storey clinical services building, targeted refurbishment of existing buildings, obviously a new car park and car parking, which it's also going to enable the new facilities, or fairly new facilities, on that site to be expanded around it. So that is important, because many of those services, I think including your cancer service, is fairly new, and the ability to, it wouldn't make any sense getting rid of those and trying to restart them on a fairly new, given they had been fairly newly developed and built.
Yeah, so as the new Health Minister, you've recommitted to this proposed brownfield redevelopment at Albury Hospital, saying that it improves health services for the region, but that at this point you don't know how many beds that new redevelopment is actually proposing to fit on that site.
Well, what I do know is that that project will deliver I think you would agree with this. I think improved health services for that region by providing contemporary, up-to-date, modern health facilities across the board. That also works with the existing fairly new facilities such as the Cancer Centre, etc. on that site. Now I'm well aware that people would like a brand new site, but at the moment this is where we are focused on delivering. Ms. Watt from HI.
Thanks. The exact bed numbers are always counted in different ways depending on what's in and what's out, whether it's acute and all sorts of other services which are provided. But that's usually developed in the next stage of planning in consultation with all the users and prioritisation of all of the services and scope.
Has the master planning process done to date for the brownfield included any geotechnical assessments? And I note that in a briefing document to the interim CEO of Albury-Wodonga Health, I'm quoting, "The building has been constructed on relatively deep fill materials consisting of highly reactive clay soils which may experience high ground movement from moisture changes." This was cited in the context of significant risk of collapse of one of the wards of the existing hospital.
I'll take the specific question on notice, but I know that there have been reports done in relation to the building that you refer to by Albury-Wodonga Health, not by Health Infrastructure, and we have relied on the content of some of those in our discussions with our engineering consultants that are engaged as part of the hospital redevelopment.
Minister, are you aware of the 2021 Albury-Wodonga Health Master Plan?
Yes, I have seen that in correspondence that I think has been provided to me in some form, but I don't know what form, Dr. Cohn.
Yeah, so I mean, earlier in your answers today, you said that there's a push from the community for a greenfield site. This was an extensive document that took a very long time to compile. It had consultation with clinicians, experts, councils, both departments, executive and the board of Albury-Wodonga Health, and it concluded that it recommended a greenfield site for the Albury Hospital. On the 21st of November 2021, former CEO of Albury-Wodonga Health emailed Vincent McTaggart, who was at that time the Director of Service and Capital Planning at New South Wales Health, and his Victorian counterpart Stefano Scalzo to say, I'm quoting again, "My apologies for missing last Monday's meeting with Janet and yourselves to discuss next steps in progression of the Albury-Wodonga Health Master Plan. I understand there was a discussion about having both departments discuss with the board their expected role in promoting the strategy moving forward, particularly with respect to brownfield development and staging process." And I'm just going to clarify the timeline for you here. The site workshop for this master plan with all of that extensive consultation took place on the 5th of November. That email took place on the 21st of November, and this master plan was released in December. So there was a conversation with the department that sounded like I was pushing for a different outcome than what this was proposing. And I just want to clarify, because no documents were provided through a formal order of the House to this effect. Are you or New South Wales Health in possession of any minutes or other record of that meeting that's cited in that email?
Dr. Cohn, I'm certainly not, and I hope you know something about me already. I take very seriously call for papers and things like that, and I understand the transparency around it, and I expect, whether it's my office or my agency, to comply with it. I wasn't the minister then, so I don't want to necessarily make comment about the individuals involved, because I wasn't, that's no context for me, but I expect departments and I expect my office and other government officials to comply with those standing orders that the upper house passes from time to time.
From the information I've provided, and what I've quoted was the results of the SO52 order through the Legislative Council, does it concern you that it appears a decision was made to progress with brownfield staging from an unminuted discussion between a member of your department and a member of the Albury-Wodonga Health Executive while this very extensive master planning process was in the middle of happening?
Dr. Cohn, I'll go through a couple of points to try and answer your question, and then, because I know how important this issue is, I'll just ask the CEO of Health Infrastructure to add some further commentary around it. What I understood and what I've been advised is that early planning confirmed that a single site to the size and scale needed to meet the forecast healthcare needs of that community, which is extensive, could be built on the existing Albury Hospital campus, but could not be built on the Wodonga campus due to the size and site restrictions. Investing in a staged new build on the existing Albury Hospital campus is more sustainable. As I've said to you, there are fairly new facilities on that site, and we believe that it would deliver the community improvements in healthcare and services in a way that's sustainable going forward. But Rebecca, would you like to add anything just a little bit before my time? So,
thanks, Minister. I can't answer any specific questions in relation to the timing that you mentioned. Happy to take that on notice. But I think the clinical services plan highlighted the need for a single site redevelopment. It didn't suggest whether that needed to be greenfield or brownfield.
Great.
There are a
Sorry,
number
I'll
of
stop you there because
advantages.
I've got to follow up. You've now acknowledged that there was actually a need identified for a single site hospital, and I'm very aware of that there's enormous clinical risk at the moment in Albury-Wodonga from having acute services split across 2 sites. In the absence of the bed numbers, how can you actually guarantee that the Albury Hospital development is going to be substantial enough to actually be a single site hospital, or do we still need acute services at Wodonga and having split acute facilities?
Well, what I believe is that the plan that we have will deliver enhanced healthcare services for the region. What I completely understand is not everyone agrees with the site, and I respect that. But as a government, we've made a commitment based on the progress of this facility and based on the fact that no government of any political persuasion has unlimited funds to build health services or education services or police services on. We understand that, but we believe that this will make an improvement to healthcare services in the Albury-Wodonga region. And we do understand, though, there are differences of opinion about a greenfield, brownfield site, but I think, Dr. Cohn, it's also important to understand that some of the services and facilities at the current site in Albury are fairly new, and we would essentially be replacing or dismantling or knocking down, however you want to put it, and recreating new services or new infrastructure on another site with fairly new infrastructure that we already have in place at the existing site. That doesn't mean that I don't understand people have a strong view on it. I do, but also I have to manage to make sure that, like any minister, we have to manage taxpayers' money effectively and responsibly, and we believe that this process and this model will deliver improvements to care for the people that you and others represent in that area.
I appreciate that the current hospital is located next to the Albury-Wodonga Regional Cancer Centre, but as you said, taxpayers' money needs to be spent carefully. I and many others are deeply concerned that $558 million is being spent on a facility that cannot and will not meet the needs of the Albury-Wodonga community. For a brownfield development that obviously needs to take place while the hospital continues to function, how will patients on the existing wards be decanted while works take place?
Well, that's a process that Health Infrastructure do very effectively across sites in New South Wales. It is a process that they've embedded. It is very challenging. I'm not going to say that it is easy to do, and I'll ask Rebecca to talk about it in a moment. I do think, though, Chair, that we have to acknowledge that we are a part funder in this process with our colleagues in Victoria. So decisions and agreements around this, and I wasn't privy to them at the time, but I would assume that the former government was in discussions with the Victorian government around investment decisions into health infrastructure in this important region. So whilst I'm not privy, and nor should I be privy to documents relating to those decisions, given they were a matter for Cabinet and ERC, that's very important to acknowledge. I don't think that this a decision would have been taken lightly or in haste, given that 2 government departments and 2 governments contribute to the funding of health services in that region. Is it a challenge building around a hospital that's operational? Yes. Have we done it before in different places? Yes. Do we have the processes in place? I'm confident we do. That doesn't mean that I don't acknowledge that people in that community, including yourself, but as well as other professionals in that community, have a different view. And that will be the case, I think, for most hospitals that most governments build, certainly all over this country, probably all over the world. Rebecca?
So I'm aware that brownfield redevelopments happen, but I'm particularly interested in this hospital. So for the major structural repairs that were recommended to be completed urgently to Medical Ward 2 at Albury Hospital, the report to the CEO said that the closure of Medical Ward 2, which is 20 beds or 21 beds, for 4 to 8 weeks is not possible without having a major adverse impact on clinical care due to a critical shortage of available beds. Albury Hospital typically runs between 20 and 60 beds negative every day. I would like to understand for this specific hospital at this specific site what planning's been done to decant patients while the works are taking place.
I'll ask Rebecca to add anything at this stage of where it's at in terms of the overall development.
Thanks. The repairs to which you refer that are required to Medical Ward 2 are not being managed by Health Infrastructure. That's at the moment a matter for Albury-Wodonga Health. We will, through the course of the next stage of planning, look at all of the staging and decant requirements as we do when we do any brownfield redevelopment. I think the current investment of the $36 million into the emergency department will assist in some of that in relation to the staging because there are new works there. The master planning is also reflective of how we will achieve that by looking at the different areas where we will put the new services and will be respectful of the existing services which are on the site which will need to be retained.
You'd understand that the committee is perhaps hesitant to believe that that's possible without the detail of how it's going to be done when this really extensive master planning process recommended against doing it. But my next question is back to the Minister. I understand that the member for Albury was involved in meetings and briefs regarding this project in late 2021, which is obviously in the term of the previous government. Yep. Is the Minister aware that the member for Albury had declared in his parliamentary disclosures, and rightly so, his ownership of the building and business across the road from the current Albury Hospital site?
I'm going to say I was aware that he declared a conflict of interest about something there. So that was probably it, but I'm not going to be disrespectful and say that that was definitely the case. All I expect, and I think all of us expect, is that as members of Parliament we do the appropriate declarations.
We honestly declare, that's right.
And we do the appropriate declarations, and I don't want to say that the member for Albury has done anything other than fulfil that requirement, and that's what I think is the expectation of all of us.
Thank you. And to be clear, in my stem of my question, I did say that it was declared, and rightly so. My question was whether you were aware.
Yeah. Well, I'm aware that there was a conflict. He'd raised some issues around potential conflict of interest. I don't think it was about a business, so to speak. I think it might have been to do with a relative, which is what I thought. But I may take that one on notice. But what I probably say to the committee is, as a minister, all of us as members of Parliament expect to do those conflicts of interest. That's what we do. I do them. I'm sure other members do them.
Honestly.
I don't want to give any impression here that I think, and I know you don't, that the member for Albury has done anything wrong, because
to be clear for the record, I don't. He completed his disclosure to the Legislative Assembly. That's available online.
Yeah.
What's the cost of the current Tweed Valley Hospital redevelopment that was announced in 2018-19?
Geez, it's substantial. We opened that hospital. That's been one of the most significant builds that we have done, mainly under the former government. Rebecca, it was...
So the estimated, the budget is $723 million, and will be delivered within that budget.
And what's the value of the New South Wales contribution to the Albury Hospital redevelopment?
It's around half of the total amount. We do a roughly 50-50 percentage breakdown, is what I understand it, Rebecca, in relation to
Yes, and there are some
Health.
other smaller numbers in relation to Nolan House as well.
So I can answer it for you. It's 225.
Yes.
When's the expected completion of the Tweed Valley Hospital redevelopment?
Tweed Valley next year.
The building work will be completed in the coming weeks. And we'll be handing over to the local health district for operational commissioning.
Fantastic.
There's some challenges there around what we didn't want to do. Some challenges around opening the hospital up in the Christmas period that people on the ground advised me. Maybe they advised the former government, but they advised me anyway And I think we've had some discussions with the member for Tweed that just in terms of making sure that the hospital gets stood up appropriately, that we would move that into early next year. So I just wanted to get that clarified.
Yeah, fantastic. I'm delighted to hear that it's possible to do a greenfield hospital build in New South Wales from announcement to completion within 5 years, and with a contribution of over $700 million from the New South Wales government.
Oh, that's very nice, Chair.
I wish that all regional communities were treated with that kind of generosity. Yeah. In the $558 million for Albury Hospital, $45 million of that was a previous commitment of the New South Wales government before this redevelopment was announced. Was there ever any request or consideration that this be used for urgent modular capacity while the planning for a future greenfield site progressed?
I'd have to take advice on that. I'm happy to ask Rebecca, but yeah, sorry, just with the predating of this, I don't want to mislead the committee in any way. So
Sorry, could you repeat the specific question around modular?
Yeah, so has there ever been any consideration or request for the existing funding committed by New South Wales to be used for urgent modular capacity for the bed deficit that we've currently got at Albury Hospital while the greenfield planning then progresses?
We are not doing greenfield planning. And I take on notice the question about modular decant, but as I mentioned earlier, we will be doing staging planning around that, and if that involves some temporary relocation, then that will be provided. But in specific answer to your question, no, I'm not aware of it.
I've only got about 30 seconds left. Having heard the really serious concerns that I, on behalf of the Albury community, have raised around the geotechnical issues with the site, the lack of bed numbers, contributions made elsewhere, the impossibility to decant wards, and the concerns around decisions being made in completely undocumented meetings that took place under the previous government, Minister, would you be willing to consider reviewing your decision to progress this brownfield redevelopment?
no, not at this stage, but that doesn't mean that I'm not engaging in correspondence that comes before me, and I'm not seeking advice from the experts in health infrastructure. That's where I will continue to do so. As a minister, certainly what I expect of myself, and I hope the committee expects, is that as information comes in, I review it, I get evaluated, I get advice on it. The advice I use is the team at Health Infrastructure, because that's the arm of government that delivers health infrastructure across regional and rural New South Wales and metropolitan areas, and that's where we'll continue to focus.
I'm out of time. Okay, we need to split the remaining time between crossbench and opposition time, so I'll give the opposition 2 minutes.
Okay, yep, thank you. Minister, I thought you were done. I was going to... Anyway, the Rural Health Incentive Scheme, has that been paused in the Mid-North Coast Local Health District since July?
No, I'm not aware of it. I know this was a program that the previous government focused on. We've made some slight changes to this in making sure that very hard to fill spots in very hard to fill locations and specific services was increased from 10,000 to 20. I want to be clear, that's not everyone. So I'm not pretending it is. That
was up to 20. Thank you. So, Minister, could you just confirm? I'm very happy if the answer is no, but the rural, because I've just been informed by, so the Rural Health Incentive Scheme, has it been paused or not paused at the Mid-North Coast Local Health District since July?
No, I'm certainly not aware that it's been paused, but Phil...
okay, no, just a yes or no. Sorry, I've just got really limited time.
Not to my knowledge.
Okay, thank you very much. Minister, what about movement on safe staffing? I'm also told that this won't even happen until, or look at being happen next year, and that nothing's actually been done since you've been in for the last 6 months. I know you've set up a committee, but are there any safe staffing ratios happening over New South Wales at the moment?
Well, that's unusual you asked me a question, because Dr. Cohn asked me that question, I think, in her first round, and I provided...
Oh, I beg your pardon, Minister, but it's my question. I really have hardly any time.
I provided a very long and detailed answer, which I'll now provide you.
Has safe staffing started?
I'll provide you now a very long and detailed answer. Since March, we have been working with the New South Wales Nurses and Midwives Association and the health districts
well, this has come from them.
With an MOU and a team. They have been working with my office. We've been meeting them in some cases weekly.
So you haven't started anywhere?
We are at the very... it is arguably the largest reform of hospital staffing that has been done in a decade
Okay,
and a
so you
half.
haven't started. Thank you,
We've
Minister.
been in for 6 months.
Thank you.
And we are rolling this reform
I don't
out,
wanna go
but we will
into
do so in a
anyone's time.
sustainable way.
In 2022, the European Society of Breast Imaging published new recommendations for screening of women with extremely dense breasts, which includes MRI for some women. The Royal Australian and New Zealand College of Radiologists is currently in the process of updating their position statement on breast density. Is any work being undertaken by Breast Screen New South Wales to investigate whether reporting breast density with screening results has a mortality and morbidity benefit?
I think Tracy and the team from the Cancer Institute is working on this. I've had a number of discussions with them about Breast Screen New South Wales. I think the former Minister for Regional Health also was focused on delivering screening across regional and rural New South Wales, particularly in hard to access areas. I'll ask Dr. Chant just to allude, just in case Tracy's not here with us, but from the Cancer Institute, but Dr. Chant might be able to add some specifics around the particular, around breast density.
I suppose just to alert you that I know that I'm aware that the Cancer Institute Chief Executive is looking at the issue that you raised. It's a very important issue. I think it'd be better that we take it on notice and get a robust response from what
Happy to.
Dr. O'Brien is up to in relation to that issue.
Thank you. I look forward to that answer on notice. Goodness, I have a very complicated question with only 1 minute left. How many cases of hospital-acquired COVID-19 have occurred in New South Wales in 2023?
So, in terms of the process for identifying hospital-acquired, there is our usual routine IMS notification system where clusters and outbreaks are registered, but at the moment I haven't got collated numbers with me in terms of reports of outbreaks in our hospitals associated with that. But just to reassure you that our hospitals recognise the importance of infection prevention and control measures to reduce the risk of that, and we do actually call out. We are actually seeing an increase in COVID transmission in the community now, and just to alert you to our weekly respiratory report, which indicates that, and we do want to get that message out that we particularly urge people to stay at home if you've got any respiratory illnesses. Don't go and share them. Please be mindful, particularly don't visit any vulnerable settings like aged care facilities or hospitals. Please just be compassionate when people are wearing masks and are taking other protective measures. And we will be continuing to alert to and vaccinations, probably the other component.
Yeah, thank you. I have lots more questions specifically about hospital transmission of COVID-19, and I'll come back to that this afternoon, Dr. Chen.
Yep. Thank you.
I think that brings us to
We've got
government
a few
time.
people at Parliament with COVID now. So it's coming. It's coming. Anyway.
Sorry, Chair, are you moving to...
I thought it was government time, but I've just been informed my timing's off and there's 2 minutes to go that we're meant to split.
Oh, you go.
Go hard.
Yeah, but I'm very happy.
Yeah, okay.
I think the ministers...
Sure, I'll go with my 2 minutes. So a community member made a GIPA request to the Epidemiology and Data Systems Branch of Health Protection New South Wales, and that GIPA request showed, and I'm quoting from it, it was advised that the information on the source of COVID-19 infection is not required to be reported into the Notifiable Conditions Information Management System, and the information that is available is very incomplete.
So look, at this I suppose it's just, maybe if I could just take you back from the beginning. Certainly when we had very low case numbers and when COVID was first notifiable, there was intensive investigations of each single case and very thorough examination of the source, and there has been some published work on transmission, including in educational settings, and hospital-acquired infections were looked at very, very closely. And that was to generate any learnings at that time. Currently, as you're aware, where we're at that phase in the pandemic, individuals are not being interviewed, and the only notifications that are required to be notified are those that are by PCR test, which doesn't actually pick up those that might be doing rapid antigen testing. And also, we're not suggesting that everyone needs to have a test to understand what respiratory virus they have. We're just urging people to be at home and take appropriate steps to prevent the transmission to other people and be aware of signs of deterioration. But obviously if you've got underlying health conditions we would recommend that you have a plan with your GP. So for those reasons, we don't have a clear understanding of how everyone has acquired COVID.
Sure. Can I just try to
yep.
narrow you down? I'm not asking about everyone. I'm
Yep.
asking about hospital inpatients. Is the data being collected whether people are catching COVID infection during their inpatient stay?
So there is a process whereby outbreaks are being documented, and that is through our Clinical Excellence Commission, and there is some documentation through that system. Now, obviously, the detailed investigation of every case of COVID in hospital is sometimes challenging because of the incubation period and when sometimes patients could have been exposed outside. But there is efforts taken at a ward level and when notifications occur to really understand if that could have been contributed to by transmission in the facility, and very importantly, actions taken to protect other patients and staff in that setting.
Sorry, I am properly out of time this time.
Is there any time?
No, we're at government time. Apologies. Does the government have any questions?
Thanks, Chair. Just a final one for me to round out the day, or the day for you, Minister, as it were. Excuse me. Just wondered whether or not if the Minister could outline for us, it's been obviously a topic of much interest this morning, the issue of cardiac surgeries and the availability at Sydney Children's Hospital, Randwick in particular. Is the Minister aware of when the decision was made to cut these cardiac surgeries? And if so, who was in government at the time?
Yeah, my advice is that was in 2018, and obviously that was the coalition government who was in power at that time.
Thank you, Minister. Thanks, Chair. No further questions.
Okay.
Interesting.
Right. In that case, we will break for lunch early and return at 2 o'clock. And thank you to the Minister for your time.
Thank you, Chair. Thank you to the committee.
Thanks everyone. It's 1 minute past 2, so we'll get started with the afternoon session of the hearing, and we'll start with 20 minutes to the opposition.
Carter's going to start.
Thank you. Thank you, and thank you everybody for being here. My first question, I think, is probably directed to Ms. Pearce. The funding cuts, the $150 million, was that suggested as an area that health could offer up as a funding cut to the ministry in the budget process?
Thanks for the question, and we appreciate the interest in palliative care. Look, as outlined by the Minister this morning, and I do need to restate, there has been a 6.8% increase in palliative care funding this year, which equates to around $23 million.
Could I maybe stop you there and say, agreed. The funding cut that is in issue is what was promised in 2022, what was planned for since 2022, which has now been taken away. That's the cut that we're focusing on. And who suggested that that should be cut from the budgets of all the LHDs who are enhancing their palliative care services using that enhancement funding?
Okay, look, I'll address that part first. Look, the ministry, as you'd be aware, and obviously Mrs. Taylor is aware, as do all agencies, provide assistance to governments in the build-up of budget deliberations. Fundamentally, the government hands down the budget, and it's our job to deliver that responsibly in accordance with government policy. We're not in a position to talk about deliberations with government in respect of our budget.
So you're saying that you can't suggest whether this was an area that health identified as possible budget savings?
What I'm trying to explain, because there have been a number of assertions made in this forum this morning about cuts, I have to reiterate there is no reduction in palliative care services. And in fact, by the end of August this year, there were 70 additional FTE across a range of disciplines. The memo that you've referred to this morning, for example, that's gone to Western Sydney, actually talks about an $830,000 increase in their palliative care budget this year. The Chief Executive there has confirmed to me...
Can I stop you again? Because we are agreed that palliative care funding has increased, but not to the level it was promised. It is $150 million off the pace in terms of the enhancement funding. All we're trying to work out, is this something that health thinks is a good idea, that was offered up by health as this would be one area that there could be budget savings? Or did the idea come from somewhere else?
I've provided my answer.
All right, thank you very much. A couple of questions in relation to palliative care, and then we probably move on to other issues. And I'm not sure whether these are for you, Ms. Pearce, or whether they're for Dr. Chant. In conversations with people in Western Sydney, issues raised in relation to the people who use the health service there, cultural background, Indigenous background, expressing concerns already in relation to trust in palliative care, and great concerns about how the VAD is going to be structured and palliative care is going to be structured. Can you confirm that VAD will be physically separate from palliative care, so that these will be, especially for those populations in Western Sydney, clearly different pathways offering different services, and therefore giving confidence to the patients and their families?
I'll make a comment first, perhaps, and then hand to Dr. Chant, who is managing the VAD program for New South Wales Health. Internally within our organisation, we made a decision some time ago, probably a year, 2 years maybe, that we would really keep the structure around voluntary assisted dying and palliative care in terms of where they sit within the ministry, quite separate. So, for example, Dr. Chant has the VAD program, palliative care sits elsewhere in the organisation, and that was a deliberate move on our part from a structural perspective to ensure that there wasn't muddying of the water. But Dr. Chant, did you want to comment about that?
The substance of the question is
clear in the sense that from a program implementation perspective, palliative care is a different service than voluntary assisted dying. I think where I need to clarify is the settings in which voluntary assisted dying may occur is in some palliative care services there might be components of voluntary assisted dying as elements of the care. Where that aligns with the person's providing person-centred care and where it aligns with the goals of care, and as you're aware, the Voluntary Assisted Dying Act, which passed Parliament, is very clear about it being patient-driven and the patient having to have capacity for the full suite of time. There's been a lot of cognizant of the different culturally and linguistically diverse groups, and I'm very pleased to say that the team implementing this has done a lot of work with culturally and linguistically diverse communities in supporting the collateral that's been developed and sensitivity about how language might be translated. So we're very cognizant of the issues. We want to also in our rollout be very clear that we really want to improve end-of-life care overall, and that when someone is asking for voluntary assisted dying as per the Act, it's important that the full suite of measures, including palliative care and other options around treatment and prognosis, are discussed. So we've got the privilege of embedding this in a sort of end-of-life care framework.
Sorry, thank you for that information. I'm still not clear, as a patient seeking palliative care, am I going to be co-located with a patient receiving VAD?
So
or will
local
they be
health
physically separate?
districts will be doing service planning associated with voluntary assisted dying. What we obviously want to do is make sure that people have access to voluntary assisted dying if they want it administered, where they might want
sorry,
it
I'm
administered.
not trying to cut you off. I'm just really struggling, and I wonder whether I've explained the question properly. What has been put to us very clearly is that, especially in Western Sydney, there is great concern amongst cultural and linguistically diverse communities and Indigenous communities that they want to receive palliative care completely separate from VAD. I'm just wondering if the service has been structured in that way.
So the local health districts have been given autonomy in the way that they structure the services.
Can you comment about what's happening in Western Sydney?
So in terms of the specifics of Western Sydney, we've obviously worked greatly with them. We can take that on notice about what their specific plans are.
Thank you. If you could take it on notice, I'd be very grateful. And one more question in this vein. I'm aware actually of evidence that was given budget estimates 12 months ago, and the stated intention then that's really been restated now to keep VAD and palliative care separate. And I'm just wondering, I don't know whether it's Ms Pearce or Dr Chant, what specific procedures and record keeping systems are in place so that spending on these programs are separate and investment in these programs are separate, and we can see exactly what money is going to palliative care, what money is going to VAD.
So there is separate allocation that has gone out to local health districts associated with voluntary assisted dying. That has gone out for a 12-month period with recurrent money to be determined as we move through implementation. As you're aware, this commences officially on the 28th of November, and clearly we need to be informed by implementation issues in terms of finalising future years of funding. The funding is kept separately and distinct, and as we've got the separation of different accountabilities from palliative care within the ministry, and we'll be accounting for the expenditure against the plans put in by each of the local health districts. We'll also have the ability to monitor activity through a variety of different mechanisms.
Do you have data on the number of patients seeking palliative care who are unable to receive it?
That's not in my portfolio area,
Can somebody assist me with the answer to that?
We wouldn't collect that kind of data, Ms Carter.
Okay, so we don't know the shortfall in palliative care? How many people seek it but cannot be provided because we don't have the resources?
We wouldn't have a count of individuals who are unable to access palliative care, but I can say for the service planning within the local health districts, as we plan all services, including palliative care, issues around our population size, our demographic, ageing population, the numbers of people that came into our services the year before and the year before that, allow us to
So
trend
you're
and
saying
plan
that
for
the
beds and
workforce planning and the health planning is based on a series of predictions, but you don't actually know that there are 100 people who sought palliative care in Forbes who couldn't be supported in Forbes?
I certainly couldn't comment on specifically on Forbes, but my thinking would be that in a community like Forbes, if there was a lot of concern amongst the community about an inability to access any service, not just palliative care, there is strong engagement with the community in these towns that will connect with their local health managers and service managers. And if these things were coming to the fore, chief executives would certainly be talking with community and making service planning around it. But as for individual numbers of people unable to, that wouldn't be, because we don't know who they are to
So
count.
we're relying on community engagement to feed through where the gaps in service are in health generally?
We would rely on community engagement. We would look at activity from a previous year and the years before that.
Okay.
We would also rely on our population changes. There's a huge amount of data around the demographics, at the types of people coming into our care, and all of these data sets would inform our service planning over time. It's not a point in time, it's iterative, and some of the data and stuff is trended over, a few years back to forward
So
plan.
do you have data about the number of Indigenous people in New South Wales who access palliative care?
I'd have to take that on notice. I'm
Okay,
sorry.
and the number of children?
I don't have that information before me. I can take it on notice.
That would
though.
be great.
Yep.
Thank you.
Okay, thank you. It's really nice to see you all again, very genuinely. Thank you for everything that you're doing each and every day. And congratulations, Mr. Sloan, Dep Sec. Pretty amazing. You must be really pleased about that.
Thank you, Assistant.
Yeah, no, well, I'm really genuinely very happy for you. Can I just ask for some questions, and I'm not sure whether they'll be Mr. Sloan or Mr. Minns, but under the government's Rural Health Workforce Incentive Scheme, will any incentives be available to attract or retain health workers in John Hunter Hospital or Wollongong Hospital?
Mrs. Taylor, essentially it's a decision that gets made at the LHD level. So if you wanted me to, I could tell you how much money has been expended year to date for that district.
I know that you can tell me anything I want, and I won't understand half of what you say, Mr.
Right.
Minns, because you're very good with all of this. But what I just want to know, I guess, is Newcastle and Wollongong included in the new Rural Health Incentive Scheme?
I'd want to check that. Someone will send me a text.
Okay. So do you want to take it on notice, and then if you get the text, you can tell me, and we can take
Sure.
it off notice? Is that okay?
Yep, happy to
Okay.
do that.
So is this new scheme is actually a modification of the old scheme that was introduced, the old scheme, or the scheme that the previous government introduced? Would that be correct?
Well, it's really a continuation with essentially one tweak. And the tweak is that we've said that in circumstances where you've not had success with the 10,000 incentive package arrangement, and it's still a critical role and that incentive is not working, you can offer up to 20,000 across a 3-year period.
But previously, would it have been correct to say that when you looked at a whole package, it could have been up to 20,000?
Yeah, and
Yeah.
so this is adding 10.
Yeah.
It's not taking anything away
No,
from
I
that.
understand that, but my understanding was that as well that some of those packages could be up to 20,000 previously.
And that would relate to the non-salary related
Yes, I
benefits.
understand that, Mr. Minns, but I just want to be really clear for the committee, because it was said that there was an increase, and if you look at the whole package of incentive, the previous program could allow for that uplift up to 20. I understand the new one does too, but that's correct?
The
When you
new
look at
one,
the
the new one
package.
is creating an extra $10,000 to be contributed towards the attraction component for 3 years.
Yeah, but the
So-
previous one could be a package of up to $20,000 too.
But there weren't many
No, I
at
don't,
that
but
level.
I'm asking you the question.
Well, I would need to check, but I doubt that anyone
Okay, well, if you
got
could
20
take-
under the old
Yeah, but it was
arrangement.
possible to get.
Well, possibly not, because...
Do you want to take it on notice, and
okay.
then we can get to the crux of it? That would be really, really good. And how many, as of the 27th of September 2023, or look, yeah, we just picked that date, so don't. How many positions are currently advertised as eligible for the Rural Health Workforce Incentive Scheme?
Okay, now I've got a table here that will just take a while to... So, the headcount that's been recruited, newly recruited with headcount across the state is 1,350.
And where will that, what date was that from, Mr.
That is from yesterday.
Okay. And
Well,
would that
I got
have-
the data yesterday. It might be the last fortnight's
and
pay
when is
point.
the start of the data?
Well, it's a rolling...
I understand, but is this a total over since the last scheme was introduced, or is this only the new?
This is the entire scheme from when it commenced. But that's not the only number that's relevant.
Okay, so how many, can you break up for me pre-March 2023 and post?
Not with the data I have. No.
Could you take that on notice? Oh, thank you very much, Mr. Mearns.
Can I just add one thing?
Of course.
That we've also extended incentives to 7,280.17 FTEs that have been to support retention.
I was just going to ask you that, and you preempted me. Sorry, I got so that's 7,000.
7,280.17.
That's pretty spectacular, isn't it?
Well, it's a scheme that was designed with two objectives in mind. One, to try and attract, and one to try and halt the retention.
I know, but I'm actually saying well done. I think that's amazing. It's absolutely fantastic that a scheme that was introduced is actually doing its job. So that's really, really exciting. So on the New South Wales Health website, it says not all rural and regional health locations and jobs will be incentivised under the scheme. The recruiting LHD will make this decision. What's the process the LHD will take when making the decision, and does the Minister have oversight of the decision?
To answer the second point first, no, these are not matters that we raise with the Minister. We have a policy document that's recently been updated that reflects that change from 10 in relation to salary to 20. The LHD, the original scheme design was that you had to first of all establish that it's a critical role, and you had to establish that there's been a period of time where active recruitment has been unsuccessful. So they're the hurdles, and then it's a matter for the LHD to make decisions in their own context against the policy document that runs to, a couple of dozen
So
pages.
nothing's really changed then on that spectrum.
No.
Okay, so tell me if I'm wrong, because we know that maths is not always my strong point. If we add up the incentives of 7,280.17 with 1,350, that would be the total number of people, so FTE, that has been supported by this scheme so far to work in rural and regional New South Wales.
Yep.
So that would be, or help me out, Mr. Minns, 7,000...
So, as you know, Mrs. Taylor, this data is always about how you ask the question.
I do, Mr. Minns. Someone might have taught me that.
Yeah. Existing headcount is different again, and it's a higher number. So, at an FTE level, we've got those 7,280 that we've retained, but at a headcount level, we've got 10,198 people retained with an incentive. And so that's reflecting the fact that particularly rural and regional, some people would elect to work a 0.6 week rather than a full week.
Well, I just think that's absolutely fantastic. Congratulations, and I will encourage the Minister for Health to start putting out some releases and some work on this, and everyone should be really proud that worked on that scheme and the people that devised it, Mr. Minns, because that is a massive result, and that is something that everyone in New South Wales Health should be really proud of. And I'm sure having a DepSec for regional health
receive acknowledgement for that, Minister.
No, I really mean it. That was years of your work, and now we're actually seeing it have an effect. I just think shouldn't lose sight of these things. I think that's just terrific. Can I now please go on just to ask some questions about about Manning Base Hospital? So I just want to know that was a member of the department present in a meeting between Minister Park and the member for Mile Lakes on the 27th of June, during which the importance of the cardiac services in the region was discussed?
Not to my knowledge, Minister.
Okay, thank you. Did you want to take that on notice to check, or are you happy?
To the best of our knowledge, we can check, but...
Understood.
Yeah.
Understood, Secretary. Thank you
Yeah.
very much. So that therefore there was no direction that the Minister gave or anything after that if no one was there?
We would have to take that on
Understood.
notice, yeah.
Understood, Secretary. In the Minister's response to a question on notice, it states that only $4.6 million, and I appreciate that I can't ask, so you just tell me if I'm overstepping, but it states only 4.6 million of the 100 million will be allocated in 23-24 for planning. So are we confident that the Manning redevelopment will be able to go ahead?
Rebecca, are you able to assist Mrs. Starr?
We know that the budget has been allocated of 100 million, and we are working through with the district a prioritisation of what the scope should be within that allocation. And the 4.6 is the allocation for this financial year.
For the planning.
Thank you. I'd like to come back to Dr. Chant and the issue of COVID-19 transmission specifically in hospitals, not in the community. So I'll come back to this GIPA that I've been sent. And the GIPA of the Epidemiology and Data Systems branch of Health Protection New South Wales stated, it was advised that the information on the source of COVID-19 infection is not required to be reported into the Notifiable Conditions Information Management System, and the information that is available is very incomplete. Why is source of COVID infection not being reported for hospital inpatients?
So I think that, just to be clear, that GIPA, the section you're discussing there relates to, they've answered it purely from other notifications which are coming electronically. Clearly we don't have individual follow-up now, so that was why I was answering the question in the way I did. So from a statewide perspective, we don't follow up the notifications, and that's why the answer to that question, the data system they're talking about is our state-based notifiable disease data system, which then has electronic feeds from labs that bring in data, and there are some diseases that we do more intensive follow-up, and in those circumstances, things like measles and other things that we would be having phone call follow-up with GPs to find out and make sure that public health action's taken. In terms of the hospital system, I can confirm that in a system in hospitals there's generally infection control practitioners or staff that have got a role in infection prevention and control. Those staff would be alerted to cases of COVID positive cases, and that would same apply for influenza or RSV positive, or a gastro positive, so anything that's infectious in nature. They would particularly be involved in looking at if there was any onward transmission in that setting, and to identify what would be the factors that contributed to that. I can confirm that those infection control practitioners from across the state meet fortnightly, convened by the Centre CEC, and they then share learnings or lessons from any of those outbreaks, which then inform the prevention control systems that we've got in place to reduce the risk. So it's that the answer to that question is we didn't hold that centrally in the particular form because our local health districts and wards are working through usual process at looking at these cases and managing outbreaks in those settings.
So does the CEC collect and aggregate that data that's being provided?
So the CEC doesn't collect and aggregate in a systematic way. But as I indicated, that when there's outbreaks in wards, they are captured through our incident reporting mechanism. And again, the focus is really on lessons learned that we can share and put in place to improve infection control and prevention systems in our hospitals. We continue to be concerned around the spread of infectious diseases, COVID, influenza, RSV, gastro in our hospitals system, and take steps to minimise that and learn lessons.
Sure. I was really concerned at some of the reports that came out of Victoria earlier this year, so particularly that for hospital-acquired COVID-19 there was a mortality rate in the order of 10%. With the data that's available to New South Wales Health, are you able to assess the mortality rate from hospital-acquired COVID?
Clearly that has changed over over the time, but we recognise that our hospital patients are particularly vulnerable. They're vulnerable by the fact that they're more likely to have significant comorbidities, and we also recognise that some areas have even greater potential risks, like our transplant units, highly immunocompromised. So we don't actually know the exact mortality associated with COVID. There is other infections we're also interested in. All I can confirm is that we're conscious of taking every step we can to minimise the risk of transmission, and we also have some increased and enhanced infection prevention and control strategies deployed in our very, very high risk services.
Sure. So what are the protocols at the moment in a New South Wales hospital if there's a patient with respiratory symptoms awaiting a COVID test result? What protocols are in place to prevent that transmission in, for example, a 4-bed ward?
In a 4-bed ward, so someone with a respiratory, we've got access to very rapid tests, but if someone had a respiratory illness, there would be segregation into a single room, because we, agnostic of whether it's RSV or other things, we will try and do that. There's a whole cascade. Obviously, there may be occasions when there's not an immediate room available, but there's a whole policy document on our website which we could provide around the steps and advice to manage infection control issues in our hospitals that the Centre for CEC coordinates, our Clinical Excellence Commission.
Yeah. I'm particularly interested in this because I've heard a number of cases anecdotally of transmission in hospitals where there were not adequate infection control procedures and patients with respiratory symptoms on a 4-bed ward. I know from my own community at Albury Hospital, we talked about earlier today, regularly runs a deficit of 20 to 60 beds, so moving people immediately to a single-bed ward, it just doesn't happen in practice. So I'm interested, I suppose, in what work's being undertaken to track that, to adapt protocols as required, or to engage staff with P2 respirators, etc. What work's being done?
So all I can say is that the Clinical Excellence Commission has regularly updates the protocols for prevention and control. I think we acknowledge everyone has a role to play. It remains an ongoing risk. These are high-risk settings for respiratory viruses, and although we've been particularly talking about COVID, we're similarly worried about and concerned about other respiratory virus transmission. So all I can just say that we've got those systems in place, but happy to follow up any particular concerns that you've got about particular settings to do that reinforcement of education, training, and look at any gaps.
Thank you. Look, I'll send through some written correspondence about those particular cases.
Thank you.
I am interested now, coming out of hospitals to the community. Obviously, testing rates are now significantly down from what they were at the peak of the pandemic, and particularly with the rapid tests. I imagine there's far less information coming in about emerging strains of COVID. What work is the department doing to monitor the current and emerging strains?
So look, I'm actually very proud of the work that the department's doing. We've had to change our surveillance methods depending on the phase. And so at the moment we are relying on a system called our FRED system. And this is a system that gives us real-time data, relatively real-time data on admissions to hospital for COVID, direct admissions for influenza. We capture bronchiolitis data. So we look at that, and that's actually very reliable. That's probably our best indicator because we actually have quite high patterns of testing in our emergency departments for respiratory viruses, obviously for diagnosis, but also infection prevention and control. We also look at wastewater surveillance. So our wastewater, we collect wastewater from 4 different sites, and again, that detects the virus in wastewater. So it's a passive system. It doesn't require that. We also look at indicators like aged care outbreaks in aged care facilities, again a factor of when we see an uptick in cases. And we also look at the Commonwealth collects data on antiviral prescribing, and that's a very good indicator as well. So we publish weekly an assessment of the level of transmission of viruses in a weekly report, which comprehensively has all of this data. And at the moment we are actually in an uptick of COVID. So we've seen a longer than usual flu season. We're seeing flu and RSV at moderate levels, but they're in decline. we're seeing COVID start to take up, and our projections are that we'll see peaks around later towards the end of the year, November, December. And so we are pushing out messages that now is the time that more COVID is around, beware. Now's the time to get vaccinated. According to the ATAGI advice, we are trying to protect our vulnerable settings. We do a lot of work with our aged care providers. We have guidance for our aged care providers, and we ask them to reflect, noting we have to balance the fact these are aged care facilities are residences and asking them, though, to adjust their protections depending on the level of community transmission. And we work with our colleagues in Health and Social Policy branch at liaising with aged care facilities and have specific guidance. So we continue to look at proportionate measures, but we do have a sense, what's most important to us at the moment is telling the community about the level of transmission in the community so they can adjust their behaviours, particularly those that are more vulnerable to severe consequences of COVID infection at this time.
Thank you. I'm going to move to a very different topic. Earlier, the Honourable Bronnie Taylor asked about the 500 paramedics being delivered for regional remote and rural New South Wales. Who made the allocations for those 500 paramedics, and who did they consult in that decision-making process?
I'm happy to take that. Thanks. So essentially, New South Wales Ambulance has a service planning unit, and they look at a whole range of indicators to determine service profiling. Specifically in relation to the regional areas, our biggest challenge is that pretty much for 128 years we've had a rural on-call service model. And if you look back in history, the timing of, maybe doing 1 or 2 jobs a week out of hours was probably entirely fine. When you're doing 2 and 3 jobs a night, the levels of fatigue that follow are significant, and do that for 30 years, and it follows logically on issues of wellbeing, mental health, etc. So probably one of the primary areas that the teams looked at in looking at the initial allocations for the rural 500 has been around those areas with significant levels of high on-call. And so that's the familiar pattern across the locations that we're looking at. They're not just all locations that have, for example, no night shift. You look at some of the really big regional centres, they have significant amounts of on-call as well. And what that's done is let us come up with a priority list of the locations that we think are the primary areas. These, once mapped out against capital allocation we just got in the last month or two through the budget, will allow us to work out those facilities that can physically take the enhancements. So that work's being done at the moment, and that can alter the list and the priorities as well. Once that's done, we consult with the unions. This is a program approach that we used in the SWEP allocation, which was 4 years ago, a statewide workforce enhancement, where we saw over 400 paramedics put into regional New South Wales, and we're replicating that approach now. So once we've got a priority list, we actually consult with the unions centrally, so the main offices of the Australian Paramedics Association and Health Services Union, and then we actually go out to the local stations. And generally what we do in those locations is consult about the types of rosters and the pattern that they'll work to meet the need. But in the examples I'm using, it's almost invariably replacing large amounts of on-call with on-duty staff.
Thank you. It's a very helpful explanation. That modelling that's been done so far, has that been made available to the unions?
No, because we're still going through that bit about now we've only recently in the last month got the allocation around the capital, and so we're just going through, in fact I was only reviewing drafts before, of where we think we will be require capital expansion at some of these locations, because bear in mind it's a 4-year program. Logic will it's no great leap of faith to understand it's pretty much 125 staff per year over the next 4 years, because it's also mapped against the other program that the previous government brought in that is more focused around the big regional areas than the metropolitan areas. So both programs will go ahead concurrently, but we just need to pin down that last bit about the priorities on capital.
Okay. And of those 500, are any of those intensive care or extended care paramedics?
Yes, so that's a different question. The particular government commitment this time round was not about specialist paramedics, but going back 3 years ago now, the former government made a commitment to 246 additional intensive care paramedics, specialist positions. 203 of those were specifically for regional New South Wales. Now again, service planning have gone through and determined profiling of all the ambulance stations across New South Wales. It's not related to whether it's metro or regional, it's basically a formula. And it's to do with activity, distance from services, a whole range of things. But the short version is it's divided into category A to D, and specialist locations are the ones where we put the intensive care paramedics because there's higher levels of activity. Generally speaking, for specialty service with high acuity, low occurrence procedures that the intensive care paramedics do, it's much safer to put them at those busier locations. So we currently have 402 intensive care paramedics in the metropolitan area and 396 in the regional areas who are trained as intensive care specialists, and we currently have another 95 that are entering training specifically to go back to regional New South Wales. So it's well advanced, but that's a 5-year program.
Yeah, thank you. And look, I'm well aware as a former country GP of the need to have a sufficient volume of procedures to maintain skills. But for intensive care and extended care paramedics who may have trained or been initially working in an area with high volume use of those skills who then relocate to a regional area, why didn't the government support the recommendation out of the ramping inquiry to actually allow people to retain those qualifications or support them to do the extra maintenance they might need of those skills?
Yeah, look, I mean, as a clinician, you know as well as anyone, you know, your desire to practice your clinical skills to the top of your scope is something that we all hold near and dear. But there are simple realities around the fact that these are decisions around safety and quality ultimately. And we can't knowingly, no matter how proficient a specialist may be in their area where they're doing the procedures on a very regular basis, who then go from a very busy workload to a community that might only have a handful of jobs per day or per week, that creates a risk profile that would actually potentially do harm to an individual rather than the good that we're seeking to achieve. So by doing a priority list of what are the places where you can support your clinical skills in a safe and quality way, then absolutely we're trying to support those rural communities, but also bear in mind that the smaller, usually smaller ones with low occurrence can't really be supported. A good example would be a hospital example. Dubbo has an intensive care unit, but if an intensivist were to go and relieve at Narromine MPS, it doesn't mean that there's all of a sudden an intensive care unit at Narromine. So that's the balance we're seeking to strike.
Yeah. I'm interested to understand if there's been any work done to examine what happens in other states. You know, I've heard anecdotally, for example, in Victoria, they have travelling paramedic educators who can do continuing professional development for people who are not using those skills as regularly as you need them to. Has that been looked at?
Not only looked at, we have them. Yeah. New South Wales has an extensive number, greater than 100 clinical training officers and educators around the state. There are 9 regional training centres. The clinical training officers are specifically equipped with, they don't actually have an office per se, they have a base, but they have a vehicle that carries all their training equipment. They go from facility to facility.
Sure. But it's your view that that's not sufficient to support the skills of those intensive care and extended care?
No, and a good example is, in the one you're using, is in Victoria they have the mobile intensive care ambulance system, which is exactly the same as New South Wales, and as you'd know, MICA is only located at specific locations. It's not just because I did an intensive care course some years ago that I take that skill with me. That's the same in Victoria as it is New South Wales, is my understanding.
One of the other recommendations out of the rural and remote health inquiry was for 24/7 patient transport services, so that paramedics aren't used for transport that doesn't require their skills. What work's been undertaken towards implementing that recommendation?
So, is that a broader one?
Yeah, so I'm happy to answer that. So we've been working pretty closely with HealthShare, who oversee patient transport services across the state. It's not in all regional and rural local health districts, but we have made inroads in Hunter, New England, exploring where the actual demand is there for PTS, and that was in consultation with local paramedics actually that we met with up there with Mrs. Taylor when we were up on a bit of a countryside tour. And we have put that in place, and that has been able to demonstrate a decrease in reliance on the ambulance service in those areas. There still is protocol where some transports will have to be transferred over to patient transport from patient transport services to New South Wales Ambulance Service, depending on the criticality of the patient or the acuity of the patient, and some disease processes or types that may not be able to be supported by patient transport services as well. But we'll continue that work with HealthShare and to look at all the places that we can utilise their services in order to decrease.
Sorry to interrupt. I've got 20 seconds left.
Yeah, sorry.
I'm delighted to hear that that's happening for Hunter, New England.
I know that's
what about
happening
the
across
rest of
the
the
state, but that was just one specific example. Yeah.
All right. I'll let the 8 seconds run out.
Oh, can I ask one quick question?
Yes.
Mr. Binns, can you tell me the head count for the ones that have come and the new ones, like the retained as opposed, because you said it was a 10,198 total.
Yep.
So can you give me the head count?
If I may, Chair, I'm just going to go through 6 numbers, and because I think I might have crisscrossed earlier in my evidence.
We're back to the opposition's time, so you'll...
Yeah.
you're
Oh,
more
sorry.
than-
No,
Yeah.
oh, okay.
You go.
Okay, so...
My team want to know, they're very excited.
The new FTE recruited with incentives is 1174.59.
Right.
The headcount recruited new with incentives is the 1350 that I mentioned previously. The existing FTE retained with incentives is 7280.17.
That's the head count?
No, that's the FTE of retained existing.
Yep.
And the existing head count retained is 10,198.
So
those are completely accurate.
Okay.
With respect to Wollongong and John Hunter, they are in modified Monash level 1 locations.
Okay.
So they're outside the scheme's purview in the sense that the scheme is about rural and remote.
Okay, I'm really pleased to hear that. Thank you.
And the last thing for completeness, the total annualised spend associated with all of those numbers I've given you, as at yesterday's report, is at 51.809 million.
That gives you a lot of million left to use.
Subject to requirement, yes.
Sorry, you go.
Yeah, no.
Thank you.
No, thank you. I've got a few questions. I suspect they're for Dr. Chant in relation to the implementation of VAD, which I think is 28th of November is the rollout, is that right? And I've been looking at the clinical practice handbook, and look, tremendous resource, and I think will be very helpful for everybody, and I can see a lot of work has gone into that. Some questions in relation to how conscientious objection is being handled. I understand from the clinical practice handbook that the process means that the first step is that there's a first request form that is filled out, and that is submitted to the Voluntary Assisted Dying Board. What information will be on that form?
So the information, just to be clear, the information the conscientious objector has
Oh no, just generally what information is on the form. Yeah.
So all of the demographic details, the person who's requesting it, general information. I'm happy to provide you for the sake of time, a copy of the
that
form.
That would be great. Thank you. No, that'd be very interesting. And who has access to that form?
So we've constructed a total separate secure portal that practitioners that are that practitioners can upload the data. So if you currently go to our website at the moment, you will see the introduction to that portal where people are able to register at the moment to be an authorised practitioner. So so at the moment you go in there, you log on, you enter your details, including your ARPRA, you upload identification details. Our staff then look at whether you meet the eligibility criteria, so there are requirements under the Act.
Sorry, can I just stop you? I thought that there would be authorised practitioners, but that any medical practitioner who receives the first request has to upload the first form?
That's correct. So I'm just
Right.
describing the portal. So the
Okay.
portal exists there at the
Yes.
moment, so you can go in and start looking at the portal.
Right.
Obviously that will
Okay.
then be expanded, for that portal will then take on the function of where forms will be uploaded.
And the form's uploaded and is stored how?
Securely in through an IT framework.
Okay.
We've gone out to tender and procured it. We're in the testing phase of that, and we'll be finalising the test environment in a couple of weeks.
Mhm.
And obviously, it won't go live until the 28th of November.
Yeah.
But there's been a lot of work with a lot of clinicians. It's very. I saw a run through yesterday. It's very sequential,
Mhm.
and it will allow the board support the functions of the board.
And so the first request form is filed if the doctor who's received the request happens to have a conscientious objection. That's recorded on the form. Who has access to that information? What are the privacy protections for the information in relation to the doctor?
Just like all health information, so it's under the whole health information form, but these are available in the context of to support the functions of the board. So I think people need to understand this is very secure information. It is treated like other health information.
And what other purposes could that information in relation to the doctor be used for?
I'm sorry, I'm just not sure what you're getting.
So could it be used, for example, if a doctor was applying for a different position or something to provide information in relation to a work review or something like that?
No, I couldn't see a circumstance where it would be used for that purpose.
No, that's great. No, thank you. All I'm seeking is clarification. That's all, just to fully understand it. In relation to junior doctors, so as I understand it, they often require recommendations from consultants, especially those perhaps on a training program, and those recommendations are important to progress their careers. What thought's been given to a situation where a junior doctor may have a conscientious objection but the consultant with whom they're working does not, so that their conscientious objection doesn't impede their career progress?
I think that I'd like to say that in implementation of voluntary assisted dying, it's been a privilege to lead the implementation and just acknowledge the work across the ministry. It's not just been our division, there's been work across the division and the local health districts and all
and I acknowledge it's significant work that's been done.
At all points, we've just been respectful that the Parliament has made this a lawful option, but also has put in significant protections and acknowledged people's ability to be a conscientious objector. So like all other things, people's views and personal beliefs should not impinge at all. And that would really be for my colleague, Mr. Minns, to discuss how if anyone's personal beliefs, views, religious issues were at all taken into account in any career progression. So,
well, if I can assist you, and Mr. Minns, I'm also happy to get your views. That example is taken from an article written by University of Queensland academics Lindy Wilmot and Ben White, who drafted the Queensland VAD bill, and their paper that they've published argues that the right of conscientious objection can be an obstacle for the career progression of junior doctors. And so I was just wondering, looking at the difficulties they have flagged for career progression of junior doctors, how the New South Wales system had been designed to prevent this becoming an issue in New South Wales.
Well, I think that it's important that whilst I'll get Mr. Minns to comment on it, it's really important that we see a lot of these issues as general issues. So it might be around the fact that someone's got a particular view around voluntary assisted dying. It might be a particular view about another thing that persons hold dear. We as a system should not factor that into their career progression. And so the usual pathways would be at play, but Mr. Minns.
Yeah, so we'd see that sort of consequence for someone in that situation. We'd see the exercise of that sort of decision making as being inconsistent with the code of conduct. So you know, people
Sorry,
have,
could you just say that again?
well, people have a right to have their view, and they have a right that the Parliament has provided
Yes.
with respect to non-participation. So they should not therefore suffer a discriminatory response in the workplace. And if that was to occur, we'd consider it as a breach of the Code of Conduct, and they'd have a right to seek to have that behaviour reviewed and ceased. But it's an interesting point, and I might seek the reference that you've referred to.
Yeah, be happy to provide it. I was wondering, and I suppose I was hoping that rather than especially putting junior doctors and junior medical staff in a position where they're after the fact seeking redress, to what extent that New South Wales Health had been able to design into the implementation of this system proactive steps to protect conscientious objection and protect the rights of workers in that regard.
I think it's been clear in every document we've constructed around people's ability to do this, and we've also been incredibly respectful in our engagement, respecting the diversity of views and the fact that they're deeply held and profoundly held. And as I said, it is important that we protect people's rights to hold diverse views on a range of matters, and actually putting in that frame is probably the most useful in terms of linking it to the usual processes we'd have where people are experiencing these things rather than seeing as something unique. So we've taken a deliberative action that that behaviours that don't respect people in the workplace or cause that thing would be dealt with use our usual framework.
No, and I think that's a good approach. I noticed that the practice handbook at 22 discusses the issue of self-care. I couldn't, though, see whether any guidelines have been established, because if you think about psychological practice, regular supervision to make sure that the psychologist has self-care, and if you think about the nature of the work we're going to be asking the VAD practitioners to engage in, I wonder what guidelines have been established for them to have self-care.
So look, the impact on providers has been considered, and there has been multiple forums. There's actually going to be a clinical practice group that's been established, and a community of practice, because we feel that that's the best forum to provide that system. In terms of our Care Navigator service, which is the sort of one front door for people wanting to seek advice, built into their system, they've built in psychological safety and debriefs and really attended to those issues. So it has been considered. And I also just want to acknowledge the incredible help that other jurisdictions have assisted us with in understanding the insights and sharing the learnings. And we've taken that on board and built in those mechanisms which we think are most fit for purpose.
In the clinical practice handbook, it focuses largely on doctors. Just wondering, if I'm a nurse, if I'm a pharmacist, if I'm another healthcare professional, where would I go to look at processes for conscientious objection and protections around that?
So there's currently, there's been a series of webinars that we've conducted, which are broad-based with, I think, a variety of different groups, GPs, open to our local health district, open to our communities. We've done them with pharmacists as well. So there's been a lot of communication out there about the roles and responsibilities. On the website, there's also be a number of new information. So the clinical handbook was really tailored to those practitioners that are the authorised practitioners. Why it is so medically focused is that to be an authorised practitioner, it requires you to be a medical practitioner, except for the nurse practitioners can be administrating practitioners.
Perhaps again this raises this issue of responsive and proactive, and whether the responsibility, and I accept that this is a broader issue than this, and I think it's important that we locate it as a broader issue, but whether the responsibility should be on the healthcare worker to identify that there have been issues in their career progression because of views they might have and seek redress, as opposed to proactive statements and supports, and especially, I suppose, education of managers and those supervising them.
Look, I think it's a fine line. We don't want to braze our expectations that we would even condone or think that that could occur. I think you've raised the issue with us. We're very, cognizant of making sure that that happens in any of our engagement. But there's been a lot of work with our junior medical officers' presentations, and in all of those we factor in respectful engagement. And I've got to say that despite the diversity of views, I've always been amazed in all the sessions we've run around the respectful engagement that we've garnered in this, navigating this very difficult area.
Yeah, no, look, I think that's very encouraging. I'm aware from the Clinical Practice Handbook, and as you've said, that for medical practitioners and nurse practitioners, they must meet specific criteria, required clinical privileges or scope of practice. I suppose I'm just seeking confirmation that the provision of voluntary assisted dying services would be regarded as outside the scope of practice for many doctors in New South Wales.
Well, to be an authorised practitioner and fulfilling those functions under the legislation, you need to undertake mandatory training. So the portal also is the way to undertake the mandatory training, and that training takes around 6 to 8 hours to complete and involves also an exam to pass, so a multiple choice questions. There are also face-to-face sessions for those that choose not or would prefer a more hands-on or iterative style, and they are run both metropolitan-based and regionally. So,
with respect to that training, just a question that arises, and you're probably aware of the experiences in the Northern Territory with the Rights of the Terminally Ill Bill, and you may be aware of that article that Philip Nitschke was a co-author of after that, where he reviewed, made his patient records available, significant diagnosis of mental illness, treatable mental illness, including depression, in a number of patients seeking to access that service. What component of the training for providers helps them identify mental health issues in patients that could and perhaps should be addressed before the request process is finalised?
Well, one of the key aspects of rolling out voluntary assisted dying in New South Wales is really trying to embed where it's aligned to people's goals of care as close as possible to the clinical services in which they're engaging. About 70 to 80% of cases from other jurisdictions has arisen in the oncology space. Clearly, the handbook, as you indicate, has a section on capacity and what is reasonably to do for capacity. But in terms of assessing it, they're very experienced, and the Parliament has set forth requirements that they are more senior practitioners, and those practitioners are responsible for assessing those issues that might impact on the person's ability to make a commitment to, or express a informed desire and commitment to voluntary assisted dying.
So I guess, to paraphrase you, if I can test my own understanding, there is an expectation of clinical experience which would allow diagnosis, but there's no specific training that would help practitioners identify mental health issues that might that perhaps should be addressed as part of the request process.
I would expect that all of the practitioners putting their hands up for voluntary assisted dying would have, in the general course of their practice, many of them are general practitioners who would day in, day out assess mental health issues. They're the frontline health providers.
Can I just clarify though, Mrs. Carter, are you referring, when you say mental health, to competence?
No, I'm not talking. Sorry, excuse me. I'm not talking about ability to consent or mental competence. I'm talking about treatable depression or other things. The Philip Nitschke article in the Lancet clearly identified that there was treatable depression, and raises the question of whether that should have been addressed before the request process would be finalised.
So I think one of the safeguards that we've really tried to implement it as very much of the care of the individual. And so what we're actually saying is, if a person on a ward raises the issue of voluntary assisted dying with a junior medical staff, now clearly they can't accept a first request, but that actually should be dealt with as a need to explore, to raise with them more senior clinicians, and is it around pain management? Is it around access to palliative care? Is it around other psychosocial aspects? So in everything we've done in implementation, we've put the patient at the centre. So I'm actually very confident that the safeguards are there, and the Parliament has thought carefully around the prescribing the safeguards
I guess I'm
within
just
it.
exploring the type of training that is provided, and I think wanting to confirm that this is patient-centred and that all the issues that the patient has are explored, and I suppose also the concern about palliative care funding, that there is truly an option for palliative care that would sit truly alongside a VAD option, so that these are effective choices.
Absolutely. And palliative care, it doesn't matter if someone's in a clinical trial, it doesn't matter if someone's continuing aggressive therapy, it doesn't matter if someone is choosing to have... I would expect most of these patients to be engaged in palliative care. And when I mean palliative care, I mean optimum symptom control, optimum pain management.
Because I think Parliament was clear that what they were looking for was to provide choice, and you have to have properly funded and available and accessible palliative care in the city and in the country for there to be an effective choice available to patients.
Every component of the implementation, including with all of the practitioners that we've ever engaged with around this issue, and it's been extensive clinician engagement, we've really highlighted the importance that, someone raising voluntary assisted dying, it's an opportunity to check that all of those other things are not impacting on the decision. It's clearly outlined in the clinical guidance, and that's been the way it's been implemented. And very much that's why keeping close to the teams, and we also would encourage people, notwithstanding Parliament has allowed people to not raise it with, keep it separate from their families, or also not with their treating teams. We've really encouraged that it's as close as possible, because we feel that particularly that the treating teams will know best around the person's clinical condition, but also any psychosocial factors.
Can I just add one last comment to that? I think that in the normal course of things, treating patients for whatever condition or area of care they're in, our staff are used to referring patients to other specialists as well if an assessment is required. So, particularly in the case of a mental health concern where, perhaps further specialist advice was required, I can imagine that would be no different in these circumstances.
The Act actually permits that, and it specifies that expert advice can be seek, and the clinical handbook covers those circumstances where you might bring into question that you want to seek external expert, whether it be about prognosis or mental health capacity.
Great, thank you. Ms. Boyd.
Thank you, Chair. We were talking, I was talking to the Minister earlier about people with disability in particular. I understand that just before the election, Labor committed to allocate $800,000 to inclusive healthcare programs across 10 hospitals. They announced that in coordination with Dylan Alcott and his organisation GSA. Do you know if anything's happened in relation to that?
Deb, are you able to comment on that one? I'm certainly, thank you for your question, Member. I'm certainly aware of the Get Skilled Access and the work they're doing in an additional 10 hospitals, but as to where they're actually up to in terms of the work, I'd have to come back to you with some more detail.
Yeah, thanks. I couldn't see anything in the budget papers about it. It's quite a significant investment. 800,000. Yeah, if you could come back on notice, let me know where that's...
We're doing some planning work to deliver the training developed by Get Skilled Access in an additional 10 hospitals, consistent with the government's commitment. But if you want a detail on locations and just what they're doing, I can come back
and where
to
it's
you
up
with
to. Yeah, that would be great. Thank you.
you.
The latest Bureau of Health Information quarterly report showed that physical restraint was still being deployed at the Children's Hospital at Westmead at a higher rate than other New South Wales public hospitals. What's being done to address that?
I can perhaps start. Look, the challenge that we experience, and clearly restraint is not something that is a go-to first option, Ms. Boyd, for our staff. I want to make that clear. In respect to the children's hospitals, in particular, what we find there often is that it's one or two very highly complex children that contribute to those numbers, so that rather than a widespread use of restraint across a large number of children, there are, and you know, if our chief psychiatrist was here, and there will obviously be the mental health hearing next week where this could perhaps be further explored. But we do, of course, look very carefully at the Bureau of Health Information report in terms of any results that it provides for us, because it helps to guide where our work needs to go. When we've looked at those cases, in particular with the children's hospitals, that's what we've found. But Deb, are you able to add anything further to that?
Summarise that, Secretary. I don't have anything further to add. My understanding was it was down to one or two people in that
Have you looked into that? Is
Yes.
that you've
Yes.
actually got the data?
Yeah.
It was reported on the 9th of October. A particular boy was restrained after having open heart surgery. This is a person who is autistic and non-verbal. And there was a media report about the trauma experienced by that boy at the Children's Hospital Westmead. I understand that some of those are mental health episodes, but a lot of them are children with disability. What assurance can you give parents of children with disability that this is being investigated and is actually, as you say, down to a couple of people, as opposed to it being a systemic issue?
I think the first thing to say is that I'm aware of that article to which you refer, and the first thing we would say clearly as a health system is that the last thing we ever want to do is to let anyone down or to have parents or children experience distress whilst in our care. All circumstances where there is a concern or complaint made about, from patient or patient's family, they would be looked at and investigated, reviewed, and the family, first and foremost, communicated with about their concerns. We do seek to learn from any of those events. Obviously, these are very difficult situations for everyone involved, which is why, as I say, we look at the information that we're provided from BHI or whatever other report is received in regard to these matters, to find areas where improvements can be made.
Mm-hmm.
But our job is to look after people, and we never want to let anyone down in that regard.
Will New South Wales Health be adopting the recommendations of the Disability Royal Commission in relation to state health settings? In particular, recommendation 6.36 provides that state governments provide that certain restrictive practices are not permitted in health settings. Is that to be adopted in New South Wales?
Deborah, are you able to comment on that particular recommendation?
Yeah, because we are currently reviewing the recommendations in detail, so I'd have to, my apologies, come back to you on that specific.
Is there a timeline for when that will be looked at?
The work is currently underway, but we can certainly expedite and get you advice back on that particular recommendation.
Thank you. Are you aware of the one-stop shop clinic operated at Westmead Hospital, established by Dr. Peter Smith and Dr. Romana Afreen in 2020? Do you know about this one? This is providing opportunistic sedation to patients with complex and severe disabilities. Funding was secured for that clinic on a trial basis with, I think, staffing for 1 day a month. We also called for a similar model to be used elsewhere in the state, because obviously there is a huge need and demand for this service. Is that something that you are looking at continuing or rolling out elsewhere?
Take that on notice.
Thank you. If I can ask something totally different, in relation to the Kirkbride precinct, I understand that the Department of Lands and Property EOI for the Kirkbride precinct has been handed back to New South Wales Health to consider options for that site. I wanted to know why that's been stalled.
No, Rebecca, no one's...
Can you take that on notice, maybe?
Yeah, apologies, no, not across that.
It's okay. Are you able to provide an update on the final relocation for the New South Wales Ambulance headquarters in Callan Park?
So, I can start, and then probably HI can It's well known that we received a significant enhancement from the previous government to relocate to significantly more contemporaneous facilities out at the Sydney Olympic Park. The transition into that new facility is being done sequentially, so we've already got our education facilities in there. Previous tenant is now moving out of additional floors, so we'll be taking over the entire building, and then we'll be building a state-of-the-art control centre on the top floor and emergency management facilities. So we'll be moving off that site sequentially. The latest advice I have formally is that that'll be about mid of next year. However, us being off the Callan Park site will be totally dependent on us rehabilitating the current Everleigh Sydney Control Centre, which will become a state disaster recovery facility and training facility.
Right.
So the end date, I think, is from an ambulance perspective, we won't be fully off the Callan Park site, at least until 2025. And what happens after that? My colleague may have something to add.
Thanks. I can just confirm that the primary building works will be completed at Homebush later this year. There's then a significant amount of ICT and comms work that has to go into that. It's very high tech, and that, as my colleague says, will be around the middle of next year. And some of that's already operational, and the virtual care centre, which is very complex and high end, will be in a similar position, but for both of those dates. As to the future use of Callan Park, we are currently working with our property colleagues around master planning for those uses and what might be appropriate there.
Okay, thank you very much. We've heard a lot of reports of sexual assault of older women in the aged care sector. As high as 52 reports every week. I understand that there is a considerable overlap with federal responsibility in this area. Are you aware of those cases, or where people should be going, or who people should be looking to for responsibility in addressing that issue?
Member Garth, are you talking about terrible incidents like that in aged care facilities?
Yeah. Is there any responsibility from health for those issues, or is it entirely a federal issue?
It would be entirely a federal issue.
So.
But certainly if an elderly person, anything of the nature of sexual assault would involve police and be a criminal matter, of course. We do provide forensic services for such things, for sexual assault, elderly or otherwise, so perhaps we would have a role there. And if there was any follow-up care, physical or otherwise, for that individual, then certainly the local health district and ambulance would be involved in making sure that person was safe and had their physical...
But the systemic issue is more of a federal thing. Thank you. I appreciate I'm jumping around the issues here.
Member, would you mind if I just added to, if it's all right, Secretary, through you, to just a little update on the seclusion comment around the Children's Hospital. I just want to let the committee know a safety and wellness plan is completed for each patient admitted to the Sydney Children's Hospital's network, along with a sensory profile and a plan to ensure optimisation of therapeutic intervention and prevent avoidable risk of restraint and conclusion. Year to date, the acute inpatient units at the Children's Hospital has actually had 0 episodes of seclusion. And as to our response to your question...
Financial year or calendar year?
I'll be financial year to date, yep. Due to very complex needs, a small number of young people in particular, those with complex disorders, that's why we saw that above the state average in that physical restraint in that report. But we can certainly come back to you more, but I just thought I'd flag the nature of the sort of patient and family planning that occurs on admission.
Thank you. Just a couple more. The spending on the $52.7 million for 48 new sexual assault nurse examiners and medical and forensic officers. Are you able to give us any more detail on sort of where those nurses are located? Have they been hired?
We received the funding in this year's budget, which came in September, so we're currently working with the local health districts in terms of the nature of those positions. There'll be a combination of medical, nursing and allied health. It's a significant investment. There'll be around 48.1 full-time equivalent staff that will be spread across the system to enable care for women and children, or people and children, who are impacted by violence, neglect or sexual assault.
Will they be spread across the entire sort of evenly across local health districts pretty much?
Yes, look, I mean, you'd expect that the metropolitan areas perhaps, there'd be with larger populations as a percentage, a bit more activity, but certainly this is not a matter just for metropolitan Sydney. Our issue will be around recruitment and our ability, because as you'd be aware, they're a very specialist workforce. Part of the funding package actually goes to some training and retention issues, because again, it's a pretty stressful work environment and we really want to look after those staff that are providing these incredibly important services to the community.
Thank you. I think this is my final question. The other commitment from Labor was to the women's health centres, $100 million over 5 years. Just wanted to know how much had been spent so far and what the process was for allocating that additional funding.
I'm afraid I'm unable to advise you how much has been spent so far, but we do have a women's health framework, the funding you've outlined. Member, we're working with the women's health centres to identify what particular programs and things they wish to do within their centre, and so that we can match the funding to the sort of services and their population and demographic requirements at their centre.
My understanding is that additional money was to, basically they hadn't had any increase in their core funding since the 80s, was my understanding. We now have this increase, but I'm hearing that this money is now being sort of allocated per project instead of going towards that core funding. Is that, from your answer just now,
well,
that seems to confirm that? Is that right?
It is annual funding of $13.4 million to 20 centres across the state, and that annual funding is just that. It would be ongoing, so that would enable them to recruit staff or...
So it's additional funding,
yes,
additional operational funding?
That's correct. And a further $8.3 million will be allocated so that was 23-24, the annual funding, and then an additional 8.3 as part of the election commitment. There's also 2.1 million for Full Stop Australia. And so, these are annual funding for the women's health centres to report. But
not the whole 100 million then? So not the whole 100 million over, what was it, over 5 years? And the figures you just gave me, 13 million
so that's for
per
1 year?
Yep. But not, I would expect 20 million. So are you saying that the other...
I'll have to clarify the breakdown, but the commitment that you've described is accurate. I was just there. It's broken down into segments, but this is annualised funding across all those women's health centres. But I can give you the breakdown.
Thank you. That would be really useful. Thank you.
I've got some more questions about infrastructure. The first one's relating to Tweed Hospital, which was mentioned this morning. So I understand that the new hospital is opening in 2024. What is planned for the existing Tweed Hospital when the new hospital is opened?
Those deliberations are currently underway in consultation with the local health district, other health users, and also with Property New South Wales.
Are those deliberations regarding ongoing use of that site for other types of health services, or is there a consideration that site will be used for other purposes?
That will be part of the deliberation, whether it's surplus to health requirements for health services. There's currently an ambulance station on the corner of that site, and the local health districts runs some other services there as well, which will need to be housed at a location to be determined for that site to be surplus to requirements. But there's also discussions with Property New South Wales about potential other uses, particularly with the government's new priorities.
And what's the timeline for those deliberations?
I'd have to come back to you on that. They're ongoing discussions. And also, as I mentioned, with government's new priority around housing supply.
Thank you. What is the allocation in the budget for Grafton Base Hospital, and how is that broken down?
I can come back to that in just a moment. It's broken down. It's currently in its planning stage. So we're working with the local health district around what is able to be afforded as part of that redevelopment and what the prioritisation of scope might be and how that fits with the existing site master plan. And we're also undertaking various due diligence studies in that space around all sorts of normal issues that we investigate, like traffic and more accurately now flooding issues, which are of particular concern in that northern part of New South Wales.
Are you able to advise at this stage whether or not those plans will include an additional operating theatre?
I can confirm that, but my understanding is that there is operating theatres in the proposed redevelopment.
How does the current proposed redevelopment fit with previous clinical services plans for Grafton Base Hospital?
I'm sorry, I don't quite understand the question.
So I understand there's been several iterations of a clinical services plan that's been recently updated, and that previously funding was allocated for a previous version of the clinical services plan, but then that no building was done. So which version of the clinical services plan is the current funding for the redevelopment aligning with?
Our normal process of facility planning and design will be based on what the approved clinical services plan is at the time that we do that. And it will have a number of projections out to a particular year about what those requirements are, from which then inform a functional design brief and any concept planning which we do.
Okay, so just trying to clarify my own understanding, the funding for the redevelopment would be allocated based on the most recent clinical services plan and not the previous clinical services plan, which had funding for redevelopment allocated to it that never took place.
That is on occasion a little bit chicken and egg, depending on when a project's announced and what the status of a clinical services plan development or approval by the district might be.
Sure, but I'm trying to understand specifically for this one, specifically for Grafton Base Hospital.
I'd have to take that on notice.
Please do.
And the allocation, the total allocation for that project is 263 million.
Thank you. And what's the timeline for execution of that redevelopment?
The current intention is for it to be finalised in planning and go into construction within the next year to 2 years through that planning process, and a hospital of that scale would normally have a construction timeline of 2 to 3 years.
And I understand that there was about $1 million allocated as part of this redevelopment planning process. Can you just give us the detail of how that was spent?
I'd have to take that on notice.
Thank you. We've got a mixed bit of time left until 3:30. We can split.
Okay.
Yeah.
Do you want you go or me?
We've got 8 minutes, so we'll do 4 each.
Okay.
You
I'm
go.
happy. Can I please?
Yeah.
Okay. Could you please advise what funding has been committed over the forward estimates for the continuation of the ITAS program?
Sure. So, IPTAS for the current 12-month period has been budgeted $48.9 million, and we've seen significant uptake and usage of that over the last 12 months even, with an expectation of more than 45,000 people to be benefiting from it. I think we had roughly in the ballpark last year an additional 26,000 people using the scheme, and that's escalated from the annual expenditure last year being $36.6 million, which was an increase from $19 million in the previous year, and it being one of those services that we'll continue to do, and we've been very successful with the communication strategy around IPTAS. We expect that the uptake will continue to grow, and we're seeing growth of that usage of up to 16.5% in some quarter-on-quarter in some districts and usage areas.
That's amazing.
Yeah.
That's really great.
It's really good.
And so then, going forward, is that money there for this great IPTAS scheme to continue?
Yes.
Yeah. Can you tell me the figure, please?
The actual figure is still the hang on a second. The total figure is 149 across the next 3 years.
Okay. Okay. All right. And that's well, that's really exciting. I congratulate everyone on who's done that, because that's really terrific to see. I'm very excited about that. Ms. Wilcox, I'm very tempted to ask you all about the menopause stuff, but I have so many questions I have to ask. I'm not going to say that for the women's budget estimates. It's one of my favourite topics, as you know. Please, can I ask about the Coolum and Ganmain MPS? And can I ask if a development is on New South Wales Health list for the upgrade?
Take it. My recollection is it's not currently on the list of a health infrastructure project.
Okay. That's right, okay. Because the Corman Ganmain MPS was listed as the #1 priority for the Murrumbidgee Local Health District. Am I correct in saying that? Do I remember that correctly?
I'm not aware.
We'd have to take that on notice.
Yeah. Please, would you mind taking that on notice? Because I'm happy to be very wrong on that, but I thought that was the #1 priority for Murrumbidgee Local Health District. So that's not on any priority list anymore. Would I be correct in saying that?
I think we have to take it on notice, Ms Taylor.
Okay, no worries. Thank you. Thank you very much. Can I please ask now about Gunnedah Hospital? There are several health infrastructure projects in the development across the state. I'm just wondering with Gunnedah, and I do understand the history on this, but I have been told, and I just want an answer, I guess, on that, is that it will no longer receive renal or chemotherapy service as part of the hospital upgrade. Would that be correct or incorrect?
Happy for me to answer, Secretary?
Yes, please.
The build contract for Gunnedah, I'm pleased to say, has just been awarded.
Oh, that's great.
There has been a prioritisation of what has been able to be included in that, and that's because of escalation of costs from what was estimated at the time we went to tender until the time we awarded.
So, Ms Walker, I completely appreciate this position, but so basically the renal and chemo services which were planned to be there won't be there anymore.
I can check that for you.
Yes, please. Thank you.
Sorry, Mrs Taylor, if everyone mind. Sorry, just one correction. So
Yeah.
not 149199 for IBTAS across the forwards.
Okay, thank you. 199 across the forward. Thank you very much. That sounds better.
Yes.
I was sort of
that was the
excited
typo.
but not excited, but thank you. That's great.
I'll jump to a completely different topic. In May, the Therapeutic Goods Administration approved what's been called the plasma pathway to broaden eligibility criteria for plasma donation to LGBTQIA+ communities who've previously been excluded from donating blood products. Has any work been undertaken to prepare promotion of the broadened eligibility criteria, taking into account the risks that both Lifeblood and LGBTQIA+ advocacy groups have raised about the risk of re-stigmatisation?
We work closely with, so the information about this will largely come from the Lifeblood, sorry, just correcting my name, Lifeblood, in terms of the promotion of this. But clearly we have good links with our community, and we would be happy to work in partnership with Lifeblood. We have a lot of collaboration through a number of committees, and so Lifeblood hasn't raised the need with us to assist with that component, but I'm aware of that.
I understand that the Queensland Health Minister has also written to the federal government urging it to expedite individual risk assessment for whole blood donation, which I understand is international best practice based on evidence out of the US, UK, Canada and Israel. Do you know if New South Wales Health has had any engagement with the federal government about progressing individual risk assessment?
I know we've had general discussions with Lifeblood about the policy setting in this space, but I'm not. I would have to take it on notice in terms of any particular correspondence.
Okay. Yeah, happy for you to take it on notice. Jumping back to ambulances, sorry, very wildly different topics today. I understand that a number of volunteer ambulance stations, particularly in Western New South Wales, have been given Toyota Land Cruiser vehicles to use as ambulances, and it's been reported to me that there have been cases where it's almost impossible for volunteer paramedics to get the trolley into the ambulance, and very hard to work on the lower half of the patient in the ambulance because of cramped conditions. How were the Land Cruiser ambulances selected for that purpose, and is there a plan to review their function?
Yeah, it's actually fairly straightforward. There were
the fleet of former troop carriers were all replaced. There were 81 vehicles statewide that were replaced. There were 4 volunteer ambulance services, which are historical ones, where they were also using those ambulances as the primary transport vehicle. The Land Cruiser the 200 series is actually only a retrieval vehicle. That was and at these 4 locations was immediately raised by the local health district. We've swapped those vehicles out as an interim solution, and we'll be moving to a Mercedes 4x4 all-wheel drive vehicle, but there are delays bringing into the country. So the issue's been identified, addressed, and we have a long-term solution.
Thank you. I'm very pleased to hear that you're aware of the issue.
Yeah.
Is there a timeline for the arrival of the new vehicles?
That's going to be in the lap of the getting Mercedes Sprinters out of Germany. There is a really long.
Mercedes ambulances is what we've historically used.
Yes, but these are 4-wheel drive ones.
Yeah.
The ones that we use for normal class 1.
I get that it's clearly slightly not known specifically, but are we talking about weeks, months, years? What sort of time frame?
Look, I'm going to say it could be 6 to 9 months. But where we are at the moment is they've got exactly what they had immediately before the change. So we've already moved the 200s out and they've got the same vehicle, is my understanding, as they had immediately before the change. And we do have a practical solution, which will actually be an improvement overall.
Okay, thank you. The bill's about to do.
Chair, could I just go back to one of Mrs Taylor's questions?
Sure.
Just in relation to Gunnedah Hospital and the chemo and renal dialysis, those services will continue to be offered at Tamworth, so they're not affordable in the current construction contract.
Yeah, no, thank you. And I just, I got that. But thank you. At Tamworth, but no longer at Gunnedah. Okay. Please, may I?
Sorry, we're breaking for afternoon tea.
At Gunnedah, but they're no longer in the proposed build at Gunnedah.
Understood. Yep.
Sorry, Mrs Taylor, we're breaking for afternoon tea.
Oh, sorry. I'm not holding
That's
anyone
all right.
back.
You'll
from
have more
food.
time this afternoon.
Yeah.
I'll be grumpy if you don't. before we'll resume the hearing, I'll first go to Mr. Minns, who had a follow-up answer from an earlier session.
Thanks, Chair. Two things to clarify from your questions earlier in the day about safe staffing levels. Clause 8 of the MOU that has been signed by the Association and the Ministry specifies that we are seeking to complete the birth rate plus review by June of 2024. And there have been 4 meetings to date. And with respect to Level D facilities and MPSs, they are both in scope in respect of the MOU, but there's more than 80 sites and they're quite variable in their size, scale and scope of practice. So they're sort of next in our area of examination. Some Level D facilities have a Level 3 emergency department. There's about 6 or 7 of them. And so they will be in scope for safe staffing levels rollout through the emergency departments part of the MOU, subject to the budget envelope that we have available based on the decisions that the government has made with funding. And so those sites are Leeton, Cootamundra, Narrandera, Tumut, Byron Bay and Parkes. And there is, in fact, I'm advised, one Level D ward with a current nursing hours per patient day ward, and that is Camden Hospital Rehab Ward. So that will be in scope for the NHPPD part of initial rollout.
Thank you. I have follow-up questions, but I'm aware that it's the opposition needs to start first, so we'll go to opposition time.
Okay, please may I ask in what new locations has the government allocated funding for key health worker accommodation?
Yes.
Luke, can you
I certainly
respond?
So, key health worker accommodation, funding and delivery. So we have, working with, including regional New South Wales, working to deliver it in Far West, Hunter, New England, Murrumbidgee, Southern and Western.
Please may I have the new ones?
So the new ones?
The new ones that this government
being
is doing?
Far Western, Far West LHD, MLHD or Murrumbidgee LHD and Southern New South Wales Local Health District. So for them, the ones that Hunter's completed, Murrumbidgee will be delivered in Finley, Leeton, Narrandera and West Wyalong. Southern will be delivered in Cooma. I think they're exploring.
Mr. Sloan, these are all ones that were already coming because I did the first sod for the Cooma ones. So I want to know what are new ones that weren't already planning, what the government has announced since the budget that's going to be put into key worker accommodation. I'm so excited about all the ones that are happening, don't get me wrong, I'm beside myself with excitement and I think that's wonderful that they're progressing, but I want to know where the new ones are going that have been newly budgeted for.
So at the moment, the regional housing package that was from 2021 is still being worked through and delivered. To my knowledge, I don't think there's been any other commitment with regards to key worker accommodation for health. We're working through that with Department of Regional New South Wales, Department of Education, and soon.
Yeah. But yeah, thank you very much.
There has been a commitment.
So can I just say, and please correct me if I'm wrong. So the original $15 million key health worker accommodation will be completed. That's going to continue, but there's no new money to do any more new worker accommodation.
There's ongoing funding.
Yeah, ongoing, yeah, the 45.3.
I know it's ongoing, but is there any new funding?
The information I have is the government's continuing to fund $45.3 million towards health worker accommodation.
Okay, but no new. Okay, thank you. I've answered my question. And I completely appreciate the difficulty in getting staff, so please don't think this is a question trying to, it's not at all a gotcha, because I myself we had massive issues, as you know, but I was just wondering how we were going at Nyngan and Wee Waa health facilities due to staffing challenges. Has there been any better news, Mr. Sloan, or how's it going?
Look, I would love to say that there has been better news. It's still very difficult for both of those sites to recruit for a wide manner of reasons, both Wee Waa and Nyngan. There's been working parties set up in both locations with the local member very much included and kept in the loop by the local health districts for both of those working parties. Incentives are applied to all of the rolling ads at the moment that they've got out for those. And work continues to try and either attract people to those sites or operationalise other people to come across to those sites as well.
And look, I won't. I will not criticise that because I understand how hard. And can I just say thank you for continuing to try and do that, and really appreciate everything that you're all doing in that space. And it's just really tough when you hear those great numbers. You just wish that.
Yeah.
But I understand, and hopefully maybe next estimates you'll be able to have the best news that Nyngan is up and going. So that would be fantastic. Secretary, please may I ask, and this is self-indulgent, but how can you provide an update on the Ombudsman and the Healthcare Complaints Commissioner work that was happening in terms of a response to the Rural and Regional Health Inquiry?
Yes, I can, and Phil may be able to add to this, but my understanding is, obviously, well, I'll go back a step. First of all, we'd continued our discussions with the HCCC and also the Ombudsman's Office in respect to the recommendation arising from the Regional Health Inquiry. In this year's budget, I believe the Ombudsman has been provided with additional funding to enable them to have a greater area of focus on health within the Ombudsman's Office. So it's a good outcome, noting that we had given advice that, the Ombudsman obviously already has significant powers, as does the HCCC. Rather than creating a separate and distinct body that would just add to bureaucracy, this will enable the Ombudsman, through their existing processes, with some additional funding, to be able to pay further attention to health as it's required.
And will that then be communicated to health staff that other avenue will now exist?
And again, I might turn to Phil for any think he has to add. We did send out, and look, forgive me, I just cannot remember the month. We did send out across the health system at some point, either earlier this year, I think it was earlier this year, advice to all of our staff about what is available to them with respect to making complaints, including local what's available locally, whether it was to the ministry or to other bodies. I will restate again, though, clearly our preference is for our staff to feel that they can raise issues with their manager, and if not their manager, then another senior person within an organisation. The ministry is always available to people if they have a complaint to make, because we do take those matters very seriously. The Ombudsman exists if people aren't comfortable with that. We also refer issues to the Ombudsman if we're unable to resolve things for people.
Yes.
But certainly we absolutely will communicate. But Phil, did you have anything to add on that?
Thank you, Secretary. You've answered my question. I appreciate that, and I do acknowledge how seriously you take anything like that, and I know that you even meet with people yourself, and I thank you greatly for that. Can I please ask what the budget expenditure for PACER is, and if there's been any new funding?
effects of cannabis.
Sorry, Ms.
Sure.
Fairman, you might not have heard, I know you're on WebEx,
I didn't hear.
the bell
Yeah.
rang just as you were asking that last follow-up
I never
question.
hear the bell.
Spoken like a true crossbencher. Sorry. I've had enough now.
To the opposition.
Oh, is it on? You go first.
Okay.
Yeah.
I just wonder, and I'm not exactly sure, apologies to whom these questions should be directed. It's really about some updates on hospitals and services. Where are we with the Rouse Hill Hospital?
The government announced additional funding in the budget. We're in the process of working with the local health district around master planning and doing functional briefings and concept designs for how that might be incorporated into the larger budget.
Yeah, I understand it's a $700 million commitment, but $5 million was allocated in the budget. How far will you get with $5 million?
That will, I'll have to check the current year's budget, but that will assist in the planning work which is being undertaken.
Right, okay. So if I can summarise for the people looking for that hospital, there's some money for planning, but nothing else?
I think we're intending to start early works on that as well. But we are in the process and we need to finalise the statutory authorities' approvals in that space as well.
All right, thank you.
If I might just add, Ms Carter, that the early works are intended to start early next year with a completion date in 2028.
Great. All right, thank you very much. And we talked earlier about various palliative care units that are being redeveloped in New South Wales. I'm wondering, I couldn't see any funding in relation of allocation for palliative care units in Goulburn and the Southern Highlands region. Can anybody help me with palliative care services in those regions?
Ms Carter, I'd have to double check that, what's available in both those hospitals. I can come back to you.
All right, no,
it'll take me a moment.
I'd be very grateful.
Would you mind, Ms Carter, could I just add to something you raised earlier around the care of our Aboriginal patients in palliative care? It's just an important matter to come back to you because you raised it. It's very important to us as also.
Yes.
A couple of things. There are around 18 Aboriginal health workers in palliative care located in the districts around the state. There are some LHDs where they've been unable to recruit, and so we're working with them. Mr Minz's team has an Aboriginal workforce unit and they're assisting in that. We also have a senior policy officer. It's an identified position for an Aboriginal person in palliative care, so they're absolutely focused on Aboriginally appropriate, culturally appropriate models of care for our Aboriginal citizens. And we have a Aboriginal palliative care network in the ministry to which the Aboriginal palliative care health workers are members. So just wanted to reassure you that it is an important
thank you,
part
because
of what
it's
we're
important
doing.
that
Thank you.
culturally appropriate care can be provided for all the members of our community. Thank you.
Thank you.
Ms Carter, may I go back to one of your Rouse Hill queries through you, Chair? The $5 million which you mentioned for this fund in the current budget, that was out of the additional $400 million. There's also 27.797 for works in progress from the original $300 million.
Great.
So it's actually much later, which is why I stumbled a little around the early works, which I knew that we had commenced. So there's substantially more than the $5 million.
Great, thank you very much. Thank you. And I'm just wondering where we are with the ambulance station at Sutherland. Is the New South Wales Government still committed to developing an ambulance station at Sutherland?
Yes, absolutely. It's we undertook modelling in preparation for the investment under the last government that identified 30 locations around the major capital city and peri-urban areas, and definitely the Sutherland station was one of them.
And with respect to location, has a site been selected in Sutherland?
No.
Has a shortlist been developed?
No, but my understanding is there is investigations being undertaken, but there's no shortlist at this time.
So the process that we follow at Health Infrastructure is New South Wales Ambulance will give us a zone based on their modelling of a geographical area where the site should be, and then our property team works with the ambulance team about potential sites, and then we do due diligence on those sites and go through a property acquisition process.
And do we have a timeline on that for Sutherland?
I'm not able to give you one today. It is in the list of 30.
Okay, so the people of Sutherland don't know when to expect the new ambulance station?
So I think it's important to note that's actually a now 6-year program overall. So you can imagine the timing of all of these programs was actually out to what the organisation's asset needs were over the long term. So it's not as if we're sitting there saying, you know, goodness, that's the one that we've got to have tomorrow. You would know better than I, but there's substantial development in that area, particularly around residential, and this will position us very well. And the truth is that's occurring right around the Greater Sydney metropolitan area.
Yeah, thank you very much. And staying on ambulance stations, just wondering in relation to the Narrabeen ambulance station, which has been announced for closure, and the building of a new station at DY, what funds were allocated in the budget for the new ambulance station at DY?
So that's part of the 30 as well. So this goes right back to the announcement under the previous government. What happened there was a previous Sydney metropolitan infrastructure program that paid for the construction of Mona Vale ambulance station, and you would recall that Mona Vale Hospital closed at that time. What that did is basically Mona Vale is 6 to 8 minutes from Narrabeen, and Narrabeen is actually 21 minutes from Balgowlah. So the introduction of Mona Vale changed the network, and the modelling showed that there was if you were going to replace Narrabeen, you'd move it slightly to the south. So by doing this, we'll actually get a really good footprint between Balgowlah, DY/Collaroy, Mona Vale, and then up into Avalon.
So when will the Narrabeen station close?
Only after the new station commences.
Okay, so it will stay open until DY is available.
Absolutely.
And are there any issues, because I am informed that that there will be different paramedic services available. Will there be intensive care paramedic services available north of DY when these changes are made?
So Narrabeen is a Category A intensive care station, and that will relocate to DY.
So DY
becomes the intensive care station for that area.
Thank you.
Balgowlah.
Yeah. Thank you very much. And we've spoken a lot, as is I think appropriate today, about health services in Western Sydney, and we've also talked at the importance of community engagement with raising issues. I'm sure everybody's aware of the issues that have been raised by the community in relation to Blacktown Hospital, especially reports of people sleeping on the floor of ED for 19 hours. I just wonder what sort of what the response to that community engagement is, and what we might expect to happen at Blacktown Hospital.
Thank you, Mr.
Graham Lawyer, the Chief Executive of Western Sydney Local Health District, has a very active community engagement forums across his hospitals. It's one of the many strengths of Western Sydney LHD. He's also conscious of both the population and the performance pressures on particularly Westmead and Blacktown hospitals. Graham has, and the team at Western Sydney and the general managers of both those facilities have taken advantage of funding growth over the last 2 years in particular. We've seen significant both medical and nursing staff in both emergency departments, and the growth in those areas has been complemented and supported by the growth that was delivered in this year's budget. Western Sydney probably received negotiated the highest increase in NWOW activity, conscious of their of the populations that they serve. There have been some good incremental improvements for both emergency department in terms of transfer of care and also triage. Are they in the middle of the pack in relation to all of Metropolitan or all of New South Wales? Frankly, no, they're not, and the team there are very conscious of that, but they're working and they are moving it in the right direction. but that they will need more time, particularly Blacktown's fairly unique hospital, and I've seen this many times before about metropolitan hospitals slowly emerging and growing into teaching hospital status and the pressures that creates.
I understand they have a lot of pressure. I'm sure the staff are doing the best that they can, but when you use words like incremental, I'm just wondering, and will need more time, for the people of Blacktown who are waiting the best part of a day before they can be seen. I'm just wondering, what does incremental mean in practical terms? How long till people can be confident using their local public hospital that they will get the treatment that they need?
Well, certainly the quality and safety of care at both facilities is very heavily monitored by the Clinical Excellence Commission and also a unit within my division of the ministry. The incremental care, well, it's a constant work in progress. I meet with chief executives, including Graham, every week in relation to their ED performance, and we're blessed with data and information systems where we really can monitor these emergency departments within an inch of their life. And I'm not going to sit here and say that everything is rosy in both those EDs. It's about recognising that they have a problem, and the staff there do. They are also moving it in the right direction.
Okay, thank you. I have a workforce question, and we were given some really helpful figures earlier today in relation to where I think the figure is 1,112 nurses will be working. It's good to have those LHD figures, but I wonder, is anybody able to help me with, for example, the 138.2 nurses who'll be working in the Hunter? How many of those will be emergency department nurse practitioners? How many will be midwives? How many will be have surgical expertise? What's the breakdown? And I suppose a follow-up question, if I may ask two together: how do you know who you need where?
So I think the same answer applies to both questions. That we're a federated system, so in the ministry we work on things like the large recruitment for interns, for nurses and midwives that we think the system needs through what they tell us. We engage in workforce trend planning. We link that to all of the data we have about future growth in the health system and growth in demand. And we focus on the future pipelines of supply for all of our clinical disciplines, and we include access to websites for graduates who have the ability to sort of look at the future supply pipeline across our different clinical roles. So we do that at the centre, and we can't do it without the input from the LHDs. But once a performance agreement is achieved with an LHD and they're given their allocation of funding, they are making those resource allocation decisions based on local consultation with both their community and with their clinical community. So we
how
don't.
is it then that you go, okay, that the centre would say, here's 138 nurses without knowing what they need?
So what happened with the 1112 when we did it was we looked at a series of data points when we were in the middle of COVID, and how do we take a bucket of available relief and distribute it as sensibly as possible. So the team would have looked at a whole lot of workforce metrics and demand metrics at the time, and that was the allocation that gave rise to the numbers. But where a district decided to deploy those nurses and midwives was a matter for them. And really, we don't think we're in a position to be able to make those calls from the centre.
I suppose what I'm trying to understand is how the centre can know what the pipeline needs will be because a nurse is not a nurse is not a nurse, and what the special skills are, and even in decisions, the scholarship program to support more people entering nursing, was there any thought given to whether perhaps there's a need actually to support existing nurses to upskill At what level are those sort of decisions being made?
So we have a nursing and midwifery office that is the professional development arm for the nursing and midwifery workforce. So they are in contact constantly with the directors of nursing in the districts, and we have several existing programs that have been run for many years that are targeted towards encouraging people to do particular postgraduate work and study to gain additional qualifications. So that's just occurring all the time, I think is what I would say. But that detailed workforce allocation, where's the best place to put it at one point in time, we leave that to a district to determine. And the other point to note about our workforce is, and it's sometimes not well understood in the public domain, we don't have a workforce that is static. We don't hire people and they just stay there forever. It's a system with 170,000 headcount in it, and they're moving around all the time. And they are being moved around in response to issues around demand, and there's a serious seasonal trend available each year that basically reflects the demand that we face across a calendar year because of things like the effect of winter, the effect of respiratory illness, and then the impact of the Christmas period when things like elective surgery go into a slower rhythm. So it's a very fluid workforce that is constantly got movement in it.
Okay, thank you. I anticipate you may have to take this question on notice, but I'm wondering if you have, and if so, if you can provide us with a list of all contracts for training or consulting which have been awarded to a union.
Yeah, I'm sure we can have a look and see if there are any and make that information available on notice.
Thank you, I'd be grateful.
I was just going to wonder, you'll have to hold up the face, but my question is, will the new Illawarra Regional Hospital open with intensive care and level 4 services?
Can you take that one? Thanks, Ms Taylor. So yes, a lot of work and planning going into Illawarra, as I'm sure you know. The hospital will open at a level 4, but in terms of the intensive care unit, as you would also know, that in terms of building up the capability and the training and the skill set to move any hospital from one level to the next has got a bit of a lead time. When you open a new hospital, the commissioning time is probably the most, risky in terms of making sure the staff are settled in and everybody's familiar with their environment and their flow and models are all working. So the discussions that are going on now with the clinicians and with the local health district are the planning to get to level 4, and that work is underway. But I think we need to be cautious around saying that we will absolutely open on day 1 at level 4, but that is the commitment and we are working to it. Our main focus will be quality and safety and making sure those staff and that capability is ready, and recruitment for these positions that are required once you get to level 4, such as an intensive care unit medical director, is not easy in the regions. Again, a subject that you know well.
I really do, and I am not trying to be difficult.
No.
I understand, but I suppose for me, I'm just prosecuting the case with the local member that has always been really insistent down there that it will open at a level 4, and that was the commitment that New South Wales Labor would give. I understand the difficulties, I understand what you are saying about the transition program, but I'm just trying to prosecute that in my role in the opposition now, and I guess that's just what I wanted to know, because I'm a little bit confused, because you did say it would open as a level 4, but then you also talked about how difficult, and I understand it's safety and quality, but we all know what a level 4 constitutes, and will it be opening at a level 4?
The hospital itself will have a role delineation of level 4, but within that, services may have...
So it has the potential to be a level 4?
Just the intensive care unit. The current thinking is just in terms of the safety and quality and the commissioning components and building the workforce may require that we start at level 3, working in a very reasonable period of time to get to a level 4. But we want to make sure all of the appropriate elements are together, but the hospital itself will be at a level 4.
I understand, and I really appreciate your answer, and I didn't want to put you in a difficult spot, so thank you very much for that. I think I'm done, thank you, Chair, with 40 seconds to spare.
Thank you. I'll take your 40 seconds.
Okay.
Just coming back to the recent New South Wales Government inquiry into ramping and access block and some of those recommendations, so particularly around pharmacy. There was a recommendation around implementing partnered pharmacist medication charting in hospitals. Wondering if there's been any work done towards considering that implementation.
I'd have to take that on notice, I'm afraid.
On the UTI trial.
There was also a recommendation about increasing the number of public hospital pharmacists so that their availability better matches emergency department availability. I understand there's a significant number of new positions being promised in New South Wales Health. How many new pharmacist positions in the public hospital pharmacy workforce are being created as a result of this budget?
I need to take it on notice, Chair.
Okay. What work is being done to attract and retain new pharmacist interns?
Well, we're doing general work about what we'd call the attractiveness of working in New South Wales Health. So the last few years have probably created two reputational brand issues in health. One is that people have admired the health system and taken the view that it played a critical role through COVID, but there's also a narrative that's about people being tired and the data we have about burnout through the People Matter employee survey. But we've spent probably about 6 to 8 months working with our staff to understand why they like working in New South Wales Health and how they express that and what are the things that they think are the advantages for working in New South Wales Health. So with that work, it's pretty much finalised, and we're in the position now of working with broader government to look at an attraction campaign that we might conduct that tells that story of our own staff about how they value, why they value working in health. And that's likely to involve some expenditure in social media and in other forms of advertising to get that internal employee narrative out there about why a career in New South Wales Health is appropriate. And we're trying to build a toolkit of resources that can be used by all of our health entities. So it's a message about New South Wales Health, but it can be picked up and used by an LHD or one of the pillar organisations, and we can also overlay a occupational lens to that, which would be available for pharmacists.
Okay, thank you. I'm glad to hear that work's being done. New South Wales Health should be the best place for any health worker to work and should be perceived that way as well.
Well, it is by a lot of our staff.
Yeah. And I'm just interested because your answer has focused on the sort of reputational and brand issues. Does that mean that there are a number of hospital pharmacist or hospital pharmacist intern positions that are currently vacant?
I don't think so. I will take it on notice to give you a precise answer, but if the area where we're sort of seeing a pattern of challenge around graduate recruitment is mostly in medical intern in rural and regional, and it's, we're currently sitting at about 65 available places for new interns to commence in the next clinical year, but we've got the other 1,280. So, that bothers us because of how it impacts the system if we don't get those new medical interns. But it's not a huge order of magnitude. It's a little bit more than last year. And we will look at international medical graduates earlier in the process of recruitment to see if we can use that as a resource to deal with that gap. There has been at times a view that the COVID and its aftermath and some of the narrative about it was impacting on enrolments in medical related disciplines. I don't think that is now the view still of the university deans. I think they've seen a sort of swing back to more healthy levels of student interest and in enrolment. So I just think it's timely for us to to have our own staff speak to what they value about working in this system. And one of the things they value is the fact that it's such a huge system that their career opportunities are really quite considerable. And there's about 5 key themes that have come from those staff engagement sessions.
Sure. You didn't quite answer my question. I let your answer run because the medical intern piece is obviously really important as well, and I was interested to hear about what's happening with JMOs. But my question was about intern pharmacists rather than medical
so I'll
interns.
have to take that on notice. But no, it's not been raised with me as a looming, issue that's different to normal trend. But I'll certainly take it on notice.
Thank you. While I've got you, Mr. Mins, I'd love to come back to the nursing staff in question. I was grateful that you came back to us after lunch with the information about Level D hospitals, and you told us that there is one ward in a Level D hospital that is in an HPPD ward. Does that mean that all other wards in Level D hospitals are not within the scope of the safe staffing task force?
No, it means that the mechanism by which something might change in the way that we staff those facilities will be where we land in the task force discussion on the Nurses Association claim with respect to safe staffing levels. So, as I mentioned, we've and I think as the Minister said this morning, we've pretty much got to the point where most of what the safe staffing level ratios will be in the areas of initial rollout. Those things are kind of in agreement between us and the association through the task force. The things that we're still working on are the other principles that go with implementation, and they typically relate to things like how do you approach the rounding of numbers, how do you deal with the association's claim that talks about the need for supernumerary positions, in charge positions, educator positions, as well as the ratio itself. So those are the areas where we're still in discussions, and because they're quite complex discussions, we have not collectively turned our mind significantly to MPS and Level D yet. We have provided for the association quite a lot of data about those facilities, but the reason why they probably need their own specific period of discussion is that they vary quite a lot from the smallest to the largest in that category, and you've really got to reflect on how we come up with implementation principles that deal with that variability and diversity in those facilities.
Okay. I'm moving to a completely different topic now. How much is the single digital patient record project costing to deliver?
If you could just give us a moment, we'll see if we've got that to hand.
While they're doing that, I've just been provided some information. So those additional Mercedes-Benz Sprinters, the all-wheel drives, will be in the country mid-2024 from Germany, and there'll be a 3-month fit-out, so they should be in place September 2024.
Thank you. That was a very quick turnaround for that question on those.
Yeah, I don't have the full figure to hand, Chair. We can take that on notice.
Thank you. What kind of experience does the selected IT provider Epic Systems have of developing a single digital patient record of this project scale previously?
Look, our understanding is that it has a substantial history with delivering services of this size at scale. So the team were able to understand the work that they've done, for example, in the US with Kaiser Permanente and so on, which is a very, very large health service, as you would know, in the US. And the lessons that have been learnt, even from smaller rollouts, are being taken into consideration in terms of the rollout of the SDPR. This will be a huge change for the New South Wales health system that will enable our clinicians to see patient information that they couldn't previously see. So, for example, if you were a patient at Sydney Eye Hospital, which is nearby with us today, but tomorrow you were at Royal Prince Alfred, the clinicians can't currently see between the electronic medical records between the districts. The SDPR will correct that. We anticipate as well that as a consequence of that, it'll improve patient safety, but is also for patient experience. They're continually having to repeat stories in terms of their medical history, their medications, what diagnostic tests they've had, and so on. Will be addressed by this system as well as many other things. And excitingly, there is also opportunity within the SDPR for it to be able to have, for the patient themselves to be able to hold their own information that they can then share with their primary care provider, which I think will be a major improvement for us in our system in the fullness of time because of those issues, as I'm sure you're well aware, with discharge summaries and the like. So we're very excited about this. But Deb, did you have anything else to add in terms of
I don't
the
think
scale
so.
of it?
Yeah, look, some of those, the functionality that clinicians and patients are going to receive from having this single platform across the state, the Secretary's outlined, and it is a massive transformation for the system. So we're working with literally hundreds of clinicians across the state, so they'll have a lot of input into the EPIC rollout and to some of the configuration and special functions that will be important for their specialty area. So just to reassure the committee that the input of our clinicians, consumers, as well as our non-clinical staff across the system will be actively involved over the coming years. And I'll come back to you with the figure. My apologies.
Yeah, thank you. And I've got a follow-up for you, probably, Ms. Wilcox. An overhaul of this scale can rightly cause anxiety for frontline staff, particularly at the moment when they have so little non-clinical time available. What plans are in place to actually support frontline clinicians through that transition and give them, paid, for example, paid time or training with the new system?
Yeah, we're working through some of that detail with the local health districts currently. You're absolutely right. This is going to be a big impost, but there is a large amount of enthusiasm in the system for it as well. We also have a lot of clinicians already active on networks around the state, such as with the Agency of Clinical Information and the Clinical Excellence Commission, Agency of Clinical Innovation, and we're going to work with those clinicians so that we're not creating additional groups and complicating where we have groups of people and clinical staff giving input into matters. The single digital patient record will become a regular item of discussion on agendas in clinical councils and all the myriad of clinical engagement forums that we have across the state. So we're working through some of the issues around clinician time and also very mindful of that, but also to note that, as I said, we've got a lot of forum already where we work with our clinicians on complex issues such as the digital record, and it will become embedded into all of those forums. Thank you.
I've got a related question about the oncology information system. How many cancer centres did eHealth visit across the state as part of that consultation process?
I have to take that on notice, Chair.
Okay.
Yeah.
Thank you very much. I should have kept all of my questions to do with inquiries together. I'm going back to the rural health inquiry, which heard evidence about reasons that were given for wards or theatres to be unused, and at the time of the inquiry the Minister said it was unacceptable to have unused operating theatres when there are people waiting for life-changing surgery, and I agree. Can you provide us with an update on hospitals that were raised in that inquiry with unused wards, both due to infrastructure failings or staff shortages, that have any of those been resolved since the inquiry?
Yeah, we would have to take that on notice and go through the specific wards referenced if we had access to the evidence that wasn't confidential. So I'm happy to chase that up.
Thank you. I understand that there's considerable pressure on local facilities in the Riverina, particularly Leeton and Deniliquin, both due to staff shortages and an ageing population. Have you considered repurposing any of the decommissioned spaces near those hospitals into consulting rooms, allied health, wraparound services and the like?
Yeah, I think the districts across all of New South Wales have considered multiple options to be able to provide any sort of collaborative service with primary care in the town. With regards to Leeton and Deniliquin specifically, I'd have to chase that up with Murrumbidgee Local Health District, but we have examples of that already in Murrumbidgee Local Health District where they've either repurposed and have all collaborated with primary health care in order to offer those spaces. Finley is a really good example of where that happens currently, but I'm quite happy to take that up with Murrumbidgee to see if that's been explored.
Thank you. While we're on Deniliquin, I understand that Edward River Council had a meeting with New South Wales Ambulance about concerns of the airport's capacity to land patient transport at Deniliquin Airport. It's my understanding, please correct me if this is wrong, that there's a mixed fleet of King Air B350s and B200 fixed-wing aircrafts, but only the B350s can land on the main runway. There are upgrades currently underway at that airport, but I understand that there isn't any work planned to extend that shorter runway. Is that something that could be considered by New South Wales or New South Wales Ambulance?
Yeah, the detail I'm going to be shy on. What I can confidently say is I have read a brief that says there are contingency plans in place. So there's workarounds that they've already got in place, and it is to do with the mix of the aircraft, the different types that we use, and other runways. And I think there's something to do with parallel strip as well. So even if the main works are going on at the airstrip, they have an ability to use the shorter runway or something like that. But I can confidently say that there are plans in place, and we can provide more detail.
Yeah, thank you. I wasn't so much after while the works are underway. It was more, can this opportunity actually be used to expand capacity at Deniliquin Airport to be able to then land both types of aircraft longer term?
Oh, sorry. When there aren't works going, there's no problem with the B350 landing there at all.
Thank you. Thanks, everyone. I'm not going to open a whole new can of worms with 3.5 minutes to go. You gave me your 40 seconds. Would you like my 3 minutes?
No, look, can I just quickly be indulged about the ETR trial? Is it just a smashing success? You don't have to, because I know you guys want to go and everything, but I just love that everyone's talking about it and everything. I know you're very dedicated. But is there some really good news, Dr. Chan?
Look, it's been a very effective rollout. I'm just trying to find my details. I'm sure I've got the numbers, but we can certainly. I know. I can. Sorry, I'm just. Anyway,
just anecdotally, I'm happy with. You don't even have to do it on notice. I'm just so interested because it was obviously my.
There certainly has been a reasonably good uptake, and as you know, we've rolled out the oral contraceptive pill trial as well. So we'd be happy to give you the updated numbers. They do change daily.
Look,
but
if it's not too much trouble, I'm just
generally it's going well. We're finding that patients are finding it acceptable. We're waiting, obviously that'll take some time for the robust evaluation, but at the moment we're having a number of people treated, and we haven't been alerted to any sentinel events associated with it. So from a safety and quality perspective, but continue to engage with the researchers.
Okay, fantastic. I might ask the Minister if he'll provide the evaluation, but will that be public or will that be?
So yes, it's as you're aware, we tendered out for a provider. The University of Newcastle was successful, but it was really a consortium where there's University of Sydney, the George Institute, UTS. So there's a large consortium. Charles Sturt, I'm probably going to forget one of them, but large consortium, and that evaluation will be, I'm sure, publicly available once government's had an opportunity to consider the implications of the findings.
Oh, that's great. Thank you for that. That was just every time I walk past and I see a pharmacy and they're advertising, and I go and I talk to them because I can't help myself. And they always are so positive about it, the pharmacists, and they introduced me to a patient one day in Tamworth, and they said what a huge difference it had made. So well done. It was not easy to roll out, and it's just terrific to see it happening. Makes me very happy. I'm done.
Thanks.
Thank you.
Are there questions from the government? Wonderful. We can all have an early mark. Thank you all very much for the time that you've all taken to answer our questions today.
How did it